Dr. Maria, full screen video.
Yeah, this is the control from your side, correct?
Okay, thank you.
دكتور حاتم صباح الخير.
He's not speaking.
I want to drink the coffee without anybody hearing me and watching me. Yeah, mute also. Is muted now? Sure. Yeah, the video, the sound.
صباح الخير دكتور سهيل.
Anybody with us or only you and me?
صباح الخير أهلا دكتور سهيل.
Dr. Salman, is anybody with us or only you and me talking now?
Yeah, we are only two talking, but we have
Oh.
almost 30.
من هنا الصوت
هو عادي دكتور على شيء.
عالي يعني
حاصل على شيء.
بس
Ahmed, check the sound from your side regarding Dr. Suhail and Dr. Hatem. There is في صدى في الصوت شوي.
تشارجر واصل.
مكاني؟
تسلم مدام.
الو الو شو اسمها؟ بس خلينا نشوفها عمود يشوفها. شنو اسمها؟ بس قول اسمها بس بتذكرها. صباح الخير دكتور سلام.
صباح النور والسرور والعافية.
اهلا دكتور سلام، حياك الله.
صباح الخير بروفيسور محمود. صباح الخير يا بيه. ازيك يا دكتور حاتم؟
صباح الخير محمود بيه. صباح الخير دكتور سلام.
صباح النور، صباح الفل.
صباح الفل، ألف مبروك. ألف مبروك على الجميع.
الله يبارك في عمرك، الله يحفظك يا دكتور سامي.
الله يكرمك. مبروك الدكتور حاتم، حاجة شغل بقى، حاجة يعني ما شاء الله.
ربنا يخليك لينا يا دكتور سامي.
ربنا يبارك لك بالتوفيق إن شاء الله.
ان شاء الله دكتور يا رب.
أنا
طول
هعمل
عمره
ميوت
متميز
بقى يعني
حاتم.
عشان ما زهقوش يعني.
علي الصوت عندك، علي الصوت عندك يا سامي.
نعم.
علي الصوت عندك.
أقفل الصوت عندي.
علي.
أعلي الصوت عندي كده كويس. هديني لبست النضارة يمكن الصوت يعلى.
Can be better. Can be better.
جهد تشكر عليه، حاجة
كده كويس.
مرتبة.
بوجودكم دكتور، بجهودكم معنا.
ألو، حياكم الله. ايش الآن الوضع التدريب؟
Good morning, everybody. صباح الخير.
صباح الخير. أهلا وسهلا.
صباح الخير يا فندم.
صباح الخير جميعا. Good morning, Mr. Rohit.
صباح الخير.
مرحبا.
ازاي ارجع زيهم كده ولا خلينا انا في السكرين؟
I am ready when you are.
Yes, Doctor. 2 minutes we will start sharp at 11:10.
إن شاء الله.
بدك تشيل.
لا احسن يعني ازاي ارجع ابقى سمول كده.
لا هي لأنها انت فاضي.
صباح الخير.
صباح النور.
حتضلك هلا في السكرين عندك، عرفت دكتور؟
Can I please ask all speakers to mute themselves now?
لا معايا في الباب.
Can you please all mute yourself? There all, please, can you mute yourself?
كل فشيتا أوروبي.
Okay.
Where is doctor? Where is Dr. Salman? Who's playing?
Dr. Ilyas, can you stop sharing now your slide, please? بسم الله الرحمن الرحيم. سعادة الدكتورة مريم جلامة الرئيس التنفيذي للهيئة الوطنية لتنظيم المهن والخدمات الصحية الموقرة، السيد روهيت المدير التنفيذي للمستشفى الملكي للنساء والأطفال المحترم، الدكتور استشاري أمراض النساء والتوليد والعقم الدكتور حاتم شوقي رئيس المؤتمر، الدكتور استشاري طب الأطفال وأمراض الجهاز الهضمي الدكتور سهيل شبيب نائب رئيس المؤتمر، السيدات والسادة المتحدثين والمشاركين المحترمين، السلام عليكم ورحمة الله وبركاته. في البدء أود أن أتقدم بالشكر والامتنان إلى جميع طواقم الفريق الوطني الطبي وإلى كافة الكوادر الطبية والتمريضية في مختلف أنحاء العالم والتي تحمل بكل جهد وتفاني في مواجهة جائحة فيروس كورونا، ونؤكد لهم بأننا جميعا نثمن هذا الدور الذي يقومون به، ونحمل لهم عظيم الامتنان والتقدير لجهودهم الكبيرة، وكلنا أمل في انتهاء هذه الجائحة قريبا وعودة الحياة إلى طبيعتها. ينعقد اليوم تحت رعاية كريمة من لدن سعادة الدكتورة مريم جلامة الرئيس التنفيذي للهيئة الوطنية لتنظيم المهن والخدمات الصحية الموقرة مؤتمر صحة الأم والطفل في نسخته الأولى، وتحت شعار بداية واعدة لمستقبل مثمر بصيغته الافتراضية ومن على منصة زوم بسبب الظرف العالمي الذي سببته جائحة فيروس كورونا وما فرضته من حظر للسفر والتجمعات على مستوى العالم، وسعيا منا في استمرار عقد المؤتمرات العلمية والتواصل. يعقد مؤتمرنا اليوم بعد التوكل على الله، وكلنا أمل في انتهاء هذا الوباء في القريب العاجل، ليتسنى لنا مرة أخرى التشرف بحضوركم في مملكة البحرين الغالية والتجمع سويا للتباحث في مجال العلم والتطورات في الطب. كلمة راعي المؤتمر سعادة الدكتورة مريم جلامة الرئيس التنفيذي للهيئة الوطنية لتنظيم المهن والخدمات الصحية الموقرة، فتتفضل مشكور.
شكرا لك. بسم الله الرحمن الرحيم. Mr. Rohit, the director of the Royal Hospital for Women and Children, دكتور حاتم شوقي رئيس المؤتمر، الأطباء أعضاء اللجان العلمية والتنظيمية للمؤتمر، السيدات والسادة المتحدثين من داخل وخارج مملكة البحرين، الحضور الكرام، السلام عليكم ورحمة الله وبركاته. يسرني أن أرحب بكم في افتتاح النسخة الأولى لمؤتمر صحة الأم والطفل، والذي ينعقد في ظروف استثنائية عالمية بسبب وباء جائحة فيروس كورونا. ويسعدني أتحدث أمام هذا الجمع الكريم من الأطباء والباحثين والخبراء والمستمعون للتباحث والتداول في أحدث المستجدات فيما يتعلق بصحة الأم والطفل، خصوصاً النساء في سن الإنجاب وما يتعرضن له خلال فترة الحمل والولادة. طبعاً يعقد مؤتمرنا هذا في ظل ظروف صحية استثنائية، ولكن بشيء يعني مهم جدا ان احنا نسلط الضوء على اهميه الرعايه الصحيه ودور الكوادر الطبيه والعلماء والباحثين في التصدي للجائحه العالميه. لقد اصبح واضحا تاثير وخطوره هذه النوع من الامراض على صحه الفرد والمجتمع وتعريض حياه الاشخاص للخطر، خصوصا خلال فتره الحمل. لذلك يتحتم على الكوادر الطبية والباحثين الاهتمام والتركيز لإيجاد حلول علمية وطبية سريعة لمساعدة النساء في إكمال فترة الحمل بسلام وإتمام الولادة بأمان وتقديم الرعاية الكافية خلال هذه المرحلة. كما تعلمون تسعى مملكة البحرين دائما لتكون سباقة في توفير الرعاية الصحية والخدمات الطبية المتطورة والحديثة، ويظهر هذا جليا في القرارات الحكيمة التي يأمر بها سيدي صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المفدى حفظه الله ورعاه، وبالمتابعة الحثيثة لتنفيذ هذه القرارات من قبل سيدي صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء الموقر حفظه الله ورعاه، لتكون صحة الفرد والمجتمع على رأس أولويات قيادتنا الحكيمة وحكومتنا الرشيدة. وما تحقق من إنجازات في التصدي لوباء جائحة كورونا خير مثال يحتذى به، حيث تم العمل وفق خارطة طريق أعدتها مملكتنا الغالية، وحرص الفريق الطبي على تنفيذ توجيهات وتوصيات صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء رئيس اللجنة التنسيقية في حكومة مملكة البحرين. طبعا منظمة الصحة العالمية اعتبرت الجائحة والتي أصابت أكثر من 160 مليون شخص على مستوى العالم هي أسوأ حالة طوارئ صحية عالمية واجهتها المنظمة والعالم في العصر الحديث. طبعا هذا تطلب القيام بإجراءات جدية وغير مسبوقة أخذتها مملكة البحرين، ومنها كان طبعا تأسيس الفريق الطبي والفريق الوطني، وحتى نساعد جميعا الكوادر في وزارة الصحة والجهات الحكومية الأخرى. وهذا في هذا المقام لا يسعني إلا نتوجه بالشكر للقطاع الصحي الخاص اللي قدم كل الدعم للجهود الحكومية من استعداده لقبول الحالات وتقديم الدعم سواء كانت لحالات فحوصات الكورونا أو غيرها. طبعا بالإضافة إلى نجاح هذه الخطة كانت طبعا بإشراك عدد كبير من الوزارات والهيئات وأيضا المجتمع المدني، كل التزم بمسؤوليته حسب موقعه. طبعا ان احنا كون نعقد مؤتمر في ظل هذه الظروف يشكل تحدي، ولكن لابد من الحياه من ان تستمر، ولابد من الاطباء ان يستمرون في تقديم الخدمات للمرضى، وبالتالي نحتاج مثل هذه المؤتمرات لخلق مناخ صحي واعلامي حتى نبث الاطمئنان للمواطنين والمجتمع، وايضا تكريس كل خدماتنا ويعني دعمكم ايضا لمقترحات رفع مقترحات بشأن مواجهة هذه التحديات. في الختام أتقدم بجزيل الشكر إلى القائمين على تنظيم هذا المؤتمر، أخص بالشكر لجان المؤتمر العلمية والتنظيمية والجهات المشاركة والداعمة لتنظيم المؤتمر، إلى جميع المحاضرين والمشاركين، وأعرب لكم عن تمنياتي بأن يحقق هذا المؤتمر الهام الأهداف المرجوة التي سوف يعقد من أجلها، وأتمنى لكم التوفيق والنجاح في خدمتنا لهذا البلد العزيز وأهله الكرام. السلام عليكم ورحمة الله وبركاته. شكرا لكم. Thank you very much.
عليكم السلام. شكرا جزيلا دكتورة. تعتبر مملكة البحرين رائدة في مجال الطب والرعاية الصحية، وتسعى دائما من خلال المجلس الأعلى للصحة ووزارة الصحة والهيئة الوطنية لتنظيم المهن والخدمات الصحية على تطوير الكفاءات الطبية والتمريضية. كما هو يعتبر المستشفى الملكي لأمراض النساء والأطفال من المستشفيات الحديثة التي افتتحت مؤخرا لتقديم خدمات نوعية ومواصفات قياسية ذات جودة عالية وفريق طبي متميز وتمريضي من أجل توفير أفضل سبل الراحة والأمان للمريض. يتفضل الآن السيد روهيت المدير التنفيذي للمستشفى الملكي للنساء والأطفال بإلقاء كلمة مشكورا، وسيعقبها عرض توضيحي قصير عن أهم الخدمات الصحية المقدمة في المستشفى الملكي تقدمها السيدة دلال مديرة التسويق والتطوير في المستشفى الملكي للنساء والأطفال. Dear Mr. Rohit, can you present your...
Thank you. Thank you, Dr. Salman. Good morning, everyone, all the doctors. Thank you, Dr. Mariam, for giving us this opportunity and for giving us your time, especially from your busy schedule that you presently are going through. I would also like to thank the entire organizing committee, Dr. Hatim, Dr. Sohail, Dr. Mohammed Salman, Dr. Amin, and Mr. Ahmed, who have put their day and night excellent efforts in bringing us all to this platform. And also I would like to thank all the speakers and the participants for taking time out from their busy schedule and making this first Congress on maternal and child health a big success. Again, maternal and child health is a very basic principle of any society and its health infrastructure. And it gives Royal Hospital for Women and Children immense pleasure and honor to organize this event and participate with such an expert and depth of expertise which we can see on this particular platform right now is, I think, not easily matchable at various levels. We have doctors from various parts of the world who have been working on the women health, on the pediatric and neonatal health, and various other super specialties on these platforms. So I would say, I would like to wish best of luck to all the speakers, all the attendees, and hope that we will make it a regular feature in Bahrain to conduct this Congress on Women and Child Health. Thank you. Thank you, everyone.
Good morning, everybody. This is Dalal Abedli, the marketing manager for the Royal Hospital for Women and Children. I would like to give you a short, brief presentation about our hospital. It's my pleasure to be here with all of you today. Allow me to share my screen, please. So the Royal Hospital for Women and Children is a 50-bed premium healthcare provider in the kingdom, and it's the only facility in Bahrain that's dedicated for the treatment for women and children. Since its inception in 2019, it has 30 medical disciplines with world-class medical professionals. The vision and mission and pillars of cares are enabling women and children to live healthy and happy lives. The mission is providing holistic care for women and children through unwavering commitment to patients' well-being by leveraging the latest medical advances. And the pillars of cares are patient safety, clinical outcomes, education training, continuous of care. The hospital has centers of excellence, 5 key specialties: pediatric, obstetric and gynae, laparoscopic and bariatric surgery, cosmetology, and fertilization, with more than 40 consultants and specialists. Pediatric Center of Excellence was launched in March 2021. The services are covered general pediatric and neonatology, gastroenterology, allergy and immunology, orthopedics, cardiology, surgery, and psychiatric. It is operated 24 hours, 7 days a week with well care. Cosmetology and dermatology, we have partnership with doctors from United States, Beverly Hills, and Lebanon. Royal Fertility Center, it is a state-of-art facility that consists of embryology, freezing lab, operating theater, micromanipulator, observation room, and andrology lab and recovery lab. The departments of the hospitals are general surgery, obs and gyn, dental, laparoscopic, gastroenterology, orthopedic, family medicine, dietitian, intensive care unit, IVF, Pediatric Center of Excellence, dermatology and cosmetology and plastic surgery, internal medicine, physiotherapy, laboratory, urgent care, and radiology. The hospital setting is a modern and welcoming area with 2 curved main wings of the hospital adjoining a glass atrium that allows natural light, sunlight to come in. And the area is 10,000 square meters. And a nice, spacious park, which consists of 120 cars, more than 120 cars. The hospital has a couple of new advanced technology machines, such as bone density machine, mammogram machine, high-end ICU, and X-rays. We have 2 royal suites, window atrium, and 3 high-end operations rooms. Some of the examples of the community and corporate activity that the hospital did. Based on 269 reviews in a very short period of time, we were able to achieve 4.9 Google review rating, not only competing, but actually getting ahead of hospitals that has been in the market since very long time. Also, in a short period of time, we were able to get 18,300 followers on Instagram by educating and posting and keeping engaging with our followers. Thank you so much for your time, and I hope you have a good day.
Thank you. يسرني الآن دعوة الدكتور حاتم شوقي رئيس المؤتمر لإلقاء كلمته مشكورا. دكتور حاتم, please, the mic for you.
صباح الخير. Good morning, everyone. On behalf of all MAC conference members and on behalf of myself, I would like to thank Her Excellence Dr. Mariam Jalahma, CEO of the National Health Regulation Authority, who gave us the chance to organize this conference under her patronage. MAC conference is considered to be the first conference in Bahrain gathering most of the updates of obs and gynae and infertility, together with pediatrics, with most of its subspecialties under the umbrella of the Royal Hospital for Women and Children. Our eminent speakers, dear colleagues, respectable attendees, we are here to create the first milestone for a Congress which is born to live and develop. MAC Congress will be held, after God blessings, annually, almost at the same time of the year. Looking forward to always share with us the recent update in our fields. The Royal Hospital for Women and Children, together with the Scientific Committee, proposed many fruitful ideas to upgrade and develop continuously the KPIs of that Congress, where our target to be a certified international Congress within few years, where with different themes, where the theme of this year is a hopeful start for a fruitful future. Wishing you all the best to enjoy and get the most benefit of the scientific sessions of this Congress. Thank you very much.
Thank you, Dr. Hatem, and I would like now to call Dr. Suhail Shibib, the co-chairman, to present his talk. Dr. Suhail Shibib, please.
Good morning, all. Good morning, all of you. It's a pleasure to welcome the participants today for this 3-day Congress, the first Maternal and Child Health Congress. We have close to 450 participants, and I welcome all our participants. And I welcome the eminent speakers who have come to share their experience and knowledge from Bahrain, United Arab Emirates, Egypt, Lebanon, Iraq, Canada, and USA. This makes the Congress truly international. The Congress is sponsored by the Royal Hospital for Women and Children, and it's organized by Education Plus Company, broadcasted by Zoom, and patronized by the National Health Regulatory Authority, NAHRA. One of NAHRA's main objectives is to provide excellent infant and child care in health and in disease. And as a chairman of the pediatric part of this Congress, I ensured to organize the pediatric part to meet this vision by offering you a variety of subjects to cover both the infant and child care in health and in disease. And I hope this Congress will be of benefit to you. Before I end my speech, I would like to thank all the participants. I thank and acknowledge the support team and the organizers, the Education Plus company, and the Royal Hospital for Women and Children personnel who have worked so hard to make this Congress a true success. I thank the eminent speakers. And finally, a big salute to our colleagues in the front lines fighting the COVID-19, the doctors, nurses, paramedics, technicians, researchers, policemen, firemen, and all other I didn't mention. I will be looking forward for the second Maternity and Child Health Congress next year, inshallah, at one of the resorts, so we can meet and talk and enjoy together a gala dinner as in the old good days. I hope we don't have the COVID anymore. And thank you very much to all.
Thanks, Dr. Suhail. And now I would like to ask all speakers to open their camera to take the virtual group photo, please. Please, all speakers to open their camera. Yeah. Please, another speaker to open their all. Please open your camera. Still, we are waiting. Dr. Marcella, Professor Mahmoud, Dr. Saida. Dr. Hassan, Dr. Maimuna. Dr. Ilyas, Dr. Marcella, Professor Mahmoud, Dr. Saida, Dr. Dalal. Please open your camera. Dr. Hassan, Dr. Maimuna. Please, if you are hearing me, open your camera to take the virtual group photo. Dr. Saida, Dr. Maimuna, Dr. Hassan. If you hear me, please open your camera to take the. Okay, with my count, we will take the photo on 3. 1, 2, 3. Our team will take care for the photo. Just please, yeah, that's all. Thank you. نتقدم بالشكر الجزيل إلى سعادة الدكتورة مريم أحمد to take her time. I know it's very busy time for her, but thanks for presenting with us today. And now we will take a break for 5 minutes and we will start the scientific session at 12 sharp. Thank you all.
Thank you. Wish you all the best. Thank you very much.
Thank you.
Thank you, Mr. Rohit. Thank you, Mr. Amin. Thank you very much.
Thank you, doctor.
توفيق يا دكتور محمد، موفق ان شاء الله.
الله يخليك استاذ محمد، شكرا.
الله يخليك.
Good afternoon.
You can start.
Good afternoon. Everybody is hearing me?
Yes, we are hearing you clearly, Doctor.
Okay. We'll start our first session. I would like to give you a brief resume about the whole conference. I know that you all have the program, but we'll have the conference for 3 days, Thursday, Friday, and Saturday. It will start now, and it will be closed, inshallah, on Saturday by 7 o'clock, 7:30. The first day, which is today, the session will be gynecology, and followed by the pediatrics. Tomorrow, Friday, we will start by the pediatric subspecialties, and then we will have the infertility session. And on Saturday, we will start the third session, which will be obstetrics, and will be ended by the pediatric neonatology session. For each session, there will be a chairman and a co-chair who will regulate and moderate the whole session. The speakers they will have about 30 minutes for their talk, 20 minutes to address their presentation, and 10 minutes for discussion from the panel or from any of the attendees. Today, I will be the chairman of this session, and I have with me one of my dearest friends, Dr. Khulud al-Darazi, to be the co-chair. We will share together the panel, and we will address the speakers alternating. We have 10 lectures with 9 speakers, as Dr. Khulud will give us at the end 2 lectures consequently after each other.
With her.
So we will start now our first presentation with Dr. Ilyas Abu Khalil from Clemenceau Medical Center, United Arab Emirates, giving us a presentation of cervical circulage. Dr. Ilyas, please, the floor is yours.
So, on the other hand, so we have seen
thank you for having me. It's a pleasure to be giving a presentation. So today we will be talking. Can someone? I am hearing echoes. Can you mute your screen, please? Someone is not on unmute.
We reached the weekend. The mother is sitting and teaching her since 8 o'clock in the morning until 9 p.m. For God's sake, why?
I can
get angry and I get frustrated.
I'm sorry, I'm hearing someone talking.
Yeah, sorry, Dr. Ilyas. We will manage this one now. Sorry, we will manage now this one.
How many times you have memorized? How many times you have to read this morning? So I feel have not this much fun. See, each is having lots of things. And this is
All right, I guess I will start with the presentation. So we're going to talk about cerclage today, and more specifically, abdominal cerclages. These are basically cerclages that are placed where trans-cervical cerclages or transvaginal cerclages fail. The advantage of a transabdominal cerclage is placement of the suture at the level of the endocervix from the other side of the perineum, and basically from the inside. And that gives you a more stable suture. It decreases the risk of suture migration, and especially when the pregnancy is far along and when the cervix becomes softened and shortens. It does have an absence of foreign body inside the vagina, which makes it less prone to infection. And you can leave the suture for future pregnancies if someone has cervical incompetence. Now, the disadvantage of it is that it's, guys, I'm still hearing someone talking. So the disadvantage of this is it will need two laparoscopy to place them, one for the placement, and the other is basically a C-section to deliver by C-section. Now, the advantage of an abdominal cerclage is it's of a transvaginal cerclage is that it's easy to perform and can be removed close to term. However, the abdominal it has to have a C-section. However, the failure rate of a transvaginal cerclage is around 13%. And when we say failure rate, is people delivering preterm. Now, the indication for a transabdominal cerclage is having two or more failed transvaginal cerclage, and or having an abnormal cervix due to extreme shortening, scarring, or laceration of the cervix. For example, people who have had multiple leaps or multiple cone for cervical dysplasia. Now, the question is, do we want to place this cerclage before or after or early in pregnancy? Do we want to do it laparoscopically or via laparotomy? And what is the role of robotic surgery? So there is no randomized controlled trial comparing whether we do it early in pregnancy or before pregnancy. However, a review of 14 studies, including 678 patients between 19 and 2013, showed that both have the similar pregnancy rate. Now, to evaluate the efficacy of preconceptional versus post-conceptional abdominal cerclages by laparotomy and laparoscopy, this is a study that included, basically, this is a review that included 14 studies of 678 patients. And you had 138 patients in the laparoscopy group and 540 in the open abdominal group. These were the patient characteristics of the different studies, which were done by laparotomy and laparoscopy, and whether they were done before and after conception. The outcomes were fetal survival rate, rate of failed cerclage, and they reported surgical complication. So they didn't find a difference between the rate of third trimester delivery and live birth rate after an abdominal cerclage, whether it was placed laparoscopically or by laparotomy. And the failure rate was basically the same, whether it was placed by open surgery or laparoscopy. They also reported the complications that happened. And most of these complications are related to excessive blood loss happening with the open groups. Now, the laparoscopic cerclage was described in 1998, and many authors prefer to do it before the pregnancy, and it has less morbidity and was very well accepted since then. Now, this is a study that compared laparoscopy versus laparotomy for abdominal cerclages in patients who had cervical incompetence but were not suitable for a transvaginal cerclage. The cohort included the laparoscopy group with 51 patients and the laparotomy group with 18 patients. And these are the patient characteristics. They were almost similar between the both groups when it comes to successful pregnancies, gestation of all pregnancies. These are also the indications why these abdominal cerclages were done, and they were comparable between both groups. Now, the outcomes were not also very different. The outcomes, whether delivery beyond 37 weeks, whether the number of neonates that survived, or the birth weight in grams. Also, The only difference between both is the length of hospital stay, and that's expected because the laparotomy group would stay more in the hospital than the laparoscopy group. Now, recently, we've been doing robotic abdominal cerclages, and this is a retrospective study that included 24 non-pregnant patients who had robotic transabdominal cerclage. And when having the outcomes laid down, you can see that the time is basically is longer in robotic cerclage placement. However, if you break it down to the only consult time, removing the docking and all of it, it is pretty reasonable as a time. And the length, however, the length of stay for the robotic was less than the laparotomy, and the estimated blood loss was pretty much significantly less. So I don't want to stay much on the data. I want to show you two videos of how the technique is done. And this is a surgical video showing the differences between placing a cerclage in someone who's not pregnant as a preemptive measure, or in someone who's already pregnant at beyond up to 12 weeks. And this is basically called the prophylactic cerclage. In this tutorial, we will review the techniques of minimally invasive cerclage, and we will highlight the differences between preconceptional and conceptional cerclage. The technique of a minimally invasive cerclage begins by creating a window in the broad ligament. A bladder flap is then created. The window in the medial leaf of the broad ligament is created medial to the ureter and lateral to the uterine arteries. The uterine artery is skeletonized, and the procedure is repeated contralaterally. A suture is placed medial to the uterine artery at the level of the internal cervical os, and the suture is tied around the cervix. So this is a Merceline tape that is used. It's a pretty stiff suture that will stay there and will last for a long time. Now we will go over some differences between conceptional and preconceptional techniques. In a non-gravid uterus, a uterine manipulator can be used for manipulation, exposure, and better visualization during the procedure. In this 16-week gravid uterus, a sponge on a stick is all that can be used. For this, visualization and access are compromised. In preconceptional cerclages, access to develop broad ligament windows is easier, and development of these windows is with less bleeding. In gravid uterus, access to develop those windows is made harder because of the engorgement of blood vessels, the size of the uterus, and the poor manipulation. In a non-gravid uterus, it's easier to skeletonize the uterine artery with minimal bleeding risk. In a conceptional cerclage, the uterine veins are engorged and are in close proximity to the uterine arteries, which makes skeletonizing them a little bit harder. So you see how thick that uterine artery pedicle is. It's tied posteriorly. In case of fetal demise in future pregnancy, the knot can be removed via posterior culdotomy and avoid unnecessary laparotomy. In a conceptional cerclage, the knot is placed anteriorly due to the bulky uterus and difficult access to the posterior cul-de-sac. Minimally invasive cerclage placement is a technically challenging procedure. When indicated, it should be performed by appropriately trained and experienced surgeons. Okay, that's the first video. In this tutorial, we will review I want to show you the techniques of minimally invasive. I want to show you the other video we have is the last one, is placing this cerclage in someone who had stage 4 endometriosis. We present a case of robotic cerclage in a patient with advanced stage endometriosis. Traditional transvaginal cerclage fail in 13% of women with cervical incompetence. General accepted criteria for choosing transabdominal cerclage includes congenital short cervix or amputated cervix, cervical scarring that would prevent a transvaginal approach, and failure of prior cerclage. We present a case of a 30-year-old female with a history of infertility. She has multiple IVF cycles and cervical incompetence, referred for transabdominal cerclage. She has a history of 3 first trimester losses, 2 mid-trimester losses, and a failed vaginal cerclage. In this case, we use a 12mm umbilical port and 2 ancillary 8mm robotic port and a 5mm assistant port. So the same thing can be done laparoscopically. In this case, the cul-de-sac was noted to be completely obliterated. The preloaded needle is parked safely on the parietal peritoneum. The right ureter is identified transperitoneally. The retroperitoneal space is accessed and the paravesical space is developed. The pararectal space is then opened and the ureter is isolated from surrounding scar tissue. At this point, the right pelvic sidewall anatomy is clearly identified. In a similar fashion, the left-sided retroperitoneal space was dissected. After the lateral margins of the rectum were identified by opening the pararectal spaces, the rectovaginal space was delineated using an EEA sizer. So the EEA sizer is in the rectum, and we are trying to open the rectovaginal space to separate the rectum from the adhesions to the lower uterine segment and the vagina. This is part of restoring anatomy in an endometriosis surgery. And also it is essential for us to place the suture there for the cerclage. So we were not expecting this when we went in. This lady came for previous failed cerclages. And then when we got in, we saw the endometriosis. The vesicouterine peritoneum was dissected transversely and dropped below the level of the lower uterine segment. So dissecting the bladder off of the uterus and the lower segment. A window is created in the right posterior leaf of the broad ligament, 2 centimeters lateral to the cervico-uterine junction and medial to the ureter. The right uterine vessels are exposed and skeletonized. Now another window is opened here. Similarly, the left uterine vessels are isolated and skeletonized. The needle is placed in the lateral isthmus, medial to the uterine vessels, starting on the right, going posterior to anterior. So careful, we should be avoiding the arteries, but being medial to them and lateral to the cervix, right in that isthmus. The procedure is repeated contralaterally with the needle going into the anteroposterior direction. So now the suture is all around the cervix. The tape is pulled snugly against the anterior cervical isthmus. The ends are tied together posteriorly. You can see the anatomic relationship of the tape to the nearby structures. The patient delivered a healthy male infant at 37 weeks by cesarean section. We present a case of... All right, I'm gonna stop sharing my screen. Thank you so much. That was the end of the presentation.
Thank you, Dr. Elias, for your nice presentation. And we will have a chance for only few number of questions so that we will be fixed to our timetable and schedule. First question, please. No questions?
Here, Dr. Hatem, there is one question in the question and answer. The question is...
the question says, from one of the attendees, how many cases of laparoscopic cervical cerclage done at Royal Maternity, and is robot available? I will answer none of them, and we don't have we don't have a robot yet.
Well, let me add to it. The abdominal cerclage can be done laparoscopically. It happened in these videos that we've done them robotically because we have the robot where we practice. However, same procedure can be done exactly laparoscopically. And we have not done them yet at the Royal Hospital because I have not visited yet, but soon if I will be there and we will be able to proceed with them laparoscopically.
Thank you, Dr. Ilyas. We have two more questions. No, it's already answered. So,
there is one question from Dr. Rehab Ismail, Dr. Hatem.
Well, okay. Thank you for the presentation and videos. Just asking, do you agree with practice of applying cerclage in each IVF pregnancy without a clear indication? I mean, just prophylactic? Dr. Ilyas.
There are specific indications to placement of cerclage, and IVF is not one of them. The indications could be related to the history. If you have history of repeated losses due to cervical incompetence, there's also based on examination, and this is where the rescue cerclage comes in. And there is one based on the cervical length in someone who has a history of preterm birth. But none of the indication for cerclages are related to the IVF treatment.
Thank you. We will end the first speaker here so that we will be fixed to our schedule. And if there is any more questions requested to the speaker, so his contacts and email will be available so that you can contact him with any other questions you want. I'll give the floor now to Dr. Khulud Al-Darazi to present the coming speaker.
Dr. Khulud, please unmute yourself before.
Let's be here.
Thank you, Dr. Hatem, for invitation. I'm so pleased to be with you and to co-share the sessions. It's been always a pleasure to be with my older friends. Professor Husni Malas is a consultant and department head of OBGYN at King Hamad University Hospital. He's here today to share with us his experience about the office hysteroscopy. I hope all enjoy it, and I'm sure they will. The floor is yours, Professor Husni.
Yeah, thank you so much, Khulud. Can you hear me?
Yes, we can hear you, Dr. Hassan.
Yeah, I just want to share the screen. Yes.
Close it. Close it. Minimize it.
Yeah.
Minimize it. Yeah. Minimize.
Open the slide. Minimize everything.
Can't do it. I'm just trying to share my screen. Can you see my screen now?
Yes, it is clear.
It's very clear.
Okay, okay. Thank you so much. Bismillah ar-Rahman ar-Rahim. Good afternoon, ladies and gentlemen. It gives me great pleasure to be with you this afternoon to share with you my knowledge about office hysteroscopy and our experience at King Hamad University Hospital. I'd like to extend my sincere thanks to the organizing committee, to Khulud, to my dear friend Hatem for inviting me to give this lecture. Before, it's not working. Yeah, I just want to disclose that I have no conflict of interest with anyone in relation to my presentation. Well, hysteroscopy was first used by Pantaleoni in 1869, and 50 years later, Rubin has used the carbon dioxide to distend the potential space of the uterine cavity. Same year, Goss in 1925 has used fluid to distend the uterine cavity. However, the hysteroscope did not become popular before 1970s, and since that time, there was a gradual improvement of the instrument until we reach what we are doing these days. Office hysteroscopy, some people call it as outpatient hysteroscopy or ambulatory hysteroscopy. It is the visualization of the inside uterus, including the endocervical canal and the uterine cavity, aiming to diagnose different pathologies, take biopsies if needed, and perform treatment. Some argue that the 3D ultrasound scan is very good and can be compared to the office hysteroscopy. However, with the office hysteroscopy, you can see with your own eyes what's happening inside the uterus. You can take a biopsy, you can do minor treatment, which you cannot do with the 3D ultrasound. And for sure, the office hysteroscopy is much superior than the 3D ultrasound. The office one can be done in an outpatient setting. It does not require any hospital admission, particularly around in this area of the COVID-19. It does not require any sedation nor anesthesia. It is acceptable by most of the patient, and it is cost-effective and very time-consuming, time-sparing. The office hysteroscope can be either the rigid type with a diameter of the outer sheath between 2.5 to 5 millimeter, or the flexible hysteroscope that has a rotatory tip that rotates between 120 to 160 degrees. I mean, the advantage of the flexible hysteroscope that it can goes around masses inside the uterine cavity, like the presence of uterine fibroid, where it can go around it either above or below. So this is the advantage mainly of the flexible one. The angle of vision varies between 0 degree, where it gives you a panoramic view of the uterine cavity, or 70 degree that it shows you better without moving the hysteroscope up, down, right, or left. It shows you the different walls of the uterus. This is a view of the flexible hysteroscope, and this is a view of the rigid hysteroscope. Now, the hysteroscope tips need to have a light in order to lighten the inside of the uterine cavity. And this light is usually provided from a light source, usually xenon. And the eyepiece of the hysteroscope is usually connected to a video camera. And this camera is connected to the monitor. I mean, the monitor is important. I remember still, when we first using it back in the UK, I mean, at that stage, we had to put the eyepiece along our eyes. bend our knees, sit between the patient's legs. It was very, very difficult. Nowadays, with the presence of monitor, you can show the patient, you can see yourself more comfortably, you can show your assistant, and you can show your nurses. Now, it is, you know, the uterine cavity is a potential space. That means the wall of the uterus are clapped over each other's. I need a distending media to separate them so that you can visualize the inside of the cavity. And the distension media could be a gas, carbon dioxide, or could be fluid. I mean, the most likely fluid that we use in the office hysteroscopy is the normal saline. I mean, the mannitol, sorbitol, and glycine can be used, you know, mainly with the operative hysteroscope because they do not mix up with blood, and it gives you a better view whenever there is bleeding, which doesn't really happen in cases of office hysteroscopy. And the best medium is the normal saline. The sheath of the hysteroscope can be allowed to insert some instruments, particularly scissors if you want to cut something inside the uterine cavity, a grasping forceps if you want to remove an IUCD, or a biopsy forceps if you want to biopsy the endometrium or a polyp inside. And if there's any evidence of bleeding, you can use the roller ball or the loop electrode. The source of energy that we use is commonly the bipolar one because it's the safest source of energy. There are many indications for the office hysteroscopy, but the most common investigation is to investigate abnormal uterine bleeding either before or after the menopause. We can use it for the evaluation of uterine cavity in cases of recurrent implantation failures, in cases of failed IVF. Some people, they do not say that it is a case of unexplained infertility before having root inside the uterine cavity. Again, we can use it for the evaluation of the uterine cavity in cases of recurrent miscarriages. Can be used for investigation of thickened endometrium, particularly for those women who are on tamoxifen for breast cancer and they have thick endometrium ultrasound scan. Can be used for the investigations of suspected uterine polyps or myomas. A missed IUCD can be easily removed through the office hysteroscopy. And some people, some authorities do use the office hysteroscopy to block the tubal ostia in cases of sterilization, which I think, you know, it's very rarely used these days. There are very, very, very few contraindications for the use of office hysteroscopies, particularly in the presence of active cervical infection or uterine infection, including herpes. Continuing pregnancy, you should not use the hysteroscopy, and people do recommend not use it in cases of known cervical or genital cancer, just in case if you perforate the uterus, you're going to spread the malignancy. Not many investigations are needed before doing the procedure. Simply make sure that the patient is not pregnant by urine pregnancy test. No need for any prophylactic antibiotics before the procedure. And you don't need to catheterize the bladder. You can always ask the patient to go and empty her bladder before the procedure. Of course, with any procedure, there are risks. However, the risks associated with the office hysteroscopy are minute. One of them is the failure. I'm going to show you why it may fail. Or the other thing is the presence of pain, and there is a way around, you know, to stop the pain and make it successful. Many women, or some women, they complain of feeling sick or feeling faint, and that's probably because of the position of the patient, because of the manipulation of the cervix. Little bleeding might happen if you are doing a biopsy or you are taking, removing a polyp. Infection and uterine perforation are extremely, extremely rare. In order for the hysteroscope or the office hysteroscopy be successful, it is important to pick up the right patient for the procedure. And it's very important not to do the procedure when the patient is menstruating or when the patient has abnormal uterine bleeding, because you won't be able to see it properly. And it's very important to select your patient properly, particularly those patients who can stand a little bit of the pain. A patient who comes and tell you, look, you know, I cannot stand any painful periods, you know, I faint during my periods, or when you're examining her, you find that she cannot tolerate the vaginal examination, or having a cervical smear, those patients are not going to really stand the procedure and they're going to be failed. If a patient tells you, look, I had a previous traumatic experience during any sort of surgery or, you know, during coming to the hospital, again, try to avoid such types of patients. If you know that the cervix is narrow, Avoid using the office hysteroscopy because it will not go through the cervical os. It needs dilatation. And you cannot dilate the cervix, without putting the patient to sleep. And if the patient, she does not accept the idea, say, no, I cannot, stand people being around me. I cannot see the instruments. I can't see operation room. Please, I don't want this. This, again, you try to avoid her. All these, if you select your patient properly, that means most likely you're going to have a successful procedure. Therefore, there are certain measures that we have to take into consideration in order to improve our success rate. The most important one is the patient's counseling. I mean, it's very important to explain the patient, during the clinic before coming for the procedure, why we're doing the procedure, how we're going to go to the procedure. When she comes to the operating or to the hysteroscopy room, show her the instrument, tell her that's what we're going to do for you. You're going to have a little bit of pain. It's going to stay for such time. We have a procedure that we can give you to relieve the pain. All this, will alleviate her fears. Now, when you are doing the procedure, always tell the patient what you're doing. Look, now I'm examining you. Now I'm using the scope. Now I'm looking inside your cervix. Now looking inside your uterus. Have a look to see what we are doing. And when you are keep on talking to the patient, that will relieve her pain and anxiety. And definitely you're going to have a successful procedure. So again, pick up the right patient, and that will improve your success rate. If analgesia is needed, you can use it. I'm going to tell you what we are using in King Hamad. And try always to make a brief procedure. Don't pick up a difficult case. If you find that there's a large polyp, or you will find a small myoma that you need to remove, or you find that the cervix is closed, those patients cannot tolerate the procedure, and definitely you're going to fail. So try always to use it for minor removal of small polyps or for diagnostic hysteroscopies. That is, the cervix, is very painful, and it might put the patient into shock, so avoid it. Avoid using the tenaculum. You don't need to use a tenaculum at all. And in many scenarios, you don't need even to use a vaginal speculum. And try to always use the narrow scope available. I mean, the one that we are using here, the alpha scope, is 2.5 millimeter. It is very narrow, and it can be introduced through small surfaces. And distending the uterine cavity with saline produces the least amount of pain. Now, I'm going to share with you now our experience at King Hamad University Hospital with the office hysteroscopy. We looked into those patients that, we want to do for the office hysteroscopy between the years 2018 and 2020, aiming to assess to see whether our population, are going to accept the procedure or not. During that period of time, we have performed about 101 office hysteroscopies. We have done about 163 hysteroscopies under general anesthesia, and the office hysteroscopy accounted for about nearly 40% of our procedures. The setting is always a small room in our outpatient department, and as you can see it now here, we have the chair for the patient. It has its own monitor. You can see the monitor here for the patient. This is our monitor, and this is the pump. This is the saline. This is the cable. This is the tray where we put the instruments. This is the source of energy, the bipolar energy. This is, the other monitor if needed. So this is the office, the hysteroscopy we do. It is in the clinic. The patient can come like any other patient coming for examination. This is the tray where we use the hysteroscope. I mean, this is the alpha scope we're using. This is the cable. This is the camera. If you want to use the speculum, it's available, and so on. And this is the stores. Again, hysteroscope. It is a bit wider than the alpha scope, so it's a bit probably needs to have a wider surface. And we have done it on patients mainly suffering from abnormal uterine bleeding. In about 50% of those cases, they had abnormal uterine bleeding before the menopause. 13% of those patients, they have postmenopausal bleeding. 13 patients, we have removed their missed intrauterine contraceptive device. 12 cases, we were investigating them for the infertility, particularly for recurrent implantation failure. 7 patients, they were taking tamoxifen with breast cancer, and they had thickened endometrium, so we investigated this endometrium, and 7 cases had uterine polyps, so a total of 101 patients. When we looked whether those patients have tolerated the procedure or not, as you can see from the numbers, the majority, about 94% of the patient, they tolerated the procedure without any sort of analgesia completely. Only 4 patients, count again, about 4% of the patients, they required analgesia. Only 3 patients, they found the procedure intolerable and we couldn't proceed with the procedure. So the ability to tolerate the pain is only about 3%. For those patients who required analgesia, we use Interlux, nitrous oxide and oxygen, which is available in every obstetric clinic. We all know it's called the laughing gas, was first discovered by the English scientist Priestley in 1973. It's colorless, it is safe, it's non-flammable, taken by inhalation, it stays for about 5 minutes. The patient usually takes 1 or 2 puffs, and if you feel all right, you can finish the procedure in no time. And I think the availability of it in every obstetric unit makes it very handy. We looked how many patients had previous surgery before the procedure. The majority of them, they had previous cesarean section. Some of them had dilatation of the cervix, either because of DNC or before evacuation of the uterus. 5 of them had previous hysteroscopies, and only 1 had previous problem with her cervix. That means majority of them, the cervix was not totally closed. We had 10 cases, about 10% of patients, they have failed procedure. 3 of them, which I mentioned beforehand, they could not tolerate the procedure. Unfortunately, 5 of them, they had narrow cervix. And with those cases, shouldn't have been brought over for the office hysteroscopy because we knew that they had narrow cervix, so they shouldn't have been brought over because this scope will not get through. 1 of them has big cervical mass. Again, we could have identified this, in the clinic before bringing her for the office hysteroscopy, and that with a large enterocele, again, they couldn't see the cervix because they're very large enterocele. So these 7 cases, we could have removed them from the failure by identifying them in advance in the clinic. Our failure rate will go down only to 3%. Those patients who could not tolerate the procedure, 1 of them was at the age of 42, we investigated her for abnormal uterine bleeding. She had previous cesarean section, however, also she had previous miscarriage, so her cervix was dilated a little bit. 40 patient, another patient at the age of 40, she had only 1 miscarriage before we were investigating her for the infertility. And 1 76-year-old, she had thickened endometrium because of tamoxifen, but she had 2 normal deliveries. Again, she could not tolerate the procedure. So, those patients who could not tolerate the procedure were very, very, very few of them. I didn't put this slide here. The age of the patient ranged between 24 to 78 years old. So there was a different age groups. The patient's parity, the majority of them, they were multiparous, around 75%. They were multiparous. 14%, they were nulliparous. That means their cervix was completely, totally closed. 11 were gram-multiparous. The complication that we faced, 1 patient, she had abdominal pain and dizziness, which is a very minor complication. 1 patient had a bit of uterine bleeding after the biopsy over the polyps, again, a very tiny complication. So the rate of complication, only 2 patients out of all those patients, they had these minor complications. As a summary, we found that, the office hysteroscopy in our hospital was successful in about 90% of cases. And if we have taken care to include only those suitable patients, the success rate would have gone up to 97% of cases. And it works at all age group, as I mentioned before, between 24 to 78 years old. And it is different parities. It doesn't matter whether the patient is nulliparous or multiparous. And it is tolerable by majority of the patients. And analgesia, if needed, it is available and very safe. You can use it. And the complications were extremely little, 2 minor complications. The take-home message is office hysteroscopy should be available in every gynecology clinic, and we should teach all our junior staff about using the office hysteroscopy. And because it is very, very common, now they are producing the disposable hysteroscope, where you can remove this, throw it in the bin, and then you can use it even in private setting. Thank you so much.
Thank you so much, Professor Hosni, for this wonderful and nice presentation. It just encourage everybody that really, many cases really, they don't need really to have undergo general anesthesia to have hysteroscopy. Unfortunately, this is still the case, I think, with many gynecologists. We have a question here from Dr. Hafsa. She's the first question, during your study, you did not indicate when exactly you do the hysteroscopy, in what day of the menstrual cycle?
It doesn't matter.
It doesn't matter. So
it doesn't matter, though best time is after a period where the cervix is slightly open, but because this hysteroscope that we are using is pretty narrow. So it is really accommodated by any services. We do it at any time except when she's menstruating. And again, the point that that you have raised, Khurud, I think, regarding the issue of it does not require admission and anesthesia, is very important around this time where with COVID. With this COVID-19 era, where every patient coming to the hospital, she needs to be assessed, she needs to have her PCR, she needs to be, it's not easy now to admit patient for surgery. Like for us, stop all our elective surgery, but our office hysteroscopy is still going on. And we found that, the bulk of our patient was mainly during the late 2020 and the beginning of 2021.
Right. Another question, is there any risk of dissemination of the malignant cell with the use of the office hysteroscopy in suspicious endometrium?
Yeah, some people, they say that, if there are malignant cells and you push the fluid inside the scope, it might go through the tubes, or if you perforate the uterus, may. So this is why, as I said, probably it is not very much recommended in the presence of cervical cancer or endometrial cancer if it is confirmed. But of course, if you're doing for investigation, for abnormal bleeding, you find the cancer, you take a biopsy, that's fine.
What about the endometrium? So if you're suspecting any endometrium, especially with AUB, they might have endometrial, pathology. So yeah. Will you do as well office hysteroscopy?
Well, if it is diagnosed endometrial cancer, we don't do it. But if you don't know it is a endometrial cancer, if hysteroscopy is one of the reasons why you have to do it. You can go inside. The amount of pressure we're using is very little. To go inside uterine cavity, abdominal cavity, it's very, very little risk. But yes, we do it in any abnormal bleeding, even with postmenopausal bleeding.
Great. I can see no more questions, and thank you very much again for your presentation.
Thank you so much.
Thank you, Dr. Hosni. Thank you, Thank you, Professor Hosni, for your nice presentation. It's really very interesting and encouraging also. And I would like to go for the coming speaker, which is one of our dearest colleagues and friends, Dr. Huda Juferi, consultant of Ops and Gynae in Ibn Nafis Hospital. And she will present to us a topic under the title of Pre-Malignant Condition in Gynecology and Management of Abnormal Pap Smear. Dr. Huda, the floor is yours.
I think it's not my turn, it's Dr. Anastasia.
Yes.
By mistake, I will be following my presentation.
I'm sorry. There was some confusion with the list in front of me. It's not my fault, wallahi.
It's fine.
So we will go for Dr. Anastasia, which is one of our colleagues in the Royal Hospital for Women and Children. And she is a consultant of orthopedic surgery, which will present to us how to investigate, diagnose, and treat female athlete triad. Dr. Anastasia, the floor is yours. And excuse me and my apology for the inconvenience.
Of course. Good afternoon, everyone. It's a great honor to be here today. So I will be talking to you about how to investigate, diagnose, and manage the female athlete triad. The female athlete triad is a medical condition typically observed in active females. It includes 3 basic elements: low energy threshold, which could be irrelevant to eating habits, irregularity of menses, and decreased bone density. It is essential to realize that an athlete does not need to have all 3 components of the female athlete triad at the same time to be diagnosed with a condition. The International Olympic Committee suggested changing the name of the diagnosis to the more accurate relative energy deficiency in sport. The effects of the above-mentioned disorders may not be completely reversible, so precautionary measures, prompt and accurate diagnosis, and adequate intervention are essential. All female athletes might suffer from the triad. Hence, all active females should be evaluated for signs of the triad, and further intervention is warranted if one or more components are established. Why is the triad harmful to an athlete's health? The immediate effects: increased musculoskeletal injuries, poor athletic performance due to low energy availability, and stress fractures. And the long-term effects: infertility, if energy availability and menses do not normalize, lifelong eating disorders, low bone mineral density and osteoporosis, and psychiatric disorders. Based on current literature, certain sports, such as ballet or gymnastics, and sports with weight divisions, have a higher percentage of female athletes suffering from the condition. Investigation. The team physician is the first to screen the athletes for component of the disorder at frequent intervals. The elements that should be assessed for the triad include history of menstrual irregularities or amenorrhea, history of stress fractures, history of eating or weight problems, negative thoughts, anxiety or depression, a history of dieting, personality traits such as perfectionism or pressure to lose weight or frequent weight cycling, early start of sport-specific training, overtraining, and repetitive and non-healing injuries. Questionnaires given to the female athletes should include inquiries about their current weight and expectations, as well as period pattern and history, dietary concerns and restrictions, and a bone fracture history. With the above information, the physician should be able to identify athletes at risk of developing the disease or athletes already suffering from the female athlete triad. A study looked into grouping the athletes according to their risk for stress fractures. They used a specific questionnaire, and they concluded that high-risk athletes were 4 times likely to suffer an injury when compared to the low-risk group. According to D'Souza, physical examination signs such as low body mass index, recent or continuous weight loss, orthostatic hypotension, lanugo, yellow skin, hair loss, or additional signs of an eating disorder, such as parotid gland swelling or callus on the proximal interphalangeal joints, should also prompt further evaluation. Taking an accurate menstrual history is important, starting from age of menarche to the present, inquiring regarding months of consecutive missed menses and the number of menses per year since menarche. Lab tests of secondary amenorrhea in girls should begin after 3 months or more of missed menses. A medication history should be also obtained, including medications which may affect the period or the bone mineral density, such as oral contraceptive pills or other contraceptive agents. A history of physician-diagnosed bone stress injuries and other fractures should be noted, as well as a family history of eating disorders, osteoporosis, or fractures. A complete physical examination should include height and weight, blood pressure, and heart rate. Also, a study of the athlete's growth chart could reveal growth arrest. Bradycardia, which is a resting heart rate of less than 50 beats per minute, is common in cases of anorexia nervosa. However, it is commonly found and anticipated as normal in elite athletes. During clinical evaluation, orthostatic hypotension should be checked as well, as it is sometimes present within the female athlete triad. Usually, a gynecologic examination is normal in athletes at risk of the triad. A laboratory investigation of an amenorrheic athlete should include a pregnancy test and all hormonal blood tests. More lab tests may be required based on the medical history and the physical findings. When an athlete suffers from an eating disorder or bradycardia, a variety of specific investigations should be done, such as a complete blood count, electrolytes, blood glucose, urine analysis, and electrocardiogram and cardiac echo. Diagnosis: sporadic menstrual disorders or complete amenorrhea in a female athlete can be the first sign of the female athlete triad. Osteoporosis and stress fractures, psychological dysfunction, and decreased athletic performance may be the first signs of the disorder. Management of the female athlete triad. The aim of the treatment is to resume normal period cycles, increase bone quality, and address psychological disorders. Non-pharmacological interventions, including psychological therapy and family support, may also be an efficient way to treat an eating disorder. However, it is critical to note that not all athletes with the female athlete triad suffer from an eating disorder. Many athletes have not realized their high energy needs. Others do not fulfill their daily caloric intake due to poor appetite. An experienced nutritionist can advise the athlete and her family regarding adequate food consumption and special dietary supplementation in order to restore energy levels and improve bone quality. Generally, daily consumption of 1,000 to 1,300 milligrams of calcium and 600 international units of vitamin D is sufficient. In particular athletes, coaches may have to decrease athletic activity levels until energy levels are fully restored. The most important factor to return normal menstruation is proper weight increase. Treatment can be difficult if the athlete and her environment are convinced that weight increase, higher energy intake, or temporary decreased training activity may lead to poor sports performance. The physician should discuss and analyze the treatment plan with the athlete, her family, and trainers. Coaches often are not familiar with the symptoms of the female athlete triad or the serious consequences of the disorder, so education of coaches is vital. Adequate communication with families and coaches ensures they understand that the athlete is unfit to participate in sports until treatment goals are reached. Successful management is only achieved by a multidisciplinary team composed of the physician, the sports nutritionist, the sports psychologist, the trainers, and the family members. Pharmacologic therapy in the management of the female athlete triad is not yet established. According to Chamberlain, treatment with medication may be considered only when non-pharmacologic treatment has not achieved the treatment goals. In patients with severe anxiety or depression, antidepressant medication should be prescribed. Current studies support the use of oral contraceptive pills to improve bone mineral density. However, it is important to communicate with the athlete that the medication cannot act efficiently without adequate food intake. Overall, successful treatment of athletes is highly dependent on a multidisciplinary approach, including a sports medicine physician, a sports dietitian, and a mental health practitioner. depending on the individual situation. Consultation from an endocrinologist, orthopedic surgeon, psychiatrist, or exercise physiologist may be beneficial. This treatment approach should be based on trusting and respectful interactions between healthcare providers and the athletes. Careful management and consideration of the effects of treatment goals on health status, athletic performance, and personal lifestyle is mandatory to ensure treatment adherence and necessary post-treatment follow-ups by affected female athletes and their families. Conclusion. Physicians should inform trainers, coaches, and parents to stay alert for symptoms and signs of the female athlete triad. Frequent updates and discussions with the athletic staff and parents about the warning signs may help in preventing the disease or diagnosing it in its early stages. Thank you for your attention.
Thank you, Dr. Anastasia, for your nice talk. And the floor is open now for questions. Okay, Dr. Anastasia, there is no more questions. And again, my apology for the inconvenience. And we will give the floor to Dr. Khulud for the coming speaker. Dr. Khulud, please.
I don't seem to have the program. Yes, it's now the floor for Dr. Shaima Abdel Maboud. She's a senior cardiac specialist and heart imager in Shifa Al Jazeera Medical Center, and today she's gonna present to you women heart in childbearing and a pregnancy period. The floor is yours.
Okay, welcome. First of all, I am glad today to participate in this elegant conference. Thanks for invitation. I'll share my screen now.
Yes, you can, please.
Okay. Today we will discuss about heart diseases during childbearing period and pregnancy. Pregnancy in patients with heart diseases becoming more common due to its early diagnosis and better treatment. Incidence 0.2 till 4% worldwide, USA 1 to 3%, in India 0.5 till 1%. Developing countries, rheumatic heart disease most common up to 95%. Developed countries, congenital heart disease up to 50%. The ratio between rheumatic heart disease to congenital heart disease has fallen in the last 2 cases from 10 to 0.1 to about 3 to 0.1, even 1.1 in developed countries. Physiology adaptation in pregnancy: increased blood volume on 40 to 50%, increased cardiac output 30 to 50%, decreased systemic vascular resistance. The heart elevated upward and rotated forward to and to the left. Pulse increase up to 10 to 15 minutes per minute after 13 to 20 weeks, and it may cause palpitation. Disturbed rhythm, arrhythmias, premature atrial contraction, BPCs can be occur. Increased clot factors, number 7, 8, 9, 10, fibrinogen. Cardiac output changes during labor and birth. Intravascular volume changes just after childbirth. And also can causes cardiac changes are not well tolerated, and cardiac failure can be developed during pregnancy, labor, postpartum, and it is all this period called peripartum. If myocardial disease develops, valvular diseases can exist, or congenital heart diseases defect is present, cardiac decompensation is anticipated. Hemodynamic changes during labor and delivery, anxiety, pain, uterine contractions, oxygen consumption, increase the threshold, increase the cardiac output during labor, increase the stroke volume, and increase the heart rate. Increase systolic blood pressure and diastolic blood pressure, especially on the second stage. Those changes are influenced by the form of anesthesia and anesthesia. Cardiac diseases can be classified as acquired, congenital, and other important conditions. Acquired is rheumatic heart disease, ischemic heart disease, and cardiomyopathies. Congenital is cyanotic heart disease, left to right shunt, ASD, BSD, BDA, cyanotic heart disease, right to left shunt, tetralogy of Fallot, tricuspid atresia, Epstein anomaly, TGA, total anomalies of pulmonary venous drainage, obstructive lesions like aortic stenosis, coarctation of aorta, pulmonary stenosis. Other important conditions like arrhythmias, infected endocarditis, Marfan syndrome, mitral valve prolapse, pulmonary hypertension, Eisenmenger syndrome. This is important question can we face in our clinics. Some females coming to ask me, can I be pregnant? And mothers come to us, if my daughter can be married and be pregnancy with heart disease. There is some lesions contraindicated to pregnancy. First of them is severe pulmonary hypertension, 50% maternal death rate. In severe aortic stenosis or severe pulmonary stenosis, and HOCM, which is hypertrophic obstructive cardiomyopathy, and coarctation of aorta, there is 17% of maternal deaths. Systemic ventricular dysfunction, NIHA class 3 to 4, it is 7% maternal deaths, and all of these contraindicated to be pregnant. What is the new in the European Society of Cardiology guidelines? They enforcing to maternal WHO classification at the maternal risk and the introduction of the pregnancy heart team, more attention for the assisted reproductive therapy, discussion to the use of chromocriptin in peripartum cardiomyopathy, and the introduction of specific levels of surveillance based on the low, medium, high risk of arrhythmias and the hemodynamic compromise at the delivery. And the new information about the pharmacokinetic and pharmacodynamic in the pregnancy medications. Perimortem cesarean section is discussed also in these guidelines. Advice of contraception and determination of pregnancy in women in cardiac diseases is now provided in these guidelines. This is the maternal cardiovascular predictors. I'll focus on the maternal cardiovascular predictors. I leave the neonatal to the pediatricians, but for me, it is important. What is the female criteria that can I predict? She will be in a high mortality or a high morbidity case during pregnancy or delivery. First of them is prior cardiac events. Is this female have prior cardiac events like heart failure, transient ischemic attack, stroke, arrhythmias, NIHA class 3 or 4, left heart obstruction, moderate to severe, reduced systemic ventricular systolic ejection fraction is less than 40%, reduced subpulmonary ventricular function, CAPC less than 16 millimeter, systemic AV valve regurgitation, moderate to severe, and pulmonary atrioventricular regurgitation, moderate to severe, pulmonary arterial hypertension, cardiac medication before pregnancy, cyanosis O2 less than 90%, natriuretic peptide level is more than 128 picogram per milliliter at 20 weeks of predictive of event late in the pregnancy. Is there is history of smoking, mechanical valve processes, repaired or unrepaired cyanotic heart disease. All of these predictors that they may be cause high mortality and morbidity during pregnancy. First of all, I wanted to all of us know that in green one, it is +1 indication. It means recommended is highly indicated in green one. +2 is should be considered in the yellow, and the +3 it is harmful and not recommended. I give some diseases and how to manage according to European Society Committee guidelines. First, we can face hypertensive patient during pregnancy, how to deal with them and how to manage. So according to European Society of Cardiology, they allow it to use low dose aspirin 100 to 150 milligram per day. It's recommended in women at high or moderate risk of preeclampsia from week of 12 to 36 or 37, in women with gestation hypertension, of pre-existing hypertension superimposed by gestation hypertension or with hypertension or subclinical organ damage. We can initiate treatment from systolic blood pressure more than 140/90 or more than 150/95. In severe hypertension, like more than 170/110 in pregnant women, it is emergency and it should be hospitalized, and this was class 1 recommendation. What is the medication we can be available at this period of pregnancy or childbearing period? Need to be pregnant, methyl-dopa, labetalol, calcium antagonist are recommended for the treatment of hypertension during pregnancy, +1 recommendation. In women with gestation hypertension with mild preeclampsia, delivery is recommended at 37 weeks. It means TOP, termination of pregnancy. It is recommended to expedite the delivery in the preeclampsia and with adverse conditions such as visual disturbances or hemostatic disorders. In preeclampsia associated with pulmonary edema, we can give nitroglycerin IV infusion. In severe hypertension drug treatment, IV labetalol or oral methyl-dopa or nifedipine is recommended. Weight gain is limited, less than 6.8 kg or obese pregnant women should be considered as class 2A. What is harmful and the class 3 indication for these females? Contraindicated to give ACE inhibitor or diet-renin inhibitors, not recommended by European Society of Cardiology. Pulmonary hypertension, as we see here, this is the healthy artery, and this is the narrow, and this is the severely narrow. Pulmonary hypertension is the catastrophic cause for the maternal, and as we see here in the red, it is contraindicated to be pregnant with pulmonary arterial hypertension. And every female should be counseling for that before pregnancy. If we faced some females with pulmonary hypertension during pregnancy, and it was diagnosed by echo, there is pulmonary hypertension, we should do right heart catheterization to confirm the diagnosis of pulmonary arterial hypertension. And the treatment with low dose of low molecular weight heparin is recommended in pregnant patients with chronic thromboembolic pulmonary hypertension stiff patient. If a patient of pulmonary arterial hypertension on the targeted pulmonary hypertherapy, considered should be given and withdrawing imperiotoxic drugs, taking in account and risk withdrawal, it is class 2A. And the treatment of naive pregnant pulmonary arterial hypertension patient, initiating treatment should be considered. In congenital heart diseases, as we know, there is acyanotic congenital heart diseases like ASDB, DA, and cyanotic heart diseases. Most common is tetralogy of Fallot. These pregnant females with Fontaine circulation and saturation less than 85%, depressed ventricular function, moderate to severe AV regurgitation, refractory arrhythmia, and protein losing enteropathy should be advised against pregnancy. Here, the recommendation giving 2A, it may be considered. But in that, we can see here, it is in the red, it is category 3, it is harmful to be pregnant with all these criteria corrected by Fontaine circulation and saturation less than 85%. In this patient also with asystemic right ventricular moisture descending congenitally corrected TGA, in NIHA class 3 to 4, systemic ventricular function less than 40, when the severe CR should be advised against pregnancy. Anticoagulation treatment can be considered in pregnancy female with Fontaine patient. and the symptomatic patient with epic-time anomaly with saturation than less 85% or heart failure should be advised against pregnancy. Aortic diseases like Marfan, bicuspid aortic valve, Loeys, and Turner, vascular heterodynos, and all of these most are connective tissue diseases. As we see here, and the location of the aneurysm can be everywhere at the aortic arch or ascending or descending. And this risk of all are high from 1 to 10, except the bicuspid aortic valve is less than 1%. Comorbidity, all of them have must of comorbidity. And how to advise these pregnant females? According to Marfan, ascending aorta more than 45 millimeter or more than 4 millimeter, and there is family history of dissection or sudden cardiac death, we can advise her to not be pregnant. Bicuspid aortic valve with more than 5 millimeter, ascending aorta is dilated. Loeys syndrome, if there is more than 45 millimeter or more than 40 millimeter in family history of dissection or sudden cardiac death. And in Turner syndrome, if there is aortic stenosis index more than 25 millimeter per meter square, because it is according to body surface area, and vascular heterodynos in all patients advised not be pregnant. How to manage the aortic diseases? It is recommended to all women with aortic diseases to be counseling about the risk of the aortic dissection. And this female, I should investigate her by CT and MRI and see all entire the aorta before pregnancy in patient with genetically proven aortic syndrome or known as aortic disease. In bicuspid aortic valve patient, imaging plain ascending aorta is mandatory. And this patient is recommended for delivery with aortic dilatation should be aortic dissection should be delivered by cesarean section, and there is a cardio team and cardiothoracic surgery is available in patient with ascending aorta less than 40. Vaginal delivery is recommended. In patient with ascending aorta more than 45 millimeters, cesarean section delivery should be considered. And in the history of aortic dissection, cesarean section should be considered. Prophylactic surgery should be considered during pregnancy if the aorta diameter more than 45 millimeter and increasing rapidly. When the fetus is viable, delivery before necessary surgery should be considered. In the patient with aorta to be 40 to 45 millimeter, vaginal delivery with epidural anesthesia and expected second stage should be considered. There is some specific for Ehlers-Danlos. This is should be not be pregnancy, and beta blockers can be used in the aortic diseases like Marfan syndrome. And pregnancy is not recommended in patients with severe dilatation of aorta and the disease as Marfan syndrome more than 45, bicuspid aorta more than 50, and Turner syndrome if the index more than 25. Pregnancy is not recommended in patients with vascular Ehlers-Danlos syndrome. Valvular heart diseases. How to manage patients with valvular heart diseases? As we see here, if the female is on the mechanical valve and taking the high dose of warfarin more than 5 mg, this patient should be continue on the warfarin and monitor INR at least 2 or twice weekly. Here also we can, and this is in the first trimester, and second trimester also we can advise to continue and monitor INR at least twice per week. At the 36 weeks, she can be hospitalized and give unfractionated heparin IV. Or in hospital, exchange 2 molecular weight heparin 2 daily dose and to continue monitoring for the INR. At the 36 of the planned delivery, say 36 hours planned delivery, we will give unfractionated heparin. And as the delivery time, we will stop unfractionated heparin 4 to 6 hours before delivery and restart 4 to 6 hours delivery if no bleeding. If the female is pregnant on the mechanical valve and taking low dose warfarin, less than 5 mg, it is the same also. We will give the hair in the first term, continue on the warfarin and continue monitoring twice weekly on the second and third trimester also can continue, or we can hospitalize her as she wishes. And on the third 6 week, she should be hospitalized and taken IV unfractionated heparin, or in hospital change to low molecular weight heparin, and before planned delivery 36 hours we will give unfractionated heparin, and at the delivery time we will stop unfractionated heparin in 4 to 6 hours, and then we will resume after 4 to 6 hours if there is no bleeding. This is how INR to be in the range. If she is in low risk, 2.5 to 3, and the medium 3
Dr. Shaima. Dr. Shaima.
There is a connection problem, is fixed. Just give us few minutes.
Okay.
It may be less.
She'll go only 5 minutes left for her anyway.
I hope it's okay now.
Now, yes.
Sorry for the disturbance.
You're live again.
Okay. Now it is share screen. Okay.
Yes, you've got 5 minutes left.
Okay. For the native valvular heart, we can intervene if there is a considered mitral stenosis, valve area less than 1.5 centimeter. In aortic stenosis, also we can intervene if there is symptomatic LV dysfunction less than 50% and develop symptoms during exercise. For the patient with coronaries, ECG should be done and the troponin level. Primary coronary angioplasty should be done if the patient is in the STEMI and net is not connected.
We can hear you, but the slides are not shared yet. It will be shared in a minute.
It is shared or no?
Not shared.
Can open the not shared. Screen is not shared. Management of coronary artery disease, ECG, and we can do angioplasty for STEMI patient under precaution, invasive management, conservative management for STEMI, and follow up the patient. For heart failure patient, acute heart failure, we can do this strategy for these patients by evaluate the fetus viable or not, and then we can do delivery and maximize advanced anti-heart failure therapy. If the fetus is a viable patient desire delivery, we can maximize advanced acute heart failure. If the patient needs a pregnancy to continue, we will hospitalize the patient and maximize the treatment. If the patient has the cardiomyopathy during pregnancy, we can start anticoagulation and for the intracardiac thrombus. And there is also heart failure during pregnancy according to guidelines, respecting that we can prevent them if there is patient is heart failure HFrEF with reduced ejection fraction, and peripartum cardiomyopathy should be evaluated. There is peripartum and dilated cardiomyopathy for the recurrent during the subsequent pregnancy, all cases after recovery of the LV function. As we see here, also in arrhythmias, they develop, they consider them low risk, medium, or high risk. We can give beta blocker, selected beta blockers for arrhythmias like atrial premature contraction or AF +1 indication. We can give flecainide, propafenone, sotalol, digoxin, and propamine should be considered. Catheter ablation and the EP carto mapping can be done also, +2E. And the immediate electrocardioversion is recommended for sustained post unstable and stable BT. For acute conversion, sustained BT can be done also. Beta blocker agents are recommended during pregnancy and postpartum in patients with long QT syndrome and the CPVT. Pregnancy and BT, the thrombotic embolic manifestation, we can give low molecular weight heparin recommended for prevention and the treatment BTE patient. High risk women are recommended to give weight related prophylactic low molecular weight heparin. Enoxaparin once a day. It can be done in the pulmonary embolism if the patient with severe and cardiogenic shock. Contraindicated to give these female patients direct anticoagulation, not recommended during pregnancy. There is some general recommendation, very brief, and I'll finish my presentation. For every female pregnant and with heart disease should be pre-pregnancy risk stratification and counseling indicated for women. Recommended to perform risk stratification for all women cardiac diseases at the childbearing period, and that high risk are treated in a specialized center with a team, and fetal echocardiography can be done with highly specialized patient unexplained with new cardiovascular signs or symptoms. If cardiac surgery is after 24-hour week, vaginal delivery of the patient, and indicated for them to be physician for this. MRI with gadolinium can be considered if the echocardiography is insufficient and severe hypertension, vaginal delivery, and epidural analgesia elective instrument.
Dr. Shaima, you exceed the time for you. How many slides do you still have?
Surgery should we finish almost 3. If there is any question, we can share. No,
it's very informative. It's very informative lecture, I'm sure, and I got a lot of questions, so it's really interesting. We do apologize for this technical issue you had with during your presentation. I'm not quite sure, Dr. Hatem, is there a time for question?
Yes, we can have 2 or 3 questions.
Yes. I've got a question here. What is the role of anticoagulant in a pregnant patient who underwent repair of VSD and ASD with unremarkable second echo normal and ejection fraction more than 80%? Dr. Shaima.
I am with you, doctor. If there is any question, I'm ready.
What is your view of having anticoagulant for a pregnant lady who had a repair for VSD and ASD, and echo was second echo and ejection fraction of more than 80%?
Please again.
Role of anticoagulant for pregnant lady who underwent repair for VSD and ASD.
We can give aspirin, small dose aspirin, as we said by guidelines in this slide. We can give a small aspirin as a prophylactic, 75 to 150 mg.
Even if it's normal echo and AF ejection fraction is more than 80, there is a place for anticoagulant?
Yes, it is a high risk pregnancy.
So still we need to give anticoagulant as aspirin? And
yes, because she is a high risk pregnancy, we can give.
Only aspirin, or do you recommend?
Aspirin, antiplatelet, anticoagulation. If there is no dilatation, there is internet connection is unstable.
Another question, is there an absolute contraindication for delivery mostly a right-sided heart condition ended with pulmonary hypertension? What about functional tricuspid incompetence with no or mild pulmonary hypertension?
Pulmonary hypertension, can we deal with the patient with pregnancy? If there is severe pulmonary hypertension, it should be contraindicated and terminated pregnancy for the risk of mother's hazards.
So if it's mild hypertension, there is no place for termination of the pregnancy.
We can consider this pregnancy as a high-risk pregnancy, and we can hospitalize her, and there is a team follow up her.
Great. I will leave the floor for Dr. Hatem. Thank you very much for this interesting, and we really still apologize for the inconvenient, technical issues.
Thank you, and I'm sorry for this.
It's very informative.
I'm so sorry. Yeah, it is very tough and very long, and I hope everyone can be useful from this lecture. And I leave the lecture, and if there is any questions or comments, I'll answer later.
Yeah.
Thank you, Dr. Khulud, and thank you, Dr. Shema, for giving me the floor. And I will back again to Dr. Hoda Juferi. I am lucky to present you twice. So Dr. Hoda is one of my dearest friends and colleagues. She is a consultant of Obs and Gynae in Ibn Nafis Hospital, and she will address to us an interesting topic of pre-malignant condition in gynecology and management of abnormal pap smears. The floor is yours, Dr. Hoda.
It's lucky for me to be with you. Just 1 minute to share my presentation. Yeah, that's this. Okay. Share it. Where is it? This is one. Share. Make it powerful.
It is shared, Dr. Hoda, now.
Already shared?
Yes.
Okay. Yes. Today I'm going to present about a condition that we face every day in our clinic as a gynecologist. It's very important how to deal with it. And sometimes it's tricky, sometimes it's difficult. So I think it's very important that everybody should know about it. So to start with, I'm going to talk about the pre-malignant conditions. But to start with, we have to know what is the meaning of pre-malignancy. So as a definition, it's a morphological altered tissue in which cancer is more likely to occur than its apparent normal counterparts. And it can be also defined as a generalized state which is associated with significant increased risk of cancer. We know that some cancer are believed to be preceded by a prolonged detectable and irradiable phase of pre-malignant condition. But is it really difficult or easy to screen and treat the pre-malignant conditions in case to save the patient from getting a cancer? So in our field in gynecology, can we really screen the conditions? So in case of cancer of vulva, it's possibly we possibly can screen it. Vagina is a probably can, and endometrium is also possible, but definitely in case of cervical cancer, it's certainly we can screen it. So it's very important also to know some sort of definitions and terminology in the case of pre-malignant condition. What is the meaning of intraepithelial neoplasia? It's a process confined to the epithelium that the basement membrane is intact. There is no stromal invasion. And what is the meaning of dysplasia? Dysplasia is a histological term describing the architecture's abnormality within the tissue. And what is the meaning of dyskaryosis? It's a cytological term describing the nuclear abnormality. In gynecology, in the pre-malignant condition or intraepithelial neoplasia, vulva, we call it VIN, vagina VAIN, cervix is CIN, and the endometrium is hyperplasia with or without atypia. So in case of VIN, it's a rare condition. And here in this picture, we can see this area that it is, there is involvement with hyperkeratosis producing an area of leukoplakia with here an atrophic area, which is a normal but atrophic keratinized squamous epithelium. Most of the cases of VIN do not progress to invasive cancer. And usually it will be multicentric, and some occurs in association with cervical or vaginal carcinoma. What is the treatment? It's just 2 words. It can be applying a steroid. It can be surgical removal of the abnormal tissue. It can be by laser or diathermy or local application of chemotherapy or valvectomy. VAIN. It's a vaginal intraepithelial region which mainly due to exposure to HPV virus, or it can be due to extension of CIN, or we can see it in cases of post hysterectomy for CIN, and it can be associated with intrauterine exposure of ethyl testosterone. And the treatment, it can be, we can use Aldera 5%, can be by laser, surgery, radiotherapy, local chemotherapy, like using fluorouracil. Case of endometrial pre-malignant condition, it can be related mainly to estrogen. It can be simple or complex with or without atypia. The treatment is with progesterone therapy. It can be with oral, injectable, or IUCD with Mirena, progesterone IUCD, and it can be with hysterectomy, especially for cases of who finish their fertility. First, now we will talk about cervical intraepithelial neoplasia, which is the main concern. It is a precancerous condition where the abnormal cells grow on the surface of the cervix. It is essentially a precursor of invasive cervical cancer. The most important causative factor is the HPV virus. So what is the HPV virus? It's a double-stranded DNA. It can infect the basal layer of the genital epithelium, where there will be a malignant transformation of the cells with the expression of E6 and E7 oncoprotein, which is produced by the HPV virus. There is a lot of types, more than 100 types. Some of them are associated with genital warts, where we consider them the low risk, mainly the 6 and 11. And there is a high risk viruses associated with the cervical cancer, mainly 16 and 18, but I noticed in our population, the other types like 45, 30, and 60s are more common than the 16 and 18. It is very important to understand the natural history of HPV, how it will what will happen if you are if the patient infected with HPV. Here we can see that it can be a recent exposure with a new partner, or it's a past exposure from a sexual past history. So there will be new acquisition, or it can be a reinfection. And it depends from where there will be a disposition of the virus through the sex. In case of past exposure, there will be reactivation of the virus. It can be intermittent detection. There will be a low level of infection. Sometimes even if we do test, it will be negative. Or it can be from auto-inculation from another anatomical site, like from the anus. So patient got the infection. If she is infected with HPV virus, either it can go into a clearance, which is most of the patient will clear the HPV after 2 years of within 2 years of exposure, that they will have immunity, or they can have a persistent disease, or it can be a latent controlled infection. It will be low level or low limit of detection. It will be still infected, but when we do the test, it will be negative. But if it is persist, it will be positive, and it will progress to neoplasia or cancer. Go back. Sorry. Here we can do again to see the natural history. We can see that there is an exposure or related to multiple sex partners or early sexual life, or it can be a high parity also as a factor. And in case of male, they found the non-circumcised male are more susceptible. So if patient got infection, it will be also clear. Most of the patient will have immunity and will be cleared within 1 year to 2 years, or it can progress. If they progress, there is some other factor that lead to the progression, like high risk HPV infection, like 16 and 18, or weak immune status and response of the patient, or other sexual transmitted diseases, or can be genetic disposition of the patient itself. If it gets more and more, if it stayed, it will be infected. It will be like ASCAS low grades of infection. But if it persists more than 5 years, it's got more and more progression to cancer. These are also other factors that leads to more progression of the disease, like multiple HPV infection. More than one type of virus is involved in the infection, or smoking, or long-term use of oral contraception. This all leads to more of a progression of the disease, and genetic and epigenetic status, like the HPV integration of genetic instability of the patient, and there will be oncogenic expression of the on E6 and E7 on the patient's epithelium. And this, if the HPV virus persists for more than 10 years, it may lead to CIN2 and CIN3, and if it is more than 10 years, up to 25 years, it can lead even to cervical cancer. But it can regress. Mainly if it is less than 2 years, the regression rate is very high. So what is the classification of CIN1? CIN, it is everybody's from the medical school. We know that it can be classified as CIN1, 2, and 3, or carcinoma in situ. It depends on how much of the epithelium is involved. If it is 1/3 of the epithelium involved, it can be low grade or CIN1. If it is from 1/3 to 2/3, it will be CIN2. And if it is more than 2/3 of the epithelium involved, it can be considered as high grade. And there is the Bethesda classification. They consider the low grade squamous intraepithelium as CIN1, and the high grade is CIN2 and 3. This is again more of classification, more detailed, as we mentioned, as we know here, that it can be negative. General concept can be negative, or it can be ASCAS, or ASCAS cannot rule out high grade, low grade, high grade, or squamous cell carcinoma. It's very important, if we are talking about cervical intraepithelial lesion, is to understand colposcopy. And there is, what is the indication of a colposcopy? So it can be abnormal pap smear is an indication of colposcopy, evaluation and treatment of a CIN condition, or even just an abnormal bleeding, either postcoital or postmenopausal, or even intermenstrual bleeding is an indication for colposcopy. Or if there is a persistent foul-smelling vaginal discharge, and in case of unhealthy cervix, or if we found there a patient with an HPV positive or genital warts. The findings, it can be just punctation, mosaicism, or some other frank lesions. Here, the screening is very important to know when to screen and whom to screen and what to do in the screening. They found that recently they're finding that most of the patients up to age 21, they'll be infected with HPV, and they will clear it by their immunity. So that's why now it's not recommended to do screening for patients who is less than 21 years of age, unless she's infected. But if at 21 to 29, they are recommending to do a Pap test every 3 years, but there is no HPV screening is recommended, or we can, if patients are having ASCAS or more, then we have to do the co-testing with, we can go for the HPV virus. And patients who are more than 30, from 30 years to 65 years, the Pap test every 3 years, or co-testing with HPV and Pap smear every 5 years. And in case of more than 65 years of age, there is no screening needed if there is 3 normal Pap smear consecutively, or 2 HPV test is negative and Pap is negative. They are recommending if a patient who is having CIN2 or CIN3, or even a previous history of adenocarcinoma in situ, there should be a screening continuously up to more than 25 years follow-up every 3 years. It is very important to know the primary screening of HPV. So if HPV primary first, HPV testing is negative, we'll go just for a routine screen. But if HPV positive, if it is positive for a high risk at 16 and 18, we go direct for colposcopy. But if positive for one of the 12 types of high risk, which is mentioned down there in the 30 and 31, 30 and 50s and 60s, these are, we have to go for the cytology. If we don't have the Pap smear, but we have an HPV testing, it's positive, then we have to go cytology. If it's negative, we repeat the cytology and the HPV after 1 year. And if it is having an abnormal cytology, we have to go directly for colposcopy. It's very important to know how to deal with the abnormal Pap smear, how to read it and how to manage if we got any Pap smear result. So if I have patient and I done for her a Pap smear, but the Pap smear turned to be unsatisfactory. So where to go from there? In case of unsatisfactory cytology, so it's an unsatisfactory Pap smear, I have to go and see HPV. If HPV is negative or it is not known, I can repeat only the cytology after 2 to 4 months. If it is an abnormal, I go according to the abnormalities finding. If it is negative, then I just go for a routine screening after 1 year. If it's positive, I can repeat it after 2 to 4 months or go directly for colposcopy. But if it's again unsatisfactory, then I have to go directly for colposcopy. What about if my cytology is negative, but the HPV is positive? Then I will go direct for a repeat co-testing. Co-testing means I have to do the HPV plus the Pap smear together. So if both of them are negative, then I'll just repeat the co-testing after 3 years, or if the HPV positive or there is an abnormal Pap smear, I go directly for colposcopy. And if HPV is positive from the beginning with a high risk group, then I will go directly for colposcopy, or I can go for a co-testing, and after 1 year I go, if it is negative, I can continue. What about if it's an ASCAS? We have a lot of cases of ASCAS, so what to do with these cases? In case of ASCAS, we will go for, it is acceptable to just repeat the cytology after 1 year. If it's negative, we go for the routine screening. If it's more than ASCAS, we go for a colposcopy, and we have to do endocervical curating to identify if the endocervix is involved. And we have to do HPV testing, which is the preferable way of managing it. If it is negative, we go for repeat pap smear and co-testing in 3 years. But if it is positive, we have to go for a colposcopy with ECC, endocervical curating, and biopsy from the cervix. What about low-grade squamous intraepithelial lesion? How we manage them? It is depending on if low-grade squamous intraepithelial is associated with HPV negative test. It is preferably to repeat the co-testing. If it is HPV negative, but it's low grade, then we have to repeat the test. Co-testing means both within 1 year. And then if it's both negative, we go for the co-testing every 3 years. But if it is no HPV testing done and it is not feasible, then we have to go directly for colposcopy. But if it is positive, still we have to go for colposcopy. And accordingly, if there is CIN 2 or 3 or no. If it is CIN 2 or 3 or more, accordingly we'll manage either with the ablation treatment or with the excision treatment. But what about if it is a high-grade squamous intraepithelial lesion? It's very important to either ASCUS also cannot rule out high-grade or just high-grade squamous intraepithelial lesion. It's very important to identify that it is important to go directly for colposcopy. It's not acceptable to go directly for loop or cone biopsy just because we're having high grade. We have to do colposcopy, we have to take biopsies, and we have to do ECCs to identify if it is a persistent case or it is just transient stage. So more important is to go to colposcopy. If there is no CIN 2 or 3, we can just go for observation and colposcopy and cytology after 6 months, every 6 months for 2 years. We have to follow them for 2 years with 6-month interval of co-testing. And then if there is negative, then we'll just go for routine follow-up. But if it is still high-grade squamous intraepithelial lesion and it persists for more than 1 year with no CIN 2 or 3 with in the biopsy, we go for diagnostic excisional procedure, which is either the loop or the cold knife cone biopsies. But if it is persist for more than 1 year, the high grade, we go directly for biopsy. We don't wait. And we go for the cone biopsy preferably because we want a clear margin. What if we have AGUS? We have some patients who comes with pap smear showing AGUS. It's very important from the pathologist to identify if they're mentioning there is atypical endometrial cells. So we go directly for endometrial and endocervical sampling. And then if there is no endometrial pathology, then we have to go for colposcopy and biopsies. And in case it is not mentioning that there is atypical endometrial cell, we have to go directly to colposcopy. With that, we will do endometrial sampling and endocervical sampling, and then according to the findings. What about if it is after we got the result? So if the initial cytology shows there is favoring malignancies, then we have to go, even if there is no invasive disease, then we have to go for the excisional diagnostic procedure with the biopsies, cone biopsies. But if it is the initial cytology is AGUS, but there is no signs of neoplasia, then we have to, and there is no CIN 2 or cancer, so we can go for just the co-testing every 1 year and then 2 years. And if it is both negative, then we have just to go back to co-testing every 3 years. But if CIN 2 but there is no glandular neoplasia, then we have to go again for the biopsies. And if it persists, we have to go for colposcopy and then for diagnostic excisional procedures.
Dr. Huda, we have 5 more minutes.
Okay. So this is mainly the same. I will just mention, I think this is easier for the patient, for us to know that this type of pre-invade treatment, the local destruction, local excision or radical. And just to mention about the vaccine. Vaccine is available, and it is the initial vaccination is recommended at age 9 to 14 years with 2 doses, and if catch-up vaccine from 15 to 45 years can be given in 3 doses. And the type of vaccine we are having is the Cervarix, Gardasil, and Gardasil 9. And they found that the HPV vaccination with the HPV vaccine, it dropped the infection up to 88% in the teenage patient and among 81 in young women. And I think it's recommended to be given for all boys and girls. And thank you.
Thank you, Dr. Huda, for your nice presentation, which was very informative. And I think, and I have just one question. Does the Ministry of Health have a recommended program for screening for cancer cervix?
There is, in our Ministry of Health, there is a schedule program for pap smear testing every 3 years. It is there.
And does the ministry recommend the vaccination?
No, unfortunately, the vaccination is available only on patient request in the private sector. It is not in the Ministry of Health. It's not. Though we are seeing a lot of patients. I think every one of us seeing every day one patient, or I mean, more than one patient with an abnormal pap smear.
I have one comment or a question from Dr. Hafsa. If the result is insufficient tissue, even sure you obtained improper, why insufficient and what's the next?
It is same as we mentioned. If it is unsatisfactory, it is the same. If it is unsatisfactory, I can repeat it, and I have to do the HPV testing. If the HPV test is negative, I can repeat after 2 to 4 months. But if the HPV is positive and the pap smear is still unsatisfactory or insufficient, then I have to go for colposcopy.
Okay. Thank you very much, Dr. Huda. And we will move according to our schedule to Dr. Khulud Al-Darazi to present for us the coming speaker.
Thank you. Let me start. Thank you very much, Dr. Huda, for this informative presentation. I really enjoyed it and I learned a lot. Share with you, yes, we see a lot now with HPV positive and a lot of abnormal smear. Dr. Maimouna today is to continue about the cervical screening. It's such a very important topic because we know very well that CA cervix is one of the on the top list of the cancer in women in Bahrain. If we ovarian, and this is followed by the followed ovarian cancer, so it is very important. Dr. Maimouna is a consultant OBGYN. She worked in Dr. Abdullah Kamal Medical Center. The floor is yours. You can share your slide if you want.
Thank you so much, Dr. Khulud. Can you see it?
Yes. Can you share your slides, please? You share your screen.
Just a second.
Just press on the share
Yes.
screen. Yes.
Is it working now? Can you see it?
Yes, yes, it's working. Yes, you
All
can
right.
you can start your presentation.
First of all, I would like to thank you for the opportunity. And everyone has talked so amazingly that I feel shy here with so much senior present here. Dr. Hatim, I'm so grateful to you, Dr. Malas, Dr. Sami, and so many senior colleagues. So I will try my best effort to give a little bit more knowledge. Already the most important points of cervical cancer has been discussed by Dr. Huda, amazingly. And she has already told the most of the management. So I'll try to be more precise of the screening, points which I think should be mentioned again. So this is mainly about from conventional to molecular. So before, as we know, we were going with the pap smear, we have moved from pap smear to liquid-based cytology, and now finally we have moved to the molecular, that is HPV as the primary. So HPV being the primary test now. Now, there have been some studies done in Bahrain already regarding the cervical cancers. 3 of them which I know about is, first one done was published in 2015, in which it was basically the incidence of cancer, and it was done in a small group of people. Then the second study was done, data from 2005 to 2015 was published, which was also a small study of 300 patients. But recently in 2018, a study was done in BDF, which was published in 2020, and that included, it was inquiring about how patients present and are they following the proper way of being screened in Bahrain as per the Bahrain Cancer Society, or is it just that they're doing randomly the testing? So it was found out that patients are still not very coping up with the proper way. They're just randomly going anytime and getting their test done. So when we go to the story of this cancer, cervical cancer, we already know it starts off with the transformation zone. What is that? That is the part of cervix in which the changes start happening. So once a female, she grows up, she passes through puberty, she has her regular cycles, the mouth of the womb, or which is called the area between the ectocervix and the endocervix, there are some changes in that area due to going through a lot of labor changes, hormonal changes every period. And that area, the cells keep on changing in that area. Because of that, the transformation zone is a new area formed, which is at high risk. Now, in this transformation zone, if the HPV virus comes and sits there, our concern is not HPV being there, because it is going to be there. It's like the flu of the womb or flu of the uterus. Why? Because no matter what you do, you will get it unless you decide not to have intercourse. So the only way to avoid it is by not having intercourse. If you're going to be sexually active, you will get this. So it's like the flu, it's going to come to every person. But that HPV, the main thing is whether it stays there, for how long will it stay, and if it's persisting, what is the immunity of that person? Is that person regularly following up with the pap smears? Is she smoker or alcohol drinker? So we have to know the risk factors. According to that, it will decide whether that HPV will stay in her body or will it pass down, will it go away from the body. Now, as we discussed about transformation zone, we already know that it's the changes in the puberty, the changes in the pH, inflammation, it all makes some changes, which is going to change the cells. So over here in this picture, you can see this outside and this inside. There's difference between them. And in the beginning, this is the only small transformation zone. But as you can see, the cells, due to changes from the inside, which are columnar, they start growing and come towards the outside. And then the outside cells, they start growing back. So this area which is left over is called the transformation zone. And this is the high risk. Now, the most important facts about cervical cancer. Now we know this is we already know there is a prevention. We know that pap smear is the main screening tool, and we know that HPV is proven carcinogenic. Now, why do we not understand that? Why is there was a it came down from the year 1975 till 2006. Then it's not going down further. Now, reason is most probably it's because of the medical, from our side. Because if you don't know the things about a cancer, then it stays in society, yes. But when we know how it comes, what can we do, and how to treat it, vaccination is there, and still we are not able to control it or bring it down, that means we are a little slow in taking steps or actions. So first of all, we have to give hands off to this guy, George Nicholas, who was the one because of which the pap smear concept came. He started in 1943, and I would like to give hats off to his wife because he took a lot of samples from the womb from his wife. So the interesting thing is she must be, the main source. And after that, he collaborated with a gynecologist. So why I'm mentioning this here is that a simple person cannot do anything. We need to be collaborated with the cytologist. We need to ask the lab person who is the one reporting. And it should be between both the people when they decide that what is the result or outcome. Whatever the screening tool you will use, whether it's HPV or whether it's pap smear, but you have to collaborate. And if there's a positive finding, because we cannot risk missing a patient. Missing a patient means that you're leaving a person to, later on go into advanced stage and die. Even though this may be a slow growing cancer, this may take 10 to 15 years to develop the changes, but it's still not justified to leave a patient with a positive finding. So collaboration matters a lot. After that, we have the Zur Hossain, who deserves, hats off. He's the main person who found out about HPV virus. And after that, now we know everything about HPV, that, usually HPV, it has a lot of types, it stays in the body. Some types cause cancer, and most the other, they wash away from the body. Now, most important thing, what I counsel my patients when they come in and they have HPV positive, suppose the results say it's low risk. They're obviously low risk or high risk. For them, it's something very scary. So you have to guide them that HPV stays in the body for 1 to 2 years, and after that, it washes out. So the best way to check for HPV, like in the latest guidelines in UK, is that you do the HPV after 1 year. So after 1 year, low risk, obviously, will wash away, or even if present, we are not worried. But high risk virus, that's the main concern, because the screening is now done with only high risk virus, not the low risk. So high risk virus, if it's still persistent in the vagina, in your result of primary screening, then you go for the pap smear. Again, pap smear is normal, but high risk is still present. So you will repeat the test after 1 year. After 1 year, if high risk virus again comes positive, second time again you will go for the test of pap smear. And so this is how you correlate. Now, all has been discussed before with Dr. Huda, but I'm just putting a highlight once again so it sticks to the mind. So we have to know that HPV doesn't only cause problem in the women, it's problematic for men as well. So the cancers are not only, it can cause just anogenital, it can cause the mouth, the throat cancers. So we have to remember that the vaccination is not meant for only women or children or girls. In UK, in their vaccination program, it is recommended for boys and girls from the age of 11 onwards, 11 to 12, because the best time, they say, the most immune boosting happens from 8 to 12 years. If you take at that time, you only require 2 doses. But if patients or if children take the first dose of vaccine after the age of 15, in that case, most probably they will require 3 doses. So how do you get it? Now, I have told you most of the things, but just looking back at it, so you have to have intercourse or sexual activity. Without that, you cannot get it. Then once you get it, there are many types of HPV. Out of that, the most high risk would be 16 to 18. That's the one which will be present in 70 to 80% of cervical cancers. So if you have 16 to 18, yes, definitely, it has to be thoroughly checked whether you have, any other symptoms regarding anal, vaginal, or vulval cancer. Again, going back to, there are other high-risk viruses other than 16, 18, 31, 45, and many others now coming up. And the low-risk virus, which are 6 or 11, they are more important for the wards. So patients who are presenting with warts, you have to think maybe she has high risk virus as well. So you have to be more, vigilant to check for the other risk viruses as well. And the low risk strains, obviously, it will come off itself. So our concern lies usually here, the high risk ones for the cancer, and low risk for her practices, her sexual habits. Maybe if she's having low risk now, she may end up with high risk later. So it's so important to go into her sexual history as well. Now, coming back, as I said, that if you protect against HPV with the vaccination, you can nicely see that you don't only prevent cervical cancer, you're going to be protecting the female and the male with cervical, vaginal, vulval, anal, penile, mouth, or upper throat cancers. So this vaccine is something like we can say a blessing if we put it in our routine vaccination program for our young children, boys and girls. Coming to HPV back again, so it's simple, the life cycle, like it's all most of the pathology, but still it just enters, the HPV virus goes down deep. Once it enters, it starts making some changes in the nucleus, and it secretes some of the important molecular, just one second. Yes, some of the factors, which is E6 and E7. If E6 and E7, if you have a result from your pathology and it says E6 and E7 is positive, please remember this is something to worry about. That means it has reached to a stage where it's replicating fast, and this is going to convert into cancer. So again, the importance of liaison with the cytology matters a lot, and how you read the report matters as well. So as we say, once you have HPV infection, it's going to take you a lot of time to convert into CIN1. Maybe over the time of 10 to 15 years, you may reach here. And maybe by 20 years, you may reach here. Or maximum, it may take you 10 years for this. But still, this is not going to be hard and fast in every patient. Everything is changing. There are mutations coming up, and the HPV infection is also spreading fast. It's like, corona changes we see now. So we are not immune to HPV virus. We are all, susceptible, and every person, according to their risk factors, respond differently. So you have to be very careful which person are high risk, pick up their factors, and then screen them accordingly, according to the screening program. So we can see the changes may be mild, and then they start off getting worse with the HPV. So you see these type of changes mostly in your, outpatient clinic. And mostly these patients came to me, I took some of the pictures, and sometimes post-delivery, they forget their follow-up, or they, miss their appointment, and then they come with such services, cervix. It's very sad to, see them go through all this. So if we can, make a proper postnatal appointment and follow up. Actually, we have a proper health center program. We have very nice, Bahrain has its own program, but the follow up, the problem is the patient's education is very important. Patients still do not understand the importance of that visit. Now, as I mentioned to you, the E6 and E7 stage. So whenever you have the E6, E7 present in your result, be aware. E1, E2, 3, E4 are early stages. E6, E7 in pap smear result means be aware. As we can see in the life course, what happens? There's primary prevention, there's secondary prevention, and there's tertiary prevention. Now, in primary prevention, we have the vaccination, as we discussed already, and especially not only for girls, but for boys as well. We have the education regarding the sex, the contraception, and especially the male circumcision. And then the smoking and alcohol factors, these can be, controlled at this age. Secondary, when woman is more than 30 years, you can screen and treat. So even single visit, my main thing is when a patient comes to me, I try to make sure that she doesn't go out without getting this test, because I do not know whether is she going to come back, or is she going to follow the date given to her or not. So at least whenever you have a doubt that this patient is non-compliant, try to take a sample. And the good thing is now at least we can just screen with HPV. I mean, you don't have to go for pap smear together, because mostly they're worried about the cost in private sector. So the cost does matter, obviously. So I encourage them at least go for the main thing, for the HPV. Next, we in the tertiary settings, obviously, once you see it and you know there is something, you cure it. So I was very interested to find out last year. One of my cousins, she works in Australia in family medicine, and she told me that Australia is going to declare itself as cervical cancer free soon, maybe by 2025. The reason is because all the children would be vaccinated by that time. All of their people would be on regular screening programs, and all the women who will have problem will be under treatment. So that was like really motivating for me. And I thought, if Australia is such a big place and they can do it, why not Bahrain? So from that time onwards, I've been trying to encourage, tell patients, and it's sort of like a passion to, make everyone understand that how important it is, and we can control it. We can overcome this problem in Bahrain. And the important thing is, Bahrain is not only one culture. There are multiple people from different cultures. So the risk is different in every person. So it becomes our responsibility in a different way to aware everyone in different languages, in different cultures, that what is the importance of this. So going back to now we have come across all this. I told you as that, it takes 5 to 10 years, and not all the patients will turn into a cancer. Most of them go wash away. 28% will go into high grade, and only 3 to 5% will turn into cancer. So as we have seen, now we have vaccine coming up. Okay, so this is the commonest HPV 16 and 18 are the most common who give the cancer. So out of the other causes are also there. The vaccine which have been built up, before they were bivalent, then they got tetravalent, now they are nanovalent. So bivalent is the 116-18 coverage, tetravalent is the 116-18 6 and 8, and now the 9-valent has 5 more types of high-risk virus. So it is present in UK. Unfortunately, in Bahrain, we only get Cervarix. Cervarix is the one which covers only 2 strains, 16 and 18. But as Dr. Huda said, I would like to put this forward that unfortunately there's very extreme shortage of this vaccine most of the times, because the patients come, they take 1 dose, and by the time they're due for the next dose, it's already short. So there are patients who had 1 dose done only, and they're waiting for the second. There's some patients, because when we counsel, we're supposed to have that thing present here, but unfortunately because of the I have no idea why does the shortage suddenly come and then stays for a long time. We are suffering because of that. So I would appeal that if this vaccine could be present at level of government and should be provided to all the children and the women. US is now having their just recently I saw on this Twitter that US has launched a movement in which they said that vaccine, even before the concept was that only young age boosting. Now the concept, even at 45, you take it and it is very beneficial for you. So women like us in the, we all around, we have few years left, so we should go ahead and take the vaccine, I guess. And so we already did the natural history of HPV. I have already told that the important thing is if it persists, that's the only way it can give you the infection. Now there are some terms you will come across like CIN, dysplasia, dyskaryosis. You may come, when you're reading the report, you may come across them. So it matters that when you're reading, how do you tell the patient, and what is it? Is it histological result, or is it cytological? So we always follow the Bethesda system for that. CIN1, we know that it's minimal dysplasia. And now, according to latest, with HPV negative CIN1, we are not worried. But whenever it's 2 or 3, we straight away go for colposcopy. So now the other ways of the practices, the recent practices changes in America and UK. So in America, what they used to do was that they had either one test done, which was done every 3 yearly. It could be pap smear, it could be HPV, or it could be co-testing. Whenever they did only pap, they repeated it after every 3 years. But when they did co-testing, they were reassured and they did it every 5 years. So even now, this is preferable there. They take that as the preference. But the age in America was considered to be starting from 21 before. Now it has been changed to 25. Whereas in UK, it is still like the starting age to do pap smear is 25 only. In the patient who have hysterectomy done already, if the patient had the smear done and it had pap smear too, you must continue taking the pap smears for those patients, the screening. And if the patient present after the age of 65, maybe at 70 or 80, first time, so you must check the pap smear. It doesn't matter that she's after the age of 65, you still check that patient. So these were some things which are like different in the latest guideline. They have rechecked and they have reassured in the American. In the UK practices, the main change is that you follow HPV now as the primary screening tool. Once the HPV guides you, it's positive, you go for pap smear. If pap smear says that there is CIN, you go for colposcopy. In case if HPV you're positive, pap smear is negative, you repeat it after 1 year. After 1 year, again, if HPV negative, washed out, routine testing every 3 yearly. But if again positive, you again go for pap smear. If in pap smear again you have any CIN, you go for colpo. So it's like a small chart. It's very simple, but you can download it on your mobile and follow that according to results, and it's not difficult at all. But it's become more easier with the HPV now. Screening tools, we already know we have the pap smear. Pap smear, the difference between now the liquid based and pap smear. We know that pap smear was the first one, very nice, everything, but later it was checked that with pap smear, most of the cells were lost. Whereas in liquid based, you take the sample with a rubber brush, just flow them in the liquid, and they're very nicely present. It's like you're finding a needle in the haystack. When you're looking in the haystack, you can't find, but when you look at the liquid base, you can easily see that needle. So definitely the difference is very clear in liquid based cytology. It is recommended. I think pap smear should be completely removed from here. Why? Reason is that in developing countries, they have no access, finance, everything. But alhamdulillah, Bahrain is a very nice developed country, and we have access to this very nicely. So I think all practices should be put aside, and we should try to do liquid-based cytology only. Going ahead, colposcopy is the next step. So once you have something, you have to go ahead with colposcopy. And colposcopy is unfortunately not present everywhere. It is present in the government places, government hospitals, and it is being practiced very nicely. But in private sector, it's rarely present, and it's not, I have seen that the hands are not very strong on this in most of the small centers. So we just need to educate. We should keep some, educational sessions for our doctors for colposcopy with the expert help of our seniors. Now, this we have already discussed. I have told you a little, and Dr. Huda has mentioned, you do the test HPV. If it's positive, you go for cytology. Again, if it's negative, you check it after 12 months. But if it's positive, you go for colposcopy. So it's the same pattern. Again, high risk positive, again go for cytology. Negative, again 1 year. If positive, then you go for colpo. 3 times, if HPV comes positive, then you go straight for colpo. 3 times, if HPV is positive, but cytology is negative, then you go straight for colposcopy. Okay, going back, we have discussed CIN 2, 3, we have already done that. As I mentioned, the terms which we use are still according to Bethesda system. The factors which increase the risk of transmission, I mentioned it before: smoking, increased parity, early age of intercourse, oral contraceptive pills, and immunity. So smoking will reduce the local cervical immunity. It has some carcinogenic effect, and those are released in the mucus of the cervix. So we have to understand that this is something which is directly causing the cancer. Multiple sexual partners, having a partner with multiple sexual partners. So your partner has multiple sexual partner. That is going to affect you as well. And if you have any other diseases like chlamydia, herpes, HIV, they are going to add to the factor of cervical cancer. So we'll go ahead to the vaccination, because I've discussed this, I've told everything, most of this. So one thing I want to know, so the outcome, finally, what happens if someone has CIN? What will happen? Either it will spontaneous regress. It will go back to its normal. So you don't have to scare the patients that, oh, you have CIN, you're going to get cancer, or it's going to turn into cancer. No, 70% of the times, 50% CIN1 will go back to its normal. Even the CIN2 will go back to its normal 27 to 30%. But you have to reassure them and take them in confidence that it is nothing scary now. And then you just have to be regular in follow-ups, because patient just needs to understand how important it is to follow. Coming back to, so it may progress to invasive cancer, it may progress from one stage to another. It takes years, so it may take 1 to 5 years or 5 to 10 years. And then detection and treatment of CIN prevents cancer cervix. So we have done the screening part, and we will go to the management has already been discussed by Dr. Huda. She mentioned about the LEAP, the LETS, and the further, if it's advanced or if it comes out to be cancer, then you will accordingly do the cancer management. But if it's, borderline, mild dysbiosis, moderate, in moderate and severe, it's straight away treatment. And if cancer is suspected, like you go for Colpo, you can see and treat, either do LETS there or LEAD or whatever, according to that patient. Colpo, we know what, because it's so much discussed before that I'm not going into details, but colposcopy is outpatient procedure. It is, you see the cervix at magnified view 5 to 20 times, and you can see all those tiny, changes and bigger views. So it gives you an idea of the changes. You can put acetic acid, you can put Lugol's iodine and see the changes, and then take a biopsy wherever you think there is a change of, the epithelium. Here you can see this area, and here, when you zoom in, how nicely the changes are apparent. So this is all about colposcopy. We'll go with the vaccination. As I discussed about vaccination, I've mentioned it all. So I'm sorry, I'm fast forwarding because it was already discussed in Dr. Huda's lecture. So I'm just trying to come to the main thing. So in HPV, we have already discussed in vaccine that there's 16 and 18. And then 31, 33, these are the high risk viruses. Now, what happens is that in most of the countries, you have bivalent, which is Cervarix, which is present in Bahrain. When it comes, it's present. It's from GlaxoSmith. And then the quadrivalent is Gardasil, and now the Gardasil 9 is the one which is being present. Now, 9, it is covering against the high-risk viruses, most of them, and the doses of both are, you can see here nicely, that the doses are 3 injections. So all bivalent, they say 3 injections, 3 injection 3, so 0, 1, and 6 months. But according to the research, they say that if you give them at early stage, between 8 to 12 years, then only 2 doses are more than enough to give a booster. As per the studies, they showed the booster response was very high, so you don't need to go for 3. But if the first dose was given after the 15 years, then you have to go for 3 injections. Similarly, at our age, even age, whatever age patient presents with, 30, 35, 40, those patients are supposed to get vaccination. There is one question usually patient ask me, that if I had a high risk virus, HPV 16 or 18, and after that I did my test again and it's gone now, can I get my vaccination done? So it's recommended, even if you had high risk virus, even it came positive, you are still supposed to get the vaccination done. Even if you have become immune to it because of the presence, you should, because only one virus was there. You have to protect against others. And we are still not sure about which virus can cause changes. 16, 18 are 70 times present, but other 30 times there could be other viruses as well. So in Bahrain, as I said, once I heard there was Gardasil, but I didn't see it myself. Cervix, I have been giving to patients. Some have been fully vaccinated, some with half because it got short last year, and since then it's out of stock. So I request, that if it could be included in the immunization program in Bahrain for the children who are getting their vaccinations from the age, school-going students, or if it can be included, any ways in the program, it would be much better than counseling every person, every mother separately. So as they said here, in Australia, because Australia and UK started early, so the response in there
Sorry
was...
for interruption, Dr.
Yes.
Maimouna. We are running out of time.
I'm finishing. This is my last slide. This is my last slide.
Great.
Don't worry. Thank you. So as you can see in Australia and UK, when they introduced, they had the high, robust, uptake of immunization. So a lot of coverage and, a lot of immunity was seen in them. Whereas in US, because it was started later, so, it had lesser coverage. So at the end, it's time for action. We just need to educate patients, and then act on it. So knowledge is power. We have to, look around, see the big picture. It's not only about one patient walking in my clinic. My aim is to think of all those patients who are present here in Bahrain. So if we can help all nationalities, all culture, everyone walking in, all the young girls, all the young boys, and even the old patients who present to us and they ask for vaccination. Only if we have the vaccination present, we can get control. And by a regular screening, I guess we can, be more motivated and help the patients. Thank you. And this is what we are looking forward with. If we are going to do intensive vaccination, how it goes down. This is the current situation. So by 20, earlier, I cannot see what, just 1 second. This is, by 2120. So after 100 years, maybe we will stay here only. But if we go intensive vaccination, this is what we will have. And if we go with intensive screening and vaccination, look, by 2060 where we are, we can eliminate by 2060 in coming 30 years. This is the WHO recent plan, what they've, preferred. Thank you so much. Let me know.
Thank you very much, Dr. Maimouna, for this informative presentation. And I'm sure your point is very valid that vaccination, if the vaccine is really available, as a free, maybe then we can achieve the aim of the WHO. Just to reassure you that colposcopy available in the private, maybe not your center, but I know many gynecologists, they have this
available.
As an office.
I was seeing the expertise.
Okay.
I was saying the expertise should be like, they should have more. It is available in privates, yes.
Yes, it's available in many hospitals.
Yes.
And yes, especially you see now a lot of HPV positive. I'm sure the colposcopy should be really a tool in any office, like an ultrasound.
Yes, yes.
Thank you very much, Maimouna. I don't think we have a time for a question. I probably leave it to the floor for Dr. Hatton. We receive a lot of questions, but I think we answered many of them about the positive, what if we have negative, and I'm sure they have the time later on to discuss those points with you. And it was very practical. Thank you, Maimouna.
Thank you.
Thank you, Dr. Khulud. Thank you, Dr. Maimouna, for your very nice, informative presentation. I just have one comment, which is suggesting to have an application like Be Aware, not only for coronavirus, but for all the challenging diseases and for all the diseases which are of high importance in our field in gynecology and obstetrics, and it can be it can cover all the branches of medicine so that all the population in an easy, simplified way, so that all like Osho, which is an Indian wise man who had a book of awareness called Awareness. It's moral and spiritual awareness, but we can have in addition medical awareness in not only moral or spiritual for all the diseases, and this will be a very high task for the Ministry of Health to do, and all doctors have to share according to their specialities in this application, so that it will be in hand to all the population to know what to do and what not to do, at least the basic steps to when to visit the doctor and when not to visit the doctor in a simplified, reassuring way to save the welfare and well health of our population. The cancer cervix is one of these topics which should be focused on, although Bahrain is for its proper religious restrictions and background in all our Islamic countries and all Arab countries, yet the challenge is there. So something like this, when it is handy within all the people, it will be very beneficial to them, and it will match with the theme of our conference, which is hope and a fruitful future for the whole population. Thank you, Dr. Maimouna, and thank you, Dr. Khulud. And we will move now to Dr. Karl Jalad from Lebanon, and he will address to us a very interesting topic. Is hi, Dr. Jalad, how are you?
Hello.
Welcome in our Congress.
Thank you for having me.
Is Dr. Karl Jalad is Assistant Professor of Gynecology and Pelvic Reconstructive Surgery, Lebanese American University Medical Center. And he will address to us one of the most important topics which we all face, which is the management of the lower urinary tract injuries. The floor is yours, Dr. Jalad.
Thank you for allowing me to present today. Given that I'm presenting from Lebanon and with the fear of connection issues, we pre-recorded the presentation just this morning and it's uploaded. So they will be running it as we speak, and I will be live also to answer all the questions. So I will allow the person in charge from the IT to run the presentation so we can proceed. I am waiting on my end. In case he cannot take over from there, I could then share the screen and go over the presentation myself. I will give him 5 more seconds, and if it doesn't work, we will take it over. So in the meantime, I just wanted to say that I decided to talk about this topic because this is a topic that all gynecologists hate to face, which is getting into injuries during surgery, be it with the bladder, the uterus, or the ureter. All those cases are a logistic nightmare, and it takes a very good team effort combining urology, general surgery, and urogynecology, and also oncologists to reach a good outcomes when this happens. Dr. Shawki, can you see my presentation well?
Yes, yes, just seeing well.
Okay. I will be presenting then from my end. It doesn't seem that he is uploading the presentation. So in case there's any shortage or cut, you let me know. So we will be talking about managing the lower urinary tract injuries. And the three types of cases we will talk about are the vesicovaginal, the ureterovaginal, and the vesicouterine fistula. The vesicovaginal fistula, I think, is the one everybody knows well. Those are usually happening in developed countries, and they're usually following pelvic surgeries. While in developing countries, usually complications arise from vaginal deliveries, and this nowadays is extremely rare, and I don't think you see this very often in Bahrain or any of the other countries where participants are logging in from today. So how does a patient present when coming with leakage of, with a fistula from the vagina? It usually presents with leakage of urine. But the leakage of urine is different than the I leak when I cough or I sneeze, or the urgency type of leakage. It's a continuous leakage of urine that happens during the day and during the night. It is important to ask about prior surgery, the weeks prior to the presentation, or in developing countries of very long prolonged labor, which I said we will not be discussing mainly today. A pelvic and vaginal exam is a must, and on pelvic and vaginal exam, usually you see pooling of fluid. You just see water in the vagina. Occasionally, if the fistula is very, very small and your speculum is lifting the vagina, you might miss the fistula. So in that case, you should be very cautious. A good thing to do is to backfill the bladder with methylene blue. And when you backfill the bladder with methylene blue, you end up seeing the blue passing through the vagina and showing up on your exam. Some would recommend cystoscopy, and it for sure helps with the diagnosis, especially if you have outpatient cystoscopy. But it's not an absolute necessary. You could just get an imaging or a CT scan. Now, why do you need a CT scan if you are sure that there's a fistula and it's clear? It's because of concomitant lesions. Up to 11% of patients presenting with a vesicovaginal fistula also have a fistula from the ureter to the vagina. So that shouldn't be missed, because if you miss it, then the management is very complex. And after you repair, you will still have leakage of urine. The complex fistula are fistula that involve either the trigone of the bladder, or that are close to the cervix or the urethra, or when you have a concomitant ureterovaginal fistula, or if you have a reduced bladder capacity. In all those cases, it makes it very complex. As you can see here, that little plastic thing is the Foley going in, and you can see that's a huge fistula. You don't see this usually from surgery. You see this from very prolonged labor and necrosis of the tissue. In that case, that's also a fistula. You'd see two Foley, one Foley going through the urethra and one Foley going through the opening of the fistula. The treatment for a vesicovaginal fistula, if small, obviously not like the ones you saw now, is prolonged catheterization. You put in a Foley and you wait, and you wait, and you wait, because you do not want to operate on a necrotic tissue or on infected tissue. That being said, after the phase that the tissue has healed, 6 to 8 weeks, usually if it hasn't healed, then probably moving to surgery is better, because the patient won't tolerate that Foley for too long. And those cases are litigious. The patient is not happy, there was a complication from surgery, and this can lead to bad consequences. So the surgery can be done transvaginal or abdominal. And if you're going abdominally, it can be done transvesical, meaning when you open the bladder completely, or extravesical, meaning you move the bladder and you repair. This, for example, is a fistula. Now the Foley here is not going into the urethra, it's going into the vagina, then into the bladder. And that is a way to stent the fistula and pull it towards you so you can dissect around it. First concept is to raise a flap, and that flap is anterior, and as if you're doing an anterior repair and you're raising just vaginal epithelium. The second flap is a posterior flap that's just under the fistulous tract. And then you've deepithelialized everything around the fistula. At this point, you could close that fistula immediately, or you could excise fully the fistulous tract. You don't have to excise the fistulous tract if it's a healthy tissue. After you've closed it, let's assume in a horizontal fashion, you then move on to put the flap in a vertical fashion. You don't want the suture lines to be opposing each other, and you do not want tension on those incision lines. So first there was a horizontal closure, then on top of it there was a vertical closure, and then you use the flaps that we have created to close posteriorly and another flap anteriorly. So you have 4 layers on top of that fistulous tract, which should be much more than enough to prevent breakdown of this fistula. Obviously, you keep the Foley catheter. Some would recommend doing a VCUG afterwards to test for the integrity. But if you've kept the Foley catheter for long enough and your repair was tension-free, the risk of a breakdown is very, very, very low. Some surgeons prefer going abdominally, and that's fine, but usually experienced surgeon who can operate well vaginally would prefer this approach. In case you do not have enough tissue or the fistula is too wide, then you might get a flap. One of those flaps, for example, is a Martius flap, and a Martius flap is used for vesico-vaginal fistula, but it's also used for urethrovaginal fistula, so fistula from the urethra to the vagina. And that flap is extremely helpful because you move a piece of healthy tissue from the labia, and then you move it behind the labia majora and use it to protect even more your incision line. So in this video, I'm going to be showing a Martius flap. This case was used actually not for a vesicovaginal fistula, but a fistula that was occurring in the rectovaginal plane. But the concept is the same. So you're putting your incision right on the labia majora, and after you perform that incision, you go after the fat pad. I assume you can see the video well. In case the connections, if there's any issue, kindly let me know. I can pause and go over the video more slowly. So here you can see we have mobilized the fat pad, and we are interrupting the blood supply of that fat anteriorly to move the pedicle posteriorly. You could alternatively interrupt the fat pad posteriorly and move it anteriorly, depending on whether your closure is down of the vagina or up. So now that we've interrupted that fat pad, we suture it because this is rich in blood supply. And we also tie the other end that has been left close to the inguinal area, because once it retracts, this can bleed and cause massive blood loss. Here, you are putting your Kelly clamp behind the labia, and you're pulling that fat pad or that Martius flap into the bed of your closure. And now you have your primary closure, secondary closure, third layer, and on top of all this, you are adding that fat pad, which will serve as a cushion. This is usually very helpful when you have a big defect, or when it's a recurrent fistula, or if it's a rectovaginal fistula, like the ones you see from breakdown of repairs after a 4th degree, and you want to avoid doing a colostomy. So it broke down once or twice. This is one shot before you feel that you're obligated to go for a colostomy. So then you're closing your incision in the same fashion you're closing it. The pad is on the inside. You do want some bleeding because you want the flap to be viable, and you want the flap to have some blood supply. After that, you pack. Obviously, you leave the Foley in place. And now we're going to go for the closure of the incision on the labia majora. Here, the first thing you're going to do is place a drain And after that, you close in 7 layers. This is immediately post-op. And here you can see this is at approximately 5 to 6 weeks post-op. And at 8 weeks post-op, I would challenge anyone to really know that there was a fistula or there was a flap that was made. You can see the incision, it's here, but with a bit of hair and with a bit of time, that incision won't be apparent and the patient will regain the fat in that area. So this concludes the vesicovaginal repair that's done vaginally. Of course, it can be done laparoscopically, via laparotomy, or via robotic surgery, but I wanted to give you an overview of vaginal access. A ureterovaginal fistula, on the other hand, is probably a worse nightmare for us gynecologists, because this fistula can require multiple surgeries and usually will require the involvement of other services and urologists and radiologists to be able to manage it. It could certainly affect kidneys in case of stenosis, and it could be isolated or associated with a vesicovaginal fistula, like we said earlier. On exam, you usually see pooling again, but if you backfill the bladder with methylene blue, you might not see the blue in the vagina. That's why you do what we say the double tampon test. And I'm assuming most of you are familiar with it, where we put a tampon in the vagina, have the patient take phenazopyridine. Phenazopyridine is different names in different countries, but it colors the urine orange, and then you backfill the bladder with blue. If your tampon has only orange on it, then the fistula comes from somewhere above the bladder. If your tampon is blue, then usually the fistula comes from the bladder. Now, of course, the orange would pass to the bladder and go to the tampon. It's mainly helpful if you only see orange. If you only see orange, then the fistula is above the bladder. Of course, you're going to chase that with a CT scan, cystoscopy in that case. Of course, if you have access to it, it's a good idea. Otherwise, you can do an IVP, or what's probably the best is a CT with delayed images that would give you the diagnosis to be able to plan your surgery. Now, here we have a CT scan showing the ureter on the patient's right side. And as you move down, you start seeing that fistulous tract is starting to appear, and it's appearing here, while you can see that this one is still intact. And now it has gone to the vagina and to the bladder. Most important is actually recognizing it intraoperatively. If you recognize the injury intraoperatively, it's always better because the management can be done immediately. And if it's not done immediately, at least you don't send the patient home and then realize days later that the abdomen's full of urine and that you've created a complicated setup. So treatment is to insert a stent if possible. Obviously, this is if you recognize that after surgery. If you recognize the intra-op, the best is to call a urologist or someone who's trained in reconstructing those and to go for an immediate repair. In the majority of cases, the repair has to be done abdominally. Some surgeons have done it vaginally, but that's for very specific cases. For surgical options, we're not going to go into the details of all those, but it is important to know that they exist. Put the ureter back to the ureter by removing the small part that has the defect. The reimplantation, ureteroneocystotomy, is a fancy word to say the ureter goes back to the bladder. The reimplantation with a psoas hitch is when you move the bladder up to the ureter because there was not enough space, or the ureter is too short, or the injury was too high, so you cannot reach the bladder. A Bowari flap is something I'll show you now, is when you are forced to transform the bladder into a flap to be able to get a longer tube. A transureterostomy is when you take that ureter, move into the other ureter, and an autotransplant is when you just remove the kidney and move it down. Happens with this type of case, and it is important to keep the stent afterwards and to monitor for 6 months to a year and constantly make sure that there's no stricture. If there's tension, this will not heal. This is a Bowari flap when you're taking a tongue-like shape cut on the bladder, moving it upward, making a tube out of it, and re-anastomosing it to the ureter. Here, the ureter, then you automatically affect both kidneys. And here I'm showing a robotic case where the repair is being done with a psoas hitch. So here we are on the patient's left side, and we are going after the ureter. We are trying to identify where the ureter is. We are on the medial leaf of the broad ligament. And here you have seen the ureter that's quite dilated because of the injury that has occurred. So the important thing is to mobilize the bladder. And for those of you who perform birch procedures, you are familiar with that space. Usually, if there are urologists in the crowd, they are usually familiar with that space too, because that's the space they go into to do the prostatectomies. So this is the on the side of the bladder dissection, you have the medial ligaments that you can clamp because sometimes they can bleed. So we've mobilized the bladder and we've entered the space of Retzius. As you can see, the bladder has now been mobilized and can reach the ureter, but it's still a bit tight. So you need to continue mobilizing the bladder and moving it even higher up. To do this, you go to the right side of the bladder and you continue dissecting, making sure you don't go too far, because then the right ureter and then we'll be in real trouble. Here, the bladder has finally reached the area you want it to reach, and you're going to tag it to the psoas muscle. Psoas muscle is familiar for the oncologists in the room over here. Psoas muscle is always covered with a nerve that you should avoid, and the most important thing is to tag that bladder solidly to the psoas muscle before you do anything. So this is the psoas hitch part of the reimplantation. The rest for a skilled urologist is to reimplant the ureter, and the reimplantation of the ureter starts by cutting into the ureter, which is something always freaky for any gynecologist. As you can see, the ureter is stented. So when you cut, you see the blue stent starting to appear. After you've performed your cut, then you can remove the stent and lay it on the side. Now you're going to be closing that stump, because this stump could have some backfilling of urine with time and cause problems. So you're just going to put the clip and permanently close it. With time, it will close and stop causing problems. Here, you're spatulating the ureter. So if the lumen is circular, you're just opening it so it becomes wider, so it doesn't cause a stricture. A good trick here is to keep the bladder filled with water. And the reason why is it helps with the dissection, and you will see as soon as you nick the bladder, you will know that you're in and water will come out. Again, not something us gynecologists like to see or do, but it's important to understand how it's done in order for us to get out of trouble when we get in trouble. Here, we are starting to put our stitches, and then the ureter will be spatulated into the top of the bladder. I'm keeping the video running because I was told we have 25 minutes. So if I do that, I think we will have enough time to go over the video. And now the most important thing is tension-free. You have 2 sutures on each side of the ureter, and that suture will run in a circular fashion and the other one in a circular fashion until the anastomosis has been completed. Then you reinforce that with the bladder closing on top. Sometimes you put omentum depending on the need for the case. This can be done laparoscopically by very skilled urologists. It's kind of complicated and needs a good assistant, or robotically, much easier, or of course, in an open fashion with a laparotomy. So the the fistula coming from the ureter to the vagina are rare, but do happen. I am sure in the crowd here, a lot of gynecologists at some point, if you're doing a lot of hysterectomy, if you're doing a lot of endometriosis, you at some point might be called or yourself have hit a ureter. In terms of obstetrics also, unfortunately, this happens sometimes. Diagnosing it intra-op is key. And if you don't diagnose it intra-op, early diagnosis post-op is crucial in order to avoid major complications. Now we're going into more rare fistula or complication, but I think it also comes occasionally in one's career, and it's important to know about it. This is the vesicouterine fistula, a fistula from the bladder to the uterus. And it represents 1 to 5% of the total number of fistula, and it's usually caused by a C-section. So the ones I've seen have been after 4 or 5 C-section, and I've seen one after an IUD insertion where this gynecologist inserted the IUD, did an ultrasound, realized that there was something wrong, pulled the IUD and just called it a day, and then afterwards the patient developed that fistula. It's called Yusuf syndrome because of cyclic hematuria, amenorrhea, and menorrhea, which means every month the patient at the time of period will have hematuria. And she will go from doctor to doctor until it shows up on some sort of imaging. It's very difficult to diagnose because of the difference in pressure between the bladder and the uterus. So it's not as obvious as a vesicovaginal fistula. When you put your speculum, you're going to see fluid. The ones I've seen, when I put my speculum, I saw nothing. And the CT scan initially were read as nothing. However, when I put a tampon and gave the patient oral phenazopyridine and backfilled the bladder with methylene blue and had the patient walk for 30 minutes, then I could see that there was a fistula. Now, cystoscopy in that case is probably needed. And CT scan is definitely needed to eliminate associated lesions, because at this point, you're not sure if it's coming from the ureter, the bladder, the uterus, or from where. And then hysterosalpingography has been discussed in many case reports, because by pushing pressure into the uterus, that could lead to extravasation of the contrast into the bladder and help you with the diagnosis. By doing this, you run the risk of infection, of course, so you must be ready to treat the patient in case she ends up truly having that fistula. So here is a CT scan of one of the last cases that I saw that had a vesicouterine fistula. Initially, the radiologist had read it as indentation of the bladder close to the incision line of the C-section, likely from prior, but they didn't read it as a fistula. Of course, after the case, they reviewed the images and were able to say, okay, we see what you mean. There is a small fistula that was happening here with some contrast showing in the vagina. Now, the treatment. Prolonged catheterization is always a good idea. And then you can try oral contraceptives. This will suppress the period, and you can do it for 3 months and hope that this would work. It does work sometimes. Now, some patients don't want this because they've been waiting and waiting and waiting, and they can't wait 3 more months with a Foley catheter. It's usually happening to a young lady who's in her 30s with 3 or 4 kids, and that's annoying. The surgical approach is abdominal, and the key is to separate the bladder from the uterus and then to suppress the period post-operatively. So here I'm showing a cystoscopy where you see the fistula first and you stent the fistula tract. So here you're going to see, there is the fistula, the indentation. It looks like a ureter. And we're going to put a stent in it. And the reason why you put the stent in it is because once you go up top laparoscopically, it will be easier to find that fistula. So that's the view laparoscopically. My colleague was holding the scope while I was doing the other part. And now I'm taking over here. And here we're using a harmonic scalpel going down to the bladder. And the reason why the harmonic is good, because once you hit that coil, it will make that noise. And here it's probably going to make the noise, but obviously there's no sound on this video. And now we've switched to scissors. And as you can see, we found the stent. And this is allowing us to completely mobilize the bladder from the uterus. And here we're pulling out the stent, and you can see the fairly large defect on the bladder. However, you all know that the bladder is very forgiving, so we don't worry too much about a defect on the bladder as long as we're far from the ureters. So the cystoscope was introduced at some point to make sure that we were far from the ureter. You close the bladder in 2 layers, 3 layers. 2 should be more than enough. The most important thing is to make sure that it's tightly closed, and delayed absorbable sutures or absorbable sutures like Vicryl is fine. Here we're backfilling the bladder after closing with 2 layers. And now we are closing the uterus. Some would say you should add a hysterectomy. You definitely can. However, if you're doing a hysterectomy, then you run the risk of the bladder incision close to the vaginal cuff incision and the risk of another fistula going from the vagina to the bladder. So it's not necessary to actually do that. You can just close the uterine incision. And at this point, usually the patient doesn't want kids anymore. Here, we're just mobilizing that little adhesion because it was pulling the bladder upward. This is totally unnecessary, but we added this because we thought that it was just pulling the bladder. Of course, this maneuver could end up causing another injury to the bladder. The most crucial part of the entire procedure, like any time you're repairing abdominally vesicovaginal fistula, to move the omentum and move it down and put it between the 2 layers. If the omentum is too small, then you can do a L incision in the omentum and move a tail and move it down and just tag it, put it down there. This will help with the recovery. Post-op, you keep the Foley catheter in, you suppress the patient without period for 2 to 3 months, and then the catheter, of course, is removed after 10 to 14 days at most, and then the patients usually do extremely well. So if we want to conclude, whenever you're dealing with a post-op likely complication involving the bladder, the ureter, or the uterus, the double tampon test is crucial. Any gynecologist I would recommend keeps 1 or 2 tampons in the clinic with a small dye, blue, indigo carmine, or anything of the sort. I keep the peridium in my clinics also, and then order a CT scan to rule out concomitant lesions. Close in multiple layers and tension-free, and use flaps if need be. And I would actually add one more thing. This is a good place where you want to bring in some colleagues, and usually older skilled or younger skilled or whomever is skilled in the department, another colleague, another gynecologist, a urologist. This way you have a team of people doing their best to help the patient. And of course, if this goes into a litigious case, then you have every argument to say that you've done your best to help that patient. I would love to answer all your questions, and I hope we would never be discussing a real case, because those are, as I said, the nightmare of every gynecologist.
Thank you, Dr. Karp, for your very nice, interesting presentation, which is really a nightmare for all gynecologists. And thank you for stating Professor Youssef. He is one of the eminent professors in Cairo University, Dr. Abdel Fattah Youssef, and in the 60s and 70s. And one day he was one of my senior professors. And thank you for this interesting, and for the questions. Actually, the question is mine, which is the why you did not mention the injuries of, so long that your topic is urinary tract injuries, the injuries of the urethra, which is common in the common operation, which is the anterior repair. So is there a place for injuries of the bladder and the urethra in this common operation?
Yes, so actually, I do have a presentation on that, and I usually part of this presentation, but they said the limit would be 25 to 30 minutes, so I have to remove that part. The destroyed urethra is the title of that presentation. Usually the urethra, by majority of the cases, get destroyed from slings. So a TOT sling outside in, sometimes the mesh comes and destroys the urethra, and it's not diagnosed because cystoscopy is not done routinely. I would recommend routine cystoscopy with TOT and TVT. TVT less injury to the urethra because you're placing your sling while watching for the urethra. The second way this is injured is unrecognized diverticulum. An unrecognized diverticulum sometimes gets nicked or injured, especially during an anterior repair that's confused for a prolapse, but it's actually a diverticulum, and the person goes straight into it. Or if a TOT or a TVT is placed along with a urethral diverticulum. It's fairly rare to injure the urethra during a pure anterior repair, unless that person's going up and doing what we say the Kelly plication and being a bit aggressive. But for sure, it can be injured. Key is diagnosing it and recognizing it and closing on top of the Foley with several layers, 3 or 4 O-Vicryl, and keeping it tension-free. In case the injury is too wide, then a flap from nearby tissue is needed. And if it's really too wide, then a March's flap would be necessary. But this, if recognized intra-op, could be repaired extremely well without any consequence because it's below the bladder neck. So the patient should be able to maintain continence and not become incontinent.
Thank you very much. Thank you very much. I'll give the floor now to Dr. Khulud for the coming speaker.
Thank you, Dr. Hatem. The coming speaker is Dr. Fadila. I'm pleased to present to you today Dr. Fadila, a friend and colleague. We work together in Salmania, and a very senior doctor in gynae, urogynae. And I'm sure we learn a lot today from her presentation. She works currently in Al-Kindi Specialized Hospital. And today she's going to talk about the update in management of a typical apical vault prolapse. Did I say it right, Fadila?
Yeah, apical vault. Thank you very much. Thank you, Dr. Hatem. Thank you, Dr. Khulud. I'm really glad to see you all. Although we are seeing each other through the Zoom, but it is better than not to see anybody. Thank you really for giving me this opportunity to have my talk today. I will start sharing my presentation. Everybody seeing the screen?
Yes, clear.
Okay. So I'm going to talk about the update in the management of apical prolapse. First of all, we will talk about the definition of apical prolapse.
Can you raise your voice? I don't think it's clear.
It's not clear.
Maybe you can increase the volume, Fadila.
Yeah, I will try to do it, sorry. And how is it now? Is it the volume is okay or? I'm trying to go to the. You can hear me now or?
Yes, yes.
Okay, I will go back to my slide, the definition slide. I'm going to just define the apical prolapse according to the ICS and IOGA. Apical prolapse is defined as a descent of the cervix or the vaginal cuff after total hysterectomy, in which it will be displaced from its original site. And usually it is very rare that we see isolated apical prolapse. And if we have anterior wall protruding beyond the hymen, usually the vault of the vagina or the cervix will be displaced as well with it, okay? In these two photos, you can see the vault prolapse after vaginal hysterectomy, and this is the cervical prolapse through the vagina. To know the epidemiology, it is really difficult to determine the prevalence of apical prolapse in the woman because many women they don't seek medical care for such a problem, and they found most of the women, more than 60% of the PRS women will have some defect in the vaginal compartment during the routine vaginal examination incidentally, and the incidence of having vaginal surgery for pelvic organ prolapse repair, it is 12.6% the lifetime for all the women. And there is some limited data which suggests that the prolapse usually progress until the menopause, and then the progression will be less, and then regression will happen later on. The support of the vaginal apex is very important, because if there is defect in the vaginal apex support, this will lead to the vaginal apex prolapse, the continuity, the strength, the integrity of the uterosacral and cardinal ligament, the continuity of the fascia, the endopelvic fascia, and the strength of levator ani, and the intact and neuromuscular connection. All of these, it is an important issues for the support of the vaginal apex. Here we can see this is the cervix, this is the level 1, level 2, and the level 3. The cervix usually supported by the cardinal and the uterosacral ligaments. And here we can see that if there is any defect of the uterosacral and cardinal ligament, there will be a uterovaginal prolapse or voltoprolapse with the enterocele. What is the risk factor for apical prolapse? Why some people they will have apical prolapse? According to the American College survey, they found that the Hispanic race, the Latin American race, and the white people, they have more risk of developing apical prolapse. Multiparity, it is a risk. Vaginal delivery, it has a big impact on the integrity of the ligament and fascia with the muscles. Obesity, chronic cough, constipation, advancing maternal age, weakness of the levator ani or avulsion of the levator ani, and if we have advanced prolapse stage, like grade 3 cystocele and rectocele, usually the apical prolapse will be in between. If there is family history of pelvic organ prolapse, which is usually due to weakness in the connective tissue, or if they have connective tissue disorder, this is a common presentation in patient who doesn't have other risk factor. Like sometimes we see in the clinic, young people, even nullipara, and they have vaginal or any compartment of the vagina prolapse, which means that they may have some family congenital connective tissue disorder. Hysterectomy, it is an insult for the vaginal support. And if patients have hysterectomy, either for prolapse or for any benign condition, there will be a risk of having apical prolapse. Management of apical prolapse, it is very important that we have to identify the risk, and we have to know even to patients. Most of the patients, they will not come with clear symptoms of vaginal prolapse. Some of them, they will come with a symptom of protruded mass through the vagina. And some people, they will complain that this mass, as you know, that it is a dynamic situation. They will complain that this mass is coming with standing, prolonged standing, or walking, or even with exercises. And when they lie down, it will be completely disappear. Some they will come with a pelvic pressure, sensation of vaginal bulge, low back pain, backache because of pulling on the uterosacral ligament, voiding dysfunction, incontinence, hesitancy, retention. It is common with the apical prolapse, defecatory dysfunction like incomplete rectal emptying, splinting, and it is common when it is associated with rectocele, and usually it will have an adverse effect on the sexual life, on the body image, and the quality of life. So it is very important to address the risk factor for apical prolapse. We have to go into details in the obstetric history, number of deliveries, mode of delivery, size of the fetus, because a risk of recurrence is always there. So the patient should know that even if we do a surgery for a pelvic organ prolapse, they may have a recurrence, and past medical and surgical history is very important, and family history to identify the risk of a prolapse. Abdominal and physical examination. Some patients, we have to ask them to stand in order to see, because when they lie down, it will go backward, the prolapse. So in the clinic, it is very important to examine the patient vagina, anterior, middle, and posterior compartment. The examination should be done by a single blade in which you can cover the other compartment. For example, some patients, they come and with a referral from other colleagues that patient have a cystocele, and when I examined her, I found that she's having apical prolapse. So using a single blade is very important to push the other part of the vaginal compartment. We have to look for any occult incontinence, especially with the apical prolapse. So it is very important to evaluate the patient for this issue by asking the patient to have the cuffing stress test, and sometimes we need to do the urodynamic study by reducing the prolapse part and doing the urodynamic study, examining the pelvic floor muscle tone, levator ini, and usually we score it from 0 to 5, the strength, and to follow the Baden-Walker or the POPIQ system is recommended during vaginal examination for pelvic organ prolapse. Here, the Baden-Walker, I think everybody knows how to examine the vaginal prolapse. If there is descent greater than 1 centimeter above the hymen, this is a grade 1. If it is 1 centimeter or less, it will be the grade 2, and 3, it is exceeding the hymen. And this is the other Baden-Walker, and here the POPIQ classification, which is a little bit more complicated. In some places, they recommend this as a routine, but I found it is difficult. I usually follow the Baden-Walker, but for a research purpose, maybe people can follow the POPIQ classification. The conservative management for apical prolapse is very important. The non-surgical option should be discussed with the patient if appropriate, and by modifying the risk factor like obesity. They found that obesity, it has a negative impact on the pelvic floor integrity. And even in some literature, they found that patients who do, especially the abdominal fat accumulation, those who did abdominoplasty or liposuction, it will improve the incontinence and the vaginal prolapse. Constipation and chronic cough should be corrected. Pelvic floor exercise, it is very important. Especially if we have an early stage of pelvic apical prolapse, like the stage 1 or 2, and the vaginal pessary is an important option as a conservative management for apical prolapse. You know that the idea of vaginal pessary, it is very, very old story since the 350 BC years, and when they used the half of a pomegranate dip in vinegar and they kept it in the vagina in order to block the prolapse part. And this, the vaginal pessary underwent many changes and revolution. and the one which is considered for apical prolapse is usually the ring pessary and the gel horn. So it is a good alternative for a patient who have vaginal apical prolapse, especially for those who wish to maintain the fertility during pregnancy. It is very important. Women who have vaginal prolapse, they can use the vaginal ring pessary, which is really relieving the pelvic heaviness with the pregnancy. Even after delivery, we can use it. It is a good option for all stage of prolapse. It even prevent the progression of the prolapse, and we can use it in a patient who have decubitus ulcer, complete procedentia, decubitus ulcer. So we returned for a few weeks by the time we prepare the vaginal tissue for surgery. And of course, it is a good option for old ladies who are not fit for surgery, any type of surgery. The common pessary which is used for apical prolapse is the ring pessary. And the other type is the gel horn when we have an advanced stage of apical prolapse. The donut usually used for the posterior defect, and usually we fit it between the symphysis pubis and the posterior fornix, and we should keep at least 1 finger breadth below the ring when the patient is bearing down, and this will be the proper position for application. To have a successful vaginal pessary application, we should know which type of pessary to use for each compartment, as I mentioned earlier. Like for anterior and apical, we have to use the ring pessary. Posterior, we should use the donut. For the advanced stage, we use the gel horn. We should have an adequate vaginal capacity and narrow pubic arch and good pelvic floor strength. Usually the failure will happen because of short vagina. There is no space to keep the pessary, or if we have wide vaginal introitus, more than 4 fingers. And even in post-hysterectomy, usually the vagina will be short. And it should be avoided in patients with dementia who they cannot take care of this ring, and they need close follow-up, and even with patients of pelvic pain, who have pelvic pain. Vaginal pessary, it is a simple procedure. We can do it in the clinic, but it may harm the patient if we didn't do it in a proper way, and if we didn't instruct the patient about the care of post-application care. So common problem with the vaginal pessary is the discharge, irritation, odor, and even sometimes ulceration. We have seen fistula. It could be zygovaginal fistula. It could be a cause by the ring pessary, bleeding, pain also, it is common, and they found that bacterial vaginosis is a common infection in patients who have vaginal pessaries, especially those who they don't change it, I mean neglected cases, the neglected vaginal pessary. In case of erosion, usually we remove the ring pessary for 2 to 4 weeks, and we apply the local estrogen therapy, and then patient usually they have to remove it. I mean, when we apply the ring pessary in the clinic, we should advise the patient to remove it every 3 to 4 months if she's capable to do it at home, or they have to come to the clinic for checkup and reapplication. The other, if we decided after we have followed, I mean, the conservative management of, if the conservative management failed in apical prolapse, then we have to take the patient for surgery. Evaluating and counseling the patient before surgery is very, very important, especially for patients who have previous surgery. So it is very important to evaluate the patient, and if indicated for symptomatic, of course, surgery will be indicated for symptomatic prolapse, or when the conservative treatment being failed. Before surgery, it is very important to evaluate the patient, as I mentioned earlier, to assess the presence of other defects associated with the apical prolapse. Urinary and defecatory symptoms should be evaluated as well, and the risk of recurrence or persistent symptoms should be discussed with the patient. And even in some cases, after repairing the apical prolapse, there will be a de novo stress urinary incontinence. All of these should be discussed with the patient before surgery in the clinic. And the surgical option, it's very important to know the capability of the surgeon. If there, and you know that the vaginal surgery, it went through many revolution and change in the last decades. They have used, we use a lot of mesh, and this mesh being stopped and been advised to use the biological. And again, we went to the native tissue for correcting the vaginal apical prolapse and other vaginal wall defect. Unfortunately, in April 2019, the FDA ordered to stop the mesh, the pelvic organ TVM, the transvaginal mesh, which we use it for pelvic organ prolapse. And since that day, we are not using the mesh, and this mesh for even in Bahrain, even the sling mesh, it's been stopped by the NHRA. The surgical options, as I mentioned, it depends on the surgeon experience, on the patient age, if there is comorbidities, if there is any previous surgery for pelvic organ or prolapse, and even her sexual life. So what is the option of apical prolapse? Are we going to take the patient for reconstructive or obliterative surgery? What is the route we are able to do? Is it vaginal or abdominal route, to use the mesh or not to use? And if we have to do hysterectomy or not? And what about the fertility after apical prolapse surgery? So the obliterative or reconstructed, the candidate for obliterative colpoclesis, those who failed the conservative and or they didn't have any satisfactory result, usually we do it for patients who are old age, which they cannot tolerate prolonged surgery or have comorbidities. If we have a massive prolapse, like a grade 3 or 4, and those who doesn't have any plan for future intercourse and of course surgery, will improve their quality of life. The colpoclesis history, it is very, very old technique. It passed through many changes since the 18th century, but it's still the place of colpoclesis. It is present in even nowadays, and especially with the aging population and the advice to use the native tissue. I think it will be a good option for patients, and I have done for several patients with a good result. Colpoclesis, it is a rescue operation, of course, because we used to do it for patients who have 80 years and above with a complication of the long-standing prolapse, and it is anatomically distorting. We don't conserve the anatomy, and we close the central urogenital hiatus. There is some degree of vaginectomy, and it can be combined with additional procedure, like patient have a stress urinary incontinence and perineuraphy. There is two types of colpoclesis. It is either partial, when we have the uterus present, and total when for a hysterectomized patient with vaginal vault prolapse. The partial colpoclesis by creating a new vaginal epithelium excision, and it is completing. I can show you some diagrams here. We have to remove a rectangular incision from the anterior and posterior vaginal wall, and then by Barnes string suture or continuous suture, we push the cervix inside and close it. It will end up with this, and then we will have a 3 to 4 centimeter vaginal depth and finish. And it is usually short procedure. It will take even an expert hand 15 minutes to do it. So the duration of operation, it will be less. And the total colpocesis, we do it for vaginal vault prolapse with a hysterectomized patient. And we will excise the whole epithelium. And then we will do the same things, Barnes string sutures, and this will be pushed inside and inside, and it will be end up with, sometimes we can do even perineuraphy for the patient. And some they advise to do cystoscopy, but it is not mandatory. The advantage of colpocesis, it can be done under local anesthesia. So the risk of general anesthesia for the old age will be eliminated, or in general anesthesia, it is a short operation duration. It has less risk, preoperative morbidity, post-op, and even the risk of recurrence is low. And there will not be change in the body image, and the regression, they found it is less than 10% in some studies. The disadvantage that it is eliminate of the potential of vaginal intercourse. So it is very important to choose patient selection is very important for the old age. We can do it without any problem. And if the problem, if we have the uterus, that we will not be able to evaluate the cervix and the uterus through vagina because it will be pushed inside. This is the colpocesis. The other reconstructive surgery, the goal of reconstructive surgery is to restore the function. We have to restore the anatomy as well, and we should relieve the symptoms and avoid the recurrence of the symptoms. The vaginal root surgeries, which is very common, is the sacrospinous fixation, or the iliococcygeus ligament suspension, or the high uterosacral ligament suspension, Manchester repair, and vaginal hysterectomy with the McColl coloplasty. Sacrospinous fixation, it is an old technique. This is the history since 1968, and it went under many changes. And the anatomy of the sacrospinous ligament is very important to know that here the sacrospinous, it is an extraperitoneal structure. It is related to the coccygeus muscle, and it is extended from the sacral bone to the ischial spine. It is a triangle-like structure. The length is 6 to 7 centimeter, and the width of this in one part, which is attaching to the sacral bone, is 3, and the ischial spine is 1.5. I will just go through the technique, important structure. There is the internal pudendal artery and nerve, which is very important to know. This anatomy, because during surgery, there is a complication of injury. The sacrospinous ligament, we do it by opening the anterior vaginal, or you can approach it through the anterior or posterior vaginal wall. And then we go to the rectovaginal space, then the pararectal space, and then fixing, usually we palpate the ischial spine as in the deliveries. You can feel the ischial spine. And then we have to keep 2-finger breath from the ischial spine, and we can take the stitch here and fix it to the vaginal vault. It could be done bilateral or unilateral attachment, but the latest they found the studies that it will not change the chance of recurrence if we do it unilateral fixation. The outcome, there is also a modified Michigan, which is 4-wall sacrospinous axis fixation through the anterior and posterior vaginal wall, and it has a success rate of 90%, as in this study, and it is a good procedure as it have less risk of recurrence of apical prolapse. But if we go to the posterior compartment approach, then risk of cystocele will be always present, and it has an early recovery, and it is very effective procedure for correcting vault prolapse. The complication is hemorrhage, as I mentioned, the pudendal nerve. So there may be, we injure the pudendal nerve artery, and there will be a hemorrhage. We are close to the structure, bladder and rectum, but this is very rare to happen, because if you are used to do it, I don't think you will end up with a damage. Some they will have, because of the pudendal nerve irritation and some gluteal pain, which indicate that a pudendal nerve injury, but usually it will be self-limiting, and it will be corrected after a few months. Overactive bladder symptoms may be happen, and incontinence, cystocele, because of the unilaterality of the fixation, some patients will develop dyspareunia. So according to the Royal College recommendation 2017, it is very good procedure. We can advise it for elderly and people who are elderly patient with sexual activity is not important. And sacrospinous fixation should be considered when we have a vault prolapse, and especially when it is exceeding the hymen level, like stage 3, 4, after removing a hysteroscope, after vaginal hysterectomy. It is a short procedure, so it is even for elder patient with a comorbidity, and it has a high success rate. I'm trying to be fast, not to pass the timing. The other procedure is the ileococcygeus, in which we fix the vaginal vault to the pectineal line over the, it is originate from the arcus tendinous ani and inserted into the coccygeal raphe and the coccyx. This is the anatomy. Here we can see the ileococcygeus muscle clearly in this figure. And after removing the uterus, we can, or even we open the vaginal vault and we fix it to the ileococcygeus muscle. It is bilateral procedure from both sides, and we can approach it either anterior or through a posterior vaginal incision. It is a good procedure for sexually active people because it will maintain the vaginal length, and it will reduce the risk of pudendal nerve injury, but it has a complication that recurrence is higher if we compare it to the sacrospinous fixation, and post-operative cystocele, bleeding and pain is present also, so it is not recommended routinely. The other technique is the uterosacral suspension by bilateral. It is a bilateral procedure in which we can approach it vaginally, abdominally, or by laparoscope. We suspend the uterosacral ligament. We have here the uterosacral ligament. We attach it with stitches, and
الحين طلبوا منا كل يوم نسوي رابط تيست.
We attach it. We attach the uterosacral ligament suspended by 2 to 3 delay absorbable suture, and this through the mid portion of the uterosacral ligament. We have to go to the middle part, not to the lower part. Maybe people who do macrocolpoplasty, they know this technique. And the distal portion of the uterosacral ligament are plicated across the middle and the 3 permanent suture in the anterior and posterior part of the vagina. We will end up with this figure. And usually we have to do in this technique the cystoscopy because risk of entangling or closure of the ureter will be there. So it is the risk of ureteric occlusion in the disadvantage of the uterosacral ligament. It is 2.4 to 11. Bowel injury is less, suture erosion if we use non-absorbable sutures, hemorrhage and sciatic nerve, which is usually self-limiting. And as I mentioned, cystoscopy is important. The Manchester repair, you know, this is an older procedure which been invented by Dr. Archibald in 1918th century in Manchester, England. And then it's been modified by the Father Gell, and he reported the procedure. Usually we do it if we have cervical elongation of the cervical elongation of the cervix, which are protruding outside. And for young women who wish to maintain their reproductive capacity, it can be done for uterine prolapse for stage 2 and 3 who prefer to conserve their uterus, because many patients during vaginal surgery, they prefer, even if the uterus is coming down, and we advise them, and you will see they will be roaming from one doctor to another in order to find this option to preserve the uterus. So it is a good option and good indication for preserving the uterus by using the Manchester technique. It is started, the technique usually, we have to do a diagnostic curettage before the procedure. We clamp both the cardinal and uterosacral ligament, amputate the cervix, then attach them to the level of the internal isthmus of the cervix. We can do it end-to-end or overlapping. It will not change. And then we cover the cervical stump with the vaginal mucosa. It is an easy technique. Risk of recurrence is very low. In some literature, it is less than 1%. And there is a chance for a woman to get pregnant. And it is a short operation. It has a good post-operative recovery. And we can preserve the uterus, but there is a theoretical risk of a premature delivery. So we have to explain that to the patient, and maybe she will need to have a cerclage. It will help her to maintain her pregnancy. The disadvantage of uterine preservation surgery is that a risk of adenocarcinoma or any uterine pathology will be there, especially for patients who are menopause. This is very important issue. We have to counsel them during consultation because adenocarcinoma, it can happen, and her risk will be like other population risk. In some study, they found that there will be a retained blood filled or even early stage of fallopian cancer, or even retained corpus with the mucoid material inside the uterus. The fourth technique, which is very popular, is the McCall coldoplasty. I think everybody's doing vaginal surgery. They know this technique because it is very, very old technique, and it's been used for supporting the vaginal vault after hysterectomy. Usually we hold the uterosacral ligament, which is the main support here, by a suture, absorbable suture, and then we fix it to the vaginal vault, and we push it inside so the vault will be supported. It is used as a preventive measure for after hysterectomy, either abdominal or vaginal route, or even for correction of vaginal vault prolapse. There will be ureteric obstruction, urinary retention, abdominal bleeding, postoperative dyspareunia, which is not significant, this complication. The last technique is the sacrocolpopexy, which is first described in the 1957. Usually we can do it with the presence of the uterus. We call it sacral hysteropexy, or sacral colpopexy for the prolapse vault, or sacral cervicopexy for the patient who has subtotal hysterectomy with a prolapse cervix. And it is very good procedure for correcting vaginal vault prolapse, and it has a high success rate. It reaches up to 100. As I mentioned, we can do it sacral colpopexy. It can be done abdominal, laparotomy, laparoscopy, or robotic, which is usually for research purpose, because it will be very, very expensive. The indication of the laparoscopic sacrocolpopexy, usually we used to do this technique for young patients less than 65 or even in their reproductive age, who are medically fit for surgery. They don't have contraindication of laparoscopy, or they don't have morbid obesity, which really interfere the laparoscopic surgeons, and sexually active people. And the technique starts by opening the peritoneum, exposing the middle sacral artery and nerve. And here we have the longitudinal ligament of the sacrum, and we go by a suture beneath that, holding and fixing the mesh to the sacral promontory. And if we have a uterus, like in this case, we fix it to the uterus, and then we close all over with the peritoneum. The complication, there will be a chance of a bleeding, aortic, because we have a main branch of aorta and the internal iliac, which is close to the sacral promontory. Ureteric injury is common also. Rectal injury and vesical injury can happen, but usually this is an advanced laparoscopic surgery procedure. So people who do this, they must have a good experience, and I think the risk of complication will be minimal. Post-operative complication, hemorrhage, occlusive syndrome, urinary infection, mesh erosion, spondylosis, because we are close to the periosteum of the sacral promontory, urinary incontinence, constipation, and dyspareunia, especially for those who have vault prolapse. So the question we are asking, which route is the best to treat vaginal vault prolapse? Laparoscopy is a gold standard treatment for treating a vault prolapse or even cervical prolapse, but it has a long learning curve, and there will be a problem of using the mesh, a complication of mesh. And usually both routes, the vaginal and laparoscopic route, it have a good outcome. And usually it is a short recovery, even the vaginal route in expert people. It has a good recovery, and the result will be, the outcome will be very good. So both, it can be a good route for treating vaginal apex prolapse, but experience is very important. Whether to use mesh or not to use mesh, this is very debatable issue, which been through many debates and discussion. And even here in Bahrain, we have discussed a lot with the NHRA in order to get an access for some kind of mesh. But the problem, the whole companies being suspended, and they stop bringing mesh to Bahrain, so we stop using mesh. Although for a long period I have used it personally, and I found it has a good outcome. And I think the result, we should tailor it according to the population and race. And maybe in Europe and America, they have a lot of complications, but in our region, we got a very good result, and even the complication erosion, it is manageable, and we could manage it without any problem. According to the NICE guideline, they have addressed that vaginal mesh use should be only used in the context of research, and the high complication should be discussed to the patient. And the AGIS and IOGA, they said that we have to recognize that any surgical intervention is associated with risk. All of us, we know, if we use any mesh, even for the abdominal wall, they use it in the hernia, there will be a mesh of erosion. But we have to know that mesh itself, it has its own complication, and we should be able to deal with this complication. Whether to do hysterectomy or not, they found that we said that patients with hysterectomy, either for prolapse or for other pathology, they will have a risk of developing apical prolapse. So uterine preservation did not affect the risk of pelvic organ prolapse recurrence if we keep it or remove it according to the guideline, but there will be an increased risk of pelvic neuropathy and disruption of the natural support in some studies. And they found that for sacral colpopexy laparoscopic, if we have the uterus and use it and using the mesh, so risk of erosion will be less. And they found that that hysterectomized women, they will have a 5% risk of developing a prolapse in the next 15 years. And again, in some study, there is no increase of pelvic organ prolapse. It is a conflict. There is a conflict result from some studies and from the guideline. So I think the surgeon, they should tailor the management according to patient after discussing the patient risk of recurrence of surgery. But I mean, if the patient have already vaginal, I mean, the whole uterus is outside, my experience, I found that it is difficult to support a prolapse uterus through vaginal suspension. Maybe the laparoscopic colpopexy, it will be a good option if patient choose to keep the uterus or to go for Manchester repair. Is hysterectomy eliminate current, future cervical or intrauterine pathology? Yes, I can say yes. Of course, if we remove the uterus, we will not have, they have multiple study here that showed that in some patients, the risk is minimal if we keep the uterus, the anticipated malignancy or uterine pathology. And there is only 0.3% who have endometrial carcinoma, and especially for those patients who have menopause. So all of these issues should be discussed and should be counseled with the patient. Whether the fertility will be preserved after pelvic organ prolapse surgery, when we keep the uterus, in some studies, they found that it is, they have a successful cases after sacrospinous hysteropexy. Almost 1/3 of this study, they got pregnant, and even in other study in 2011, they have after sacral hysteropexy. So I would like to end up my presentation with the recommendation of the Royal College that vaginal focus, they focus on the vaginal pessary. It is a good alternative option for treating patients who have a vaginal vault prolapse. Post-hysterectomy, vaginal vault prolapse surgery should be performed by a subspecialized urogynecologist or gynecologist who have demonstrated equal level of training or experience. Colpoclesis is a safe and effective procedure, and I think it will have a more place in the current or the modern surgery because of the aging population. Laparoscopic sacral colpopexy and sacrospinous fixation, it is an effective treatment for primary post-hysterectomy vaginal prolapse. Macoldoplasty, it is an effective procedure as well. Laparoscopy have laparoscopic sacrocolpopexy and it has the same effectiveness. So if we have a good experience in the vaginal surgery, we can do it vaginally. Subtotal hysterectomy is not recommended for preventing post-hysterectomy vaginal prolapse, and high uterosacral ligament suspension should be offered, should not be offered actually in the, as a first line of management of vaginal vault prolapse. And the mesh used, it's been stopped, the TBM, and older technique, it will come by using native tissue. This is the last slide. Thank you very much. And if you have any questions.
Thank you very much, Fadila, for this informative and evidence-based. And really, I enjoy your slides. And you kept it really simple or complicated. And I know you are the expert with this subject, and I'm sure many will have probably question, but I don't see any question here, probably because you covered plenty of things and really in your slide. I hope you are enjoying the program so far, and I really need your attention and probably not hypoglycemic, because we really have very intensive program. Hatem, they didn't leave me a chance even to have a rest to prepare or to see even my slide for the next presentation. I hope I will still have energy really to continue.
Inshallah, we will have Dr. Khulud Al-Darazi, consultant Obs and Gyne and IVF at Khulud Al-Darazi General Darazi Center. She will address to us 2 lectures. The first lecture, 2 consecutive lectures. The first lecture is endometrial hyperplasia in sub-fertile women. And the second lecture will be management of menstrual irregularities. So always the dessert is at the end. Even if we are hypoglycemic, we can have a good dose of more informative and interesting presentations from Dr. Khulud. The floor is yours.
Thank you, Hatem, for the introduction. And it's really, I have to say, I'm really impressed, because you managed really to gather all of those busy gynecologists. And I thought when I received the invitation, it's like last minute, but really I was so happy that this is happening, and it's really my honor to be with you today and to present. I'm presenting endometrial hyperplasia in subfertile women. It's a study probably this was the last thing I did in Salmania before leaving, but we were so busy. I was so busy in the private, and I really didn't have chance really to look. But thank you very much, Hatem. I managed really this time to just put those data together and present them. So I hope you all enjoy it. I'll start by a little bit of background about the study and methodology we use, result, and then maybe we can share the conclusion. PCOS is the most common cause of subfertility among Bahraini women, based on a study done in Salmania. And we know very well that chronic anovulation is one of the major features of the syndrome, and considered to be one of the criteria used for the diagnosis of PCOS. And they found that the endometrial hyperplasia is more risky for young PCOS than non-PCOS. So they have more risk to develop carcinoma, endometrial carcinoma. And I'm sure all know that endometrial hyperplasia is a precursor of endometrial cancer, and long-term risk for progression is in simple, but now they call it only endometrial hyperplasia by WHO, less than 5. But when you have a tibia, your chances to develop endometrial cancer probably will be around 30%. My interest started really when we start having patients and they fail their cycle, and we do hysteroscopy for IVF, Hatem, and then you do the endometrial biopsy, and then you see this hyperplasia. I wasn't knowing what is really, how significant it is among our population. So we thought we will do this study. And PCOS, I was thinking it's a risky group because it's of all the metabolic and the hormonal changes take place with the PCOS population. And this is namely the insulin resistance, which we know how it's really interfere with everything in liver by decreasing the sex hormone binding globulin, decreasing sex hormone binding globulin, which release the androgen and of course the estrogen as well. And if we remember that the PCO obesity is quite prevalent as well in the polycystic ovarian disease, we know how risky is obesity as well in releasing as well estrogen in the circulation by peripheral aromatization. So everything is around with the insulin resistant is increasing the androgen as well, the estrogen. With decrease of sex hormone binding globulin, it will release as well IGF, and now we know that the IGF and the androgen will affect as well the endometrium. And the chronic anovulation, which is classically believed that endometrial hyperplasia with unopposed estrogen by lack of progesterone, then this will give you risk of endometrial hyperplasia. This is another slide showing you same whatever what already I said, and then you know this that it will increase the androgen, affecting the affecting insulin resistance, will encourage more androgen in the theca cell, and it will release androstenedione, and we know that this androstenedione is the one which will lead to more proliferation in the, if you say it, if you like, to in the endometrium. So high level of androgen, which could induce the insulin resistance in the endometrium, and then combined by the abnormal insulin and insulin receptor signaling in the PCOS with hyperinsulinemia, and as well down regulation of the facilitated glucose transporter, which usually will help the glucose to be utilized by the endometrium. It will, all of this environment will be more of glucose in the endometrium, and that's, we know, any link between the hyperglycemia with the hypoxia as well for the development of the cancer. So it's really like a very PCOS, it's very unhealthy, really environment, and they found they found in a new study that one of those stress, usually your endometrium will release to protect the endometrium with the hypoxia. This also interfere in the polycystic ovary. So that's all encouraging really and healthy environment for development of proliferation of the endometrium. Endometrial cancer remain to be in the 4th place in the GCC. So if we forget about the, which of course this list include the CA breast. So if we exclude the CA breast and we concentrate only on the gynae, then endometrial cancer more prevalent, I have to say, in Bahraini population, because Hatem, maybe you were in Salmani, of course, and then you know that we see everything, you know, anybody really in a lot of Indians, Filipino, and maybe even cervical cancer will be more on this, although I think things change because we see even now precancerous a lot in Bahrain. It's well known that the prevalence of endometrial hyperplasia is more among the ovulatory PCOS. And in the literature, it varies from 1 to 40 to 49%. This is different. I think it's to do with the criteria used for the definition of the PCOS. Now, when I decided to write this paper, I really struggled because in the literature, not much mentioned about the endometrial hyperplasia among subfertile PCOS. I don't think we, as people working with the infertility, are very much interested in all of this. But I come across two papers, and I thought, okay, in those areas of Europe or wherever, they're different, their genes is different, and they don't have that much PCOS like us. So I come across two papers, one from Iran and the other one from Jordan. And in Iranian group, 2.6, and in Jordanian group is 18, which is something really very high comparing to the Iranian population. When we know that Iranian population, they have PCOS quite prevalent. So, but we're reviewing this paper, the group choose people whom really, they were already on the fertility treatment. So this is worrying. Maybe their risk before starting the fertility was lower than this, because in the Iranian group, they were not really on the fertility population. So we thought that we really need, after this, to establish our prevalence in among population. And I think in any population, it's very important, or any kind of disease, it's very important to have a prevalence. But then, because with this, you can have a clear idea where is the risky group, and how can I change or plan a strategy to tackle this problem, and of course to prevent, as prevention is better than cure. And then identify the group at risk, and to predict the clinical factors for endometrial hyperplasia, especially the value of endometrial thickness, because it's very much in the literature, and it's a good screening because it's non-invasive, and it's like you do it in any small gynae clinic. So the design of this study was a prospective cross-sectional study, and we got an approval at that time from the ethical committee in Salmania. And all our patients were consented as in Arabic in the presence of a witness before really undergoing the endometrial biopsy. So this took place on the subfertility clinic in OBGYN Salmania. And we managed to recruit in a very short period 139, and Arab. We thought we will, Bahraini mean, we are a country cosmopolitan. We are having plenty of people from different ethnic background, and I'm so proud of my country to have all of this, mosaic of people. So, but we thought our aim, what if maybe Arabic origin will have more risk of endometrial hyperplasia? So we decided to recruit only the Arabic ethnic background. And we really got really plenty. And if I review now, when I review the literature, I mean, I don't think they'll be able to recruit that much, but this is just to show you how busy is the place. And we included, as I said, only Arabic, and to decide to have a homogeneous group. We thought we will adapt inclusion and exclusion criteria. So we excluded all other ethnic background. And if they receive hormonal treatment 3 months, when I say receive, that means they are on the fertility treatment, or they were on OC pills, or not really on regular basis progesterone. So they were, sometimes we decided just to give them progesterone withdrawal. This we accept those to be really in our study. Ovarian cyst and thyroid and hyperprolactinemia, of course, we exclude them. And we check BMI for everybody, and abdominal and pelvic circumferences as well. All those patients underwent transvaginal scan on the early follicular phase, and we run a hormonal assay when they come for the scan for LH, FSH, estradiol, and the rest for androgen. And we did even 17-hydroxyprogesterone. Now I'm missing Salmania because this is expensive outside in private, but in Salmania we used to do all of this, and homocysteine, lipid profile, fasting and GTT with insulin to establish the to establish whether they are insulin resistant. And we use HOMA test, of course, for the analysis. The endometrial biopsy in the literature, there is no specific time. And even though Jordanian, they did it anytime, the endometrial biopsy, but we discussed it with the pathologist, the one which was with us in the group of the study. And we decided that to do it on the luteal phase because this is the best time really to know whether there is any endometrial hyperplasia. And we did it as endometrial biopsy by PIPL, but we did hysteroscopy as well whenever there is insufficient sample by the PIPL or there is cervical stenosis, And histopathology review all the sample and slides review by one experienced pathologist, and they use the WHO criteria. Now, at the time of the study, they used all the WHO criteria, which says either endometrial simple, complex, which we know as an all the group. But now there is obviously a new criteria for WHO, which only divide the endometrium to simple endometrial hyperplasia or atibia. So for the sake of the analysis and to be up to date, we decided to use this when we do the analysis of the study. So we have 139 subfertile, and the majority were PCOS, 78%, and this is just to reflect the high prevalence of PCOS among the subfertile population in Bahrain. And we use the Rotterdam criteria for the definition of the PCOS using the 2 criteria out of 3. And the hirsutism, we found it in both the group, the PCOS and non-PCOS, as well the progesterone was low and anovulatory in both subject, but the endometrial thickness was more significant in the PCOS group. And in terms of the metabolic parameters between the PCOS and non-PCOS, I have to admit that we have a high, obesity. Obesity is really the health disease, I think, of GCC. So, when you sit, I think, in any infertility clinic, you see more of those obese people. So, so all of them, they were really like BMI around 30, and then the insulin resistance, because if you are obese, then you have more risk of insulin resistance. So, but it is more significant among the PCOS, having 65% of them with insulin resistance, which goes as well with the same be reported earlier in the literature. And endometrial histology of the study group, we found that it's majority abnormal. And in terms of having the proliferative in 56%, and only 30% were with the secretory. And atibia found in 1%, and hyperplasia without atibia in 10%. So overall, endometrial hyperplasia was around 11%. Of course, we have 3% with endometrial polyp. I think we have a proliferative because to start with, our population is obese and anovulatory, so they have a proliferative endometrium. But this is to show you that this endometrial hyperplasia was all of them in the PCOS. So whether you are big, whether you have insulin resistant or anovulatory, it doesn't matter. What really matters having you with PCOS. So the prevalence was 11%, and with atibia is 1%. And the mean thickness of the whole group was almost 6.8. And we decided to go only to endometrial hyperplasia, and we found 7.5 thickened, and this goes as well with what we reported in the literature, especially RCOG. So to predict then how to predict the clinical factors responsible for endometrial hyperplasia, and we use ROC to predict those factors, and we decided to set a cut-off point of 7.5 millimeter for the endometrium. And we found that there is a positive correlation to age, BMI, estradiol level, endometrial thickness, and insulin resistance. And if we go to endometrial, you see here for endometrial hyperplasia with age. So as your age increases, your risk of endometrial hyperplasia with PCOS will increase. And the average age was in this study 30. The BMI as well, same, show, and thickness. So if your endometrium thickness go beyond 7.5, then you are disassociated more with the risk of endometrial hyperplasia as well, insulin resistance. So our research showed that the prevalence of endometrial hyperplasia among subfertile women, 11%, this prevalence is in agreement with the figure worldwide for the general population, which varies between 1 to 49%, and we reported data regionally, as I said earlier, between 2 to 18%. So are not really higher. We are just in the average. And all cases of endometrial hyperplasia, including this single case diagnosed with atypia, was found among PCOS group, which indicate that it is the group at risk in agreement with the previous reports. The non-factor which increase the risk of developing endometrial hyperplasia and cancer are obesity, nulliparity, and infertility, hypertension, and diabetes. And most, if you see, that most of those factors are already well known as a long-term for the PCOS. Our study revealed that 65% of PCOS develop insulin resistance, and it's positively correlated with the presence of endometrial hyperplasia as being scored under the curve of more than 0.5. And a strong positive association was found with BMI, which was generally observed in other comparable study as well to examine the risk factor for endometrial hyperplasia. It is very important to evaluate the endometrium to recognize the clinical factors that are likely to be associated with endometrial hyperplasia. To our knowledge, this is likely to be the first study to investigate the fertile Bahraini women for the risk of endometrial hyperplasia. And I'll be happy if anybody share with me the work, if they did anything. I know we are very lazy and we don't really publish, but I will appreciate if anybody did anything in that regard, even in previously, please to send it to my email. Many authors attempt to predict the clinical factors for endometrial disease, whether cancer, and then they found that the PCOS women to be associated with endometrial disease even early as a 25. In our study, they were 30. And other proposed that maybe endometrial thickness demonstrated in the anovulatory infertile PCOS with the endometrial thickened more than 7 millimeter or intra-menstrual interval of more than 3 to 6 months, 3 months can be associated with endometrial hyperplasia, and endometrial biopsy would be recommended. And this study, based on this study, that's what is really, this is what RCOG in the guideline proposed the same thing based on this study. It's not a very new study, by the way. And they reported in positive correlation with endometrial thickness. In agreement, we reported a positive correlation with endometrial thickness in agreement with other author, and the cut-off point of 7.5 millimeter is probably the value you have to use in your clinic. And this is probably in contrast with others who find endometrial thickness has absolutely no use, but not of any use. In PCOS patients, unfortunately, there is no clear clinical guideline to determine when the endometrial biopsy should be really performed. And really what we are doing as a practice, it's even in, I was searching, even in RCOG, if you see the guideline, they depend on, you know very well that they usually divide them in A, B, whatever, and then level 1, 2, 3, 4, and you see that they are really like a good practice. They cannot say that there is a randomized controlled trial. And I could not find really a guideline to tell me what to do if you have a patient in front of you, PCOS. Do you recommend routinely endometrial biopsy, or what do you do exactly? Really, the protocol for prevention is really unclear, and this is because of the lack of endometrial randomized clinical trials. So I conclude that the overall prevalence of endometrial hyperplasia is 11%, including 1% with atibia. We identified PCOS as the risk subgroup at risk, particularly those who's overweight with insulin-resistant and thickened endometrium. A future study should appraise the place of routine endometrial biopsy and measures for the prevention. Well-designed RCT include the molecular analysis and biomarkers of endometrium are needed to identify women at risk and to test the pharmacological agent which can prevent the development of endometrial cancer. And I criticize our study that it was of relatively a small group. I wish if we continue this for 1 year, because we'll have a better, at least, control group, then we can, run a multiple regression to validate the finding. And this, the control group, I think this was a strength, because in all of those studies I've seen, they don't have really control group, which is from the beginning, they were low risk. Maybe because it was done in a single center, and to avoid this, maybe multi-center case control study will be considered. And now ethnic group maybe need to be as well be in this part of the study to validate our finding, to see whether this is only on Arab population and not in other, or maybe all in other ethnic group. Maybe whoever really design a study now need to maybe to include everybody. The impact of this study, it is really prematurely to recommend endometrial biopsy as a routine for subfertile PCOS women, and maybe women with high BMI, insulin resistant with endometrial thickness of more than 7.5 or equal, maybe they need kind of evaluation. And if I put it in a practice, after this study, changed my way and view to those patients and of PCOS. It's not just a matter of how to, stimulate them or even to regulate their period, which is a simple things they can present, and I'll share with you later how I regulate their period. But it really just changed my view for them that they're really risky group. We don't pay that much attention as a clinician. I have to say the fertility about the risk of patient because the desire of having a baby is far more than anything happen. And sometimes those women, they'll be so, because they're so depressed and everything, then they make us just concentrate in whatever they want. But I think we should not really forget that they're really risky group. And grateful that everybody really going to RCOG still, and you can see there is a guideline for the long term for PCOs and how you really counsel them in your. But I think we still locally PCOs is very common, and I think we should change our view of how to manage them. I will say maybe if they fail IVF, maybe there will be a place really to do endometrial biopsy. I know the evidence is not much in that regard. I know everybody after the, whatever published, we don't do that much endometrial biopsy, but I think this is a group, a risky group. I think you have to do endometrial biopsy for them, at least after they fail one IVF. I thank all the co-authors, Dr. Huda for Amran, she's from AGU, for her wonderful help in doing the analysis and keeping this as a reality to present it. And Dr. Nahaya, I can't stop thanking her being so supportive and being so actively involved and collecting all this data with all the others in resident who work with me, and Dr. Roba, of course, the pathologist, used to work in Salmani at that time. And a very big thank you for the OBGYN for all the support, and all the residents work with me. And if I remember, I will not say not all of them, but I now remember Fatma Al-Khan, for example. She was a resident at that time with me, and she was so actively collecting the data for us. And thank you very much, Fatma. I think you are hypoglycemic by now, and I don't know whether there is a time already for question.
Actually,
I'm not sharing the
Actually, I have few positive comments on that very interesting topic, which is that the first one is really it is very rare for us to focus on this peculiar angle in treating our patients, which is the pathology of the endometrium in relation to the PCO. We are all concerned about the patient, the couple, to be happy with the baby, and whatever the procedure we are going to do to reach this. So it is very interesting to focus on this unique part, which little of us focus on it. The second positive comment is that it is very rare that you, in any presentation, you criticize the presentation, which is something to lift the hat for it, is that you are criticizing yourself during the presentation, which is something reflects how confident you are in what you have done. The last comment is that I take the permission from you to continue on this together by adding the endometrial blood flow. The endometrial blood flow as a marker in relation to the endometrial thickness, and in relation to even the blood flow of the uterine artery, to be compared with the other variables and to be compared with the normal group. I think it will be an easy marker to be prior to the biopsy. And we can also correlate it with the biopsy if it is going to be enough. But of course, nothing will be as evidence as the biopsy. But adding a marker as the blood flow has been successfully took place in the cancer ovary, which is a state, we call it neovascularization of the cancer ovary, which can predict or even diagnose as or used as a marker for cancer ovary. So using the Doppler endometrial blood flow, I think on a good number of patients can add to our knowledge in this important topic. Thank you very much, Dr. Khulud. Thank you for everything. Thank you for attending. Thank you for sharing. Thank you for your nice lecture. And we are not hypoglycemic. I hope you are not.
Thank you very much, Hatem. Thank you very much. And I'm sure this is just the beginning. Many will come up, I think, after this to many ideas.
Sure. When we brainstorm, it will be so many ideas coming.
Yes.
And we will hear from you the closing topic of this session for today, for us at least. It will continue with the pediatrics after Dr. Khulud, after this lecture of Dr. Khulud. The floor is yours.
Thank you very much, Hatem. And I'm sharing with you this management of the menstrual cycle. And with the, I have to declare that this is really a sponsor by Abbott. And when they requested me to do about irregular period, I say this is too simple. How can I add anything, out of it? And for something really neglected, not much really. I struggle when I did any, review of the literature, and something really neglected, unfortunately, for something really very common. And I think I went back. I think all women really share with me that we struggle at one stage of any, I think women always in a challenge with the bleeding, either irregular or the no bleeding or pain with the menstrual cycle. And I think any gynecologist fed up of having all of those people in the clinic. We know how this affects even the mood of the woman, and to interfere even with her social activity. And I always say this, even to my patient, that men will go to heaven because they are tolerating us and tolerating our hormonal disturbance all our life. The prevalence of menstrual irregularity is a very common problem, and especially in the young age group, and be reported to be 32 using the FIGO definition to 64. And I think it's still understanding the prevalence. It's although it's in the developing country, we pay very less attention to that, and we really paid a lot less attention even to menstrual health and menstrual disorder. When to have a effective strategy, especially for prevention or improving the quality of service provided to the women, you need to have at least a basic things, which is the prevalence. I think this is all depends on the awareness of the population and of especially the morbidity of the menstrual cycle. And it struck me a report came from Harvard for that they include really a huge number, 80,000 women. And they show that the regular period in adolescent can be associated with the risk of premature mortality. And they define this as less than 70. And this is related to cardiovascular disease. A person like me who loved really PCOS and almost for the last 20 years, I was only with them. I thought, oh, maybe those are really PCOS. We know that PCOS as well, they have all of this risk, long-term risk of cardiovascular disease, of in terms of insulin resistance, hyperandrogenism, increase of hyperlipidemia, and they have 7-time risk of having cancer. And probably this is the leading cause of death among women. And so I thought maybe those 70, I'm sure many of them, they were PCOS as well. Now, you know by now that the endometrial hyperplasia increase the risk of risk in the polycystic ovarian population, and the hyperplasia will increase with any irregular period, and especially if it's with amenorrhea, then maybe it will reach even 43%. The chances of developing endometrial hyperplasia with comparing regular and irregular 5 times with the regular period, but then 13 with the times if you are having irregular period. So irregular period is a serious thing. We thought it's very simple. In gynae clinic, we leave them even for the more junior person in the clinic to deal with them. And then the link of the of irregular period with chronic disease, the period will reflect as well the endogenous endocrine health environment. So if you are having irregular, that means there is condition, maybe underlying condition, and some of those chronic conditions like diabetes will lead to irregular period as well, because it will disturb with the GnRH activity as well, the change in the steroid action section. I learned as well that irregular period has a significant association which found with the anemia. And this is a report came very recent from Ethiopia. We see a lot of this is another really neglected condition in the clinic. We think that those patients really seeing their GP, we don't have really to look at their general health. But this is something simple, can be treated and really improve the quality of life. Of course, the endocrine problem is heavily, well known. For instance, the hyperprolactinemia, it leads to inhibition of GnRH and maybe even FSH, and cause sometimes amenorrhea, especially for those people with and all others like diabetes, as I said, because of this increase androgen, decrease the gonadotropin, affect even 6-hormone binding globulin, and this is as well, it will interfere Cushing syndrome and thyroid, which is well known. If we talk about an ovulatory disorder, we will always remember the classification of WHO. I used to use this slide heavily during my when we give it to the student, and then of course group 1, 2, 3 as well. They present with those problems with the menstrual irregularity. So the PCOS is the most common reproductive endocrinopathy, which varies in the prevalence between 8 to 13. Depends on the criteria used, and it's a very heterogeneous condition with the diagnosis is really with using Rotterdam criteria. And PCOS, of course, increase all the metabolic risk of hyperlipidemia, diabetes, and cardiovascular disease. And majority of those, they will have a regular period. So the key features in those PCOS is insulin-resistant androgen, excess and abnormal gonadotropin. I'm not going to go on those details because I'm sure they will be covered in one of the sessions tomorrow. The hormone changes there will be increase of all androgen, and then increase of LH, and increase of fasting insulin, prolactin, estradiol, and decrease of 6-hormone binding globulin. When you talk about irregular period, you will definitely come with the AUB. So I thought to define it. The AUB is defined by irregular in frequency, the volume of a flow, duration, and regularity of the menstrual cycle in the absence of the pregnancy. That's the FIGO. And then FIGO classification decided to do a structural AUB or functional. We were talking more concerned about the functional, which is ovulatory dysfunction is one of them. And to treat those related disorders in view of chronic anovulation, it can increase endometrial hyperplasia, as we mentioned earlier, and the proliferation can be controlled or inhibited by progestin or OCP. This is something we know. I thought let me be more practical. If we see this, because really this is all details, I'm sure you know far more than this, and how to manage really irregular period. But if we have a patient, 24, presented to you in the clinic, primary subfertility for 2 years with normal sperm analysis, irregular period, hirsutism, BMI with 35, and you did a scan and showing this beautiful, to tell you that I'm PCOS, no need to do anything further, but he managed to, you know, he decided to do a lot of tests, just to confirm to you that she's PCOS, okay? Now, of course, you will, how you will manage it. Old age would say, okay, now I will do all to exclude all of this. Yes, never mind. Okay, she is PCOS, I'm telling you. Okay. And then really PCOS, if we remember how to manage, it's always the choice depends on the symptom. So if they present with hirsutism, you're going to concentrate on the hirsutism. If she presents with irregular period, you're going to concentrate on that. And infertility, we will concentrate, stimulate, and that's it. I'm telling you today, please don't do that. You have to really, in an era of personalized medicine, think about her as a whole. So I will propose that this is a holistic approach for irregular period with patients. How do you do that when there is not much in the literature? So I thought I will regulate her period, yes, but I'm going to use something which doesn't interfere with my ovulation. Oh, sorry, my medicine to ovulate her, and maybe I know that they are at risk as well of miscarriages. I want something really to add a little bit of luteal support, and why not to be less androgenic because of her all androgen around and hirsutism. Does she need anything more than this? So she doesn't need really extra medicine to aggravate her condition. And I don't want anything really to use it to gain weight and maybe decrease her risk of endometrial hyperplasia, since I'm occupied now with all, hyperplasia and atypia. And I want it really affordable. Majority, they present to you with really, they can't, especially in the private, well, they can't really afford that much. Obesity in PCOS, lecture and literature, and we will not finish, okay? And I think the guideline clearly says that the life change, including the diet and exercise and weight loss, should be started in line with any treatment and to improve the long-term outcomes alongside with whatever you are giving. Weight loss can improve the circulating androgen. It provides numerous benefit for the metabolic problems and improve the complication. And it is evident that even 5%, if they lose weight, this can improve their period. And I think this is maybe because we see a lot of people who's really overweight, and we sometimes feel shame really or embarrassed to tell her please lose weight, but really it's important. For the insulin resistance, now from all those brief slides, we know that
sorry for interruption.
Yes, but we're running out.
we have 5 minutes because the pediatrics
Yes, I'll go through this quickly.
Yes, the pediatrics will start at 5.
Okay, I started late, but never mind. The metformin is a very good choice, really, for the reduction of ovarian secretion of androgen, and unfortunately, it's not really to prevent hyperplasia, but it's been shown by meta-analysis that it's improved the menstrual cycle, comparing it with the just placebo. And OC pill is a good line, it's the first line, but it can be indicated only for severe anovulatory bleeding. But one thing to remember, that 1.5 time they have, those PCOS, they have thromboembolic disease. And you have to be careful, because when they use their OC pills, this will increase their chances to 3.7-fold. So I will go to something, progesterone. I choose the progesterone because the progesterone is, there's 2 types, norepinephrine and dydrogesterone. And norepinephrine is very androgenic, dydrogesterone is less. And I think we will compare those many progesterone, but I'm going to compare those 2. So in terms of the transformation of the endometrium from proliferative to secretory is very good, both good in regulation the period, and the dydrogesterone very good for the young age group, for luteal phase defect, and it's very good in regulating the period. Many studies showed when we use them 10 milligram BD from day 11 to day 25. And affinity to receptor is very good to progesterone, but not to androgen. And if we compare both, we see more less androgenic the dydrogesterone, and it's the only one which doesn't have interfere with your the gonadotropin, and then it's more toward the progesterone, and doesn't have any anti-gonadotropic effect. And if you use it 30, so that means 3 tablets, this will block the ovulation. So the message here, even if you use it, don't use it if the patient is really on ovulation induction. Don't use it more than 10 milligram BD, because more than this, it will interfere with her ovulation. And it's very safe, been used for the last 55 years. So the conclusion for me today is the winner for today is the progesterone for the infertility. And if I conclude, I will conclude that it seemed to be, defibrotide seemed to be very safe to regulate period in subfertile women, and the management of the period should be really tailored according to the patient's risk, not just a patient who wants to have a regular period. You don't give her OC pill when she wants to have a baby, for example. Please ask. So, and I think we need the randomized controlled trial to say whether Defestone is really a good choice to be used for luteal start to prevent endometrial hyperplasia or not. Till then, I cannot say that it can prevent the endometrial hyperplasia, but it's a good choice to be used for regulatory period for PCOS and when they are planning for a pregnancy. And thank you very much. I think I'm on time.
Thank you, Dr. Khulud. Thank you very much. I have one question and one comment which I cannot dismiss because they are from Dr. Hoda Musa Umran. This is the first question, which says, excellent presentation, Dr. Khulud. What is the best time for performing the endometrial biopsy for PCO patients with infrequent cycle?
What we do usually to do this, I think, I will talk practical. because in the infertility, we don't leave them really with irregular period pattern. We always keep them on something really to see their period, because people are really very much occupied by the period, and not surprised because of their praying and all of this. So I give them Defistone. And I started really either late or early. So I started from day 11, day 19 to day 26. And whenever they have withdrawal, I calculate and I do it on day 18 of the period. That's for the endometrial biopsy.
And there is one last comment from Dr. Zainab Al-Jufairi saying endometrial thickness measurement varies between premenopausal and postmenopausal patients. Endometrial thickness varies according to the endometrial cycle. These 2 points should be kept in mind before interpreting the result of the endometrial thickness. So with this comment,
well, I will just say, well, in the study we presented, they are really fertile. We are talking about subfertile young population, and we ensure that people have a withdrawal, a bleed before we enroll them in the study. So we are not talking about random. We're talking about people who we know that they will be enrolled in the study. We excluded at that time. I think you know that you work in Salmania. We have a huge number, but we try to select a group of subfertile women who are willing to be in the study, and those we either with their period or during their. So we measure this thickness during early follicular phase. We did not measure them during randomly. We measured them during the early follicular phase. So that's in the day 5 of their period, day 4 or 5 of period.
Thank you very much, Dr. Khulud. Thank you for all the speakers. Thank you for all the attendees, either from the obs and gynae or pediatrics or any other medical or paramedical specialities. We'll close the first session of the conference now, and we'll start the pediatric session under the chairperson of Dr. Suhail Shabib and the co-chair, Professor Mohammed Al-Biltagi. And for the gynae doctors who are interested in gynae ops and infertility lectures, we will meet you tomorrow in the afternoon, inshallah. Thank you very much, and see you tomorrow. Bye-bye. Thank you all. Thank you, Dr. Khulud. Thank you.
Thank you very much, Dr. Hatem.
Thank you.
It's been a pleasure to be with you today. Thank you.
It's my pleasure.
السلام عليكم دكتور محمد.
السلام عليكم. I cannot. I am Suhail Shabib. I will be chairing this session with Professor Mohammed Al-Biltagi. I welcome all the audience, and I wish it will be of benefit to all of us. Our first speaker is the co-chairman of this session, Professor Mohammed Al-Biltagi, consultant pediatrics at King Abdullah Medical City, Bahrain. I had the chance to hear Dr. Biltagi's lectures in the past, and I was impressed with the amount of information he can pack in a short time. So let's see what he will tell us about infant colic. Is it simple or hard to treat? Let's see. Thank you. Go ahead, Dr. Bertaji, and
Thank you very much.
Coming.
Thank you, Dr. Sahel, for your nice presentation, and I do thank the conference organization and organizer for giving me this chance to be among you and among my dear colleagues and the pioneers in pediatrics will gather today. I will give a highlight about the infant colic because it's a little bit common among the infant. And I will cover the etiology and the prevalence as well as the effect on the family and the baby, plus some evidence-based management of the infant colic and how to optimize the current practice according to the national and the international guideline. So at the beginning, I will give an overview for the functional gastrointestinal disorder. The definition of this disorder is actually a combination. So it's usually a combination. It is rare to come in a single symptom, but usually in a combination of some symptoms that it is related to the age. So it comes with certain age and disappears with certain age. It comes in a form of either chronic or recurrent symptoms. And there is no underlying structural or biochemical cause to help to diagnose this disorder. So the diagnosis is mainly based on the symptoms. Here, actually, for the Roma criteria for the functional gastrointestinal disorder, we will see that here is G1, G2. So what is the G and A and the other stuff? From A up to F, this is the functional gastrointestinal disorder related to the adult. And for the infant, and neonates and infant, we have the G, and for the children and the adolescent, we have the H. So I will find here G1, 2, and 3, and 4. This is related to the infant, the neonates and the infant disorder. Among the common function gastrointestinal disorder in the infant, I will find that there are 4 common disorders, including the infant regurgitation, infant colic, functional diarrhea, and functional constipation. And I will give some highlight about the infant colic today. So what are the age presentation of some of the important functional gastrointestinal disorder? We can see here that the infant colic starts at birth and then usually disappear by the age of 5 months. Other conditions, for example, may appear in the neonatal age and even may continue to the for the children, adolescent, and even for adulthood. For example, functional diarrhea may appear at the age of 6 years and then 6 months, and then even may continue into adulthood, cyclic vomiting by the age of 2 months and extend into the adulthood. So here is some prevalence of some of the functional gastrointestinal disorder common in the neonates and infant. We find that the infant colic is about 21% in the worldwide survey. However, some studies show it's about 10 to 21%. We find that the infant regurgitation may reach up to 40%. And we can estimate that it is a little bit common. It's not uncommon. There is 1 child among 5 children who can get infant colic. So this is a very important and very common, I will not say disorder, but I will say condition that come and disappear and can make some troublesome among the family and irritate the parent. So usually the functional gastrointestinal disorder comes into a common combination. We call it المصائب لا تأتي فرادى. So usually it typically present in combination, and many infants may have more than 1 symptoms like colic, regurgitation, diarrhea, constipation, and so on. So as they come into combination, the management also should be combined. So here we can see that about 78% of the patient, of the infant, they have 2 or more functional gastrointestinal disorder, and only 22% have only single functional gastrointestinal disorder among the patient included in a study done in France by Balishi et al. There is also give us a big hint about the management. Are the multiple functional gastrointestinal disorder are worse than the single functional gastrointestinal disorder? There is a very important study published in 2018 showed that the children who get more than one functional gastrointestinal disorder are more liable to have shorter duration of breastfeeding, lower weight gain. So they can see that there is a significant difference between the children who have single functional gastrointestinal disorder compared to those who have multiple functional gastrointestinal disorder as regard to the weight gain. They also are more liable for increased drug prescription, and they usually have a slow recovery with poor quality of life. So at the same time, some of the functional gastrointestinal disorder may have a common symptoms with a very important and very common disorder, cow milk protein intolerance or allergy. Because of common symptoms like vomiting, irritability, and colic are common between the functional gastrointestinal disorder and the cow milk protein allergy. So it should be in our mind with every patient presented with different manifestation we could relate to functional gastrointestinal disorder. So what are the most important points that we have to take care during management of this disorder in the infant and children? The most important is not to miss a serious diagnosis. This is very important. Then the second important during diagnosis is not to do unnecessary investigation with a lot of cost and even an anxiety to the parent. But also for the management, we should also treat the function problem without unnecessary medication or elimination of diet. So not over-treat and at the same time not to under-treat. So what are the wrong criteria for the infant colic? So the age should be, the age of the symptom should start before the age of 5 months and usually stop before the age of 5 months, sometimes extend up to 6 months, but mostly before the age of 5 months. It is presented with recurrent and prolonged period of crying, fussing, or irritability that start and stop without any cause, any reason. And unfortunately, it cannot be even prevented by the parent and can't even be resolved by any maneuver. So there is no evidence of an organic cause, especially failure to thrive, fever, or other illness. And the caregiver usually give us a history that the crying usually persists for more than 3 hours per day for more than 3 days per week. And we should keep a diary, or the parent to keep a diary to document presence of crying more than 3 hours per day. So here is the Rome's criteria that start and disappear before 5 months, crying with fussing irritability without apparent cause, no failure to thrive, and cannot be resolved by the caregiver. However, there is some change between the infant colic in Rome criteria 3 and Rome criteria 4. We can see that according to Vessel et al., they apply the rule of 3 criteria that it starts for 3 or more hours per day, for at least 3 days per week, for at least 3 weeks. But according to the new criteria, we don't need the 3 weeks. So the 3 weeks disappear. So recurrent and prolonged period of infant crying, fussing, or irritability, it is actually unethical to wait for 3 weeks with the child is crying without making a proper diagnosis. So the term 3 weeks disappear from Rome 3 and not included in Rome 4. Another important change is just a linguistic change that we change the term from infantile colic into infant colic. And this is just a grammar correction and not related to any other issues. So what are the possible underlying causes for the infant colic? Actually, it may be a form of a mild and transient form of lactose intolerance with a lot of gas production. It also can be a form of transient and mild cow milk protein intolerance or allergy. Maybe also related to the functional immaturity of the gastrointestinal tract, maybe related also to a swallowing of a lot of gases due to improper burping technique. Also, it could be related to painful gut contraction. We call it hyperalgelic colonic hyperperistalsis due to increased amount of certain hormone like mutilin and ghrelin, which increase the colonic hyperperistalsis. Some of the studies also they showed that it may be related to presence of mild chronic inflammation of the gastrointestinal tract. So other possible causes that the maternal smoking, which also can increase some of the hormone mutilin, which increase the colonic peristalsis. This biose also, it has a lot of possible mechanism of increasing the intestinal microflora towards producing the gas-producing pro-inflammatory coliforms with a lot of gas production, and also can cause mucosal inflammation. Also, maybe lack of experience of the parent, especially in the first child, it can cause some anxiety, psychosocial disturbance, some form of gastroesophageal reflux. It could also a possible underlying cause of infant colic, and maybe just a change for the temperament. Some of the babies may have a different mood and a different characters. And also some of the authors, they mentioned that it could be a form of migraine because we noted that many of the infants who have infant colic in infancy, they may got a migraine during childhood or even adulthood, with a higher incidence of migraine among the adult who have a positive families, positive past history of having infant colic. So for a very important differential diagnosis is the cow milk protein allergy. If we represent this circle with all the infants, we'll find that about 40% of them may have colic at some time of their life. And about 25% of this 40%, which means about 10% of all the infants, they may have some form of milk allergy or milk intolerance, not necessarily to be allergy, but some form of milk intolerance, which could explain the infant colic, plus presence of sleep disturbance and other manifestation of cow milk allergy. So how can we recognize the infant colic? That it should be start in the first few weeks of life and disappear before the end of the first month. The peak of crying usually reaches the peak by the age of 6 weeks or 2 months, and the baby usually starts crying suddenly and even stops suddenly. And the crying have a special position, like taking the legs on the tummy, flexion and extension of the legs with clenching of the hand. And usually it happens during a certain time of the day, and usually in the evening time. Sometimes even we call it evening colic. The most important feature that the child is growing very well, it looks very healthy, active, vigorous, and there is no sign of any illness. So what are the factors that could tell you that the baby may have worsening of the colic? You can see the face of the mother here. She's grimacing that she's anxious and anxious. So if the parent have a colic, if they have irritable bowel syndrome, if they have a history of being colic during infancy, overfeeding, the mother to try to feed the baby to stop him crying. Overfeeding also can initiate colic. The mother try also to soothe the baby by giving him some sugary liquid. Also, this can increase the colic because of the increasing the gas production. And if the parents are very anxious, they are very feared, they have lack of self-confidence, this also can aggravate the colic. And if the mother, especially if it is breastfeeding, she take a lot of caffeine, a lot of some food that can increase the gas production, like onion, cabbage, spicy food, beans, broccoli. This also could be a factor to increase the infant colic. So what are the role of the physician in infant colic? The most important role and the most important function of the physician, the pediatrician, is to rule out organic cause, to be followed by assurance of the parent. So we have to rule out presence of cow milk protein allergy. This is because of common symptoms among the children. Meningitis is also very serious condition. Acute otitis media, pneumonia, infective diarrhea, gastroesophageal reflux disease, and the presence of urinary tract infection. So what investigation we could do? We don't do investigation, but sometimes we may do some investigation, like if the patient have a bulky stool, for example, water stool, we can do reducing substance in the stool to detect some form of lactose intolerance. We can also detect occult blood in the stool as indirect sign of having cow milk protein allergy. However, we don't do investigation, and there is no need to do unnecessary investigation. So what are the future of these babies? In a long-term studies lasted for about 10 years for the infant who have colic, we found they may have more chance of having recurrent abdominal pain, atopic condition, a sleep disorder, and being aggressiveness and a feeling of superiority over their peers. So according to what we just mentioned, is it a benign condition or a non-benign condition? Yes, it is a benign condition because there is no pathology, no underlying pathology, normal growth. Most of them resolved without any problem. However, it has also, we can consider it completely benign because there is poor quality of life for both the baby and the family. The burden, the financial burden for the family and the community, and also some of the long-term complication, as we will see, may also be associated with having infantile colic. So what are the long-term complications of this infant who have a colic? They may be associated with later to develop gastrointestinal disorder like irritable bowel syndrome, atopic condition, migraine, behavior and cognitive problem. This is very, very important. In another study lasted for about 10 years, they found that there is an increased relative risk for the recurrent abdominal pain to be 10 times for the infant who have infant colic compared to their colleagues. For the allergic disorder, increase about 3 to 8 times, and the psychological disorder increase about 10 to 14 times. So we can imagine how significant to manage the infant with colic in a proper way to decrease the long-term complication and to decrease the relative risk for other long-term consequences. So here we can see that there is increased incidence of feeding disorder during a baby, breastfeeding discontinuation, parental stress. Later, they may have a behavioral and developmental challenge. Later, they may have a poor family quality of life, even persist up to 3 years after being, and even after resolution of the colic. However, later in life, the infant who have developed infant colic, he may be an adult with functional gastrointestinal disorder. And here, a list of studies that they have a long-term observation for the infant colic later in life. So what about the relation of the colic and the family? The more the child cry during infancy, the more the family will have a disruption, especially this disruption can persist up to 3 years later. There will be a dissatisfaction with arrangement of the daily family life and poor life quality, poor and less leisure time, and less shared activity with the neighborhood or with the friend. And even it may end with seeking the advice of psychological support because there will be a form of stress that can be resisted up to 3 years after having this baby with the infant colic. So what we could help the family with the infant colic. So at the beginning, after ruling out of the organic cause, we have to assure the parent that this is I will not say physiological condition, but we will say it is non-serious condition. We can give some general advice to the parent that it could help. So at the beginning, if the child is crying, we should rule out any rule of discomfort like being wet, hunger, feeling cold, feeling hot. All this we should rule it out. Then we should assure the parent that it is not their fault. It's very important not to let them to feel guilty because this will be a form of stress over them, and the mother may be liable for having postpartum depression. We also should inform that this is a not harmful condition and it will grow by its own without any medication by the age of 3 to 6 months. And we can ask them to keep a diary. Also, according to the type of the feeding, if the baby is breastfeeding, we give some advice to decrease the gases that they can swallow, like, for example, good breast latching and attachment. And the mother to be advised that she finish one breast by time, so it doesn't give some breast from here, some milk from the right side, and then the other side should finish the breast completely before giving the other breast. The position of the baby is also very important to be about 30 to 45 degrees. And if the mother drinking a lot of coffee or caffeine, she should decrease the amount, and also to be very cautious during her food, like decreasing the amount of some food like which is well known to cause gases like onion, chili, and other stuff. What about if the baby is a bottle feeding? We have also to advise the mother to avoid overshaking of the bottle, because this will create a lot of gas bubble, which can also cause that. We also should ensure that the teat is full of milk and no gas is there. And we can also control the feeding by changing the teat size and the teat flow. We can also use a specific type of anti-colic bottle, which decrease the air swallowing. Unfortunately, it's a little bit expensive, but it is available. So we also avoid overfeeding, because overfeeding, it could also stimulate the infant colic. We should teach the parent how to burp. They should burp in the middle from 1 to 2 times, and then one at the end of the breastfeeding or the bottle feeding. Again, we have to give the parent a time for them, because it is a very stressful condition to have a baby who is crying all the time. So we can ask the help of some of the family member or the friend to give the parent some free time for them to avoid having chronic continuous stress. Here is a guideline according to the Middle East consensus about diagnosis and management of the functional gastrointestinal disorder. So here is the criteria of the infant colic. Then we should look for the warning sign that indicate serious condition, like presence of vomiting, we got neck stiffness, gastrointestinal bleeding, presence of failure to thrive, or abdominal distension. If it is available, then we have to refer. If not, we then look for other signs of other functional gastrointestinal disorder or cow milk protein allergy, like recurrent regurgitation, atopic condition, presence of diarrhea or constipation, and presence of a positive family history of atopy. If it is present here, so we can try cow milk protein free diet in the breastfeeding, or we can give extensively hydrolyzed formula in the bottle feeding. If there is improvement, then we'll continue for at least 6 months. If not, we have to refer. If there is also a warning sign of an anxiety in the parent, or parental depression, or poor mother-child relationship, or if there is any risk of child abuse, then we have to refer. If no, then we have to give just support. We can give some lactobacillus reuteri for the breastfeeding mother, and we can also give the partially hydrolyzed formula supplemented with GOS and FOS in a ratio of 9 to 1. And we also can prefer adding LP palmitate instead of alpha palmitate. And we can ask the parent to come after 2 weeks to see if the condition is improved or not. So here is the evidence-based recommendation, is just to try dairy product exclusion by the mother for about 2 to 4 weeks. There is insufficient data to give the lactobacillus reuteri for all the infant, but in selected breastfed infant, we can get benefit from supplying with lactobacillus reuteri 17,938 drops. And also we can, for the bottle feed infant, we can give the partially hydrolyzed formula supplemented with GOS and FOS plus B palmitate. We can also give some formula that contain prebiotic. We can also try the fermented formula or the low lactose formula, which can also help. Other treatment that could be available, that we can use some sheep skin blanket like this. Okay, infant car ride simulator, which will make rocking of the baby, that it also soothes the baby. Also, we can use white noise that is very commonly used nowadays to soothe the baby. However, we should refer to the child to a gastroenterologist if the parent are unable to cope with the disease. If the child abuse is suspected, we have to refer for psychological assessment. Of any organic code is suspected, like gastroesophageal reflux disease, failure to thrive. If the baby didn't outgrow by the age of 4 to 5 months, or the symptoms persist after the age of 4 months. In summary, that more than half of the infant may have some form of functional gastrointestinal disorder in the first few months of life. usually comes in combination. About 78% are combined. Psychological effect of the functional gastrointestinal disorder for the infant between the age of 1 year is significant and must be addressed. We have to assure the parent this is a functional disorder and will resolve by time. We can try partially hydrolyzed formula with prebiotic, GOS and FOS, and we can also add depalmitate or using fermented form. Thank you very much for your time. And if any question, you are mostly welcome.
Thank you, Dr. Beltaji. That was very interesting and very well done, full of information. May I add a comment rather than a question?
Sure. Sure, please.
About the, thank you. This colic is really frustrating to patients, and as you mentioned, it could very well drive into child abuse. Now, yes. A word of caution out of tradition: please, no herbs and no medications. When I say no herbs, we don't know what's in herbs and how they react in the liver of these patients. And personally, I saw patients who went into fulminant hepatic failure after trying to control the colic with some traditional herbs. Ma al-gharib and anise water. These are not the optimal things, as my grandmother used to say and practice. What they do is that they slow the gut movement. They introduce colic, and colic will cause distension of the gut and gas in the gut, and we go into a vicious cycle with colic. So I suggest that they are not used. Otherwise, cow's milk protein intolerance should be high on this, and as you mentioned, hydrolyzed or semi-hydrolyzed formula will be ideal in these situations. Thank you very much, Dr. Beltaji. Any other questions, please?
Thank you, Dr. Sohail. Just a comment for what you just mentioned about using the herbal medicine. Some of them, it may contain strychnine, which can cause strychnine poisoning, which is very fatal. This is commonly used in the southeast part of the world, especially in Japan and China. They are using also special type of herbs that is very neurotoxic.
I agree with you. You know, it's cultural, and any herb that is used in adult, it is not safely used in children. These chemicals are more concentrated in certain amount that is not suitable to be used in children. So we follow these things step by step. Put in mind cow's milk protein intolerance, cow's milk protein allergy. You might think of lactose intolerance even, you know, or galactose intolerance. This is the age around 5 months when you introduce fructose, fruit and vegetable. You have to rigor your thinking and look at any minor details in the diet of the child, the formula itself, the excessive crying for pain, already developed constipation, swallowing a lot of air, so many things. It's really wide area of thinking, and you should practice how to focus and zoom on each group of problems and complications at one side. But again, ma al-gharib, anise water, most of these medications in the pharmacy that tells you for colic, they just cause constipation and get you a vicious cycle and more frustration with the parents. Thank you, Dr. Beltaji. We'll go to the next speaker. And Dr. Beltaji, please introduce the second speaker. Thank you very much.
Thank you, Dr. Sohail. We are very lucky to have Dr. Tawfiq He's a consultant pediatric in Sheikh Khalifa. Dr. Tawfiq. I think this is Dr.
will be as a recorded session. I will share it with you.
Okay. So
Mr. Ahmed, please, Dr. Tawfiq unfortunately had a surgery in his at the dental office yesterday, so he recorded his presentation. Ahmed, please,
I will make I will make short introduction for Dr. Tawfiq. Dr. Tawfiq is a very well recognized international speaker of many of the international conferences in the Arab area and outside the Arab area. Dr. Tawfiq, he is a consultant pediatrics in Sheikh Khalifa Medical City in Emirates, and he is a figure in pediatric there. And he's interested with gastrointestinal disorder, especially celiac disease. And we enjoyed many times to attend for his lectures. So, Dr. Tawfiq, the floor is for you.
Good evening. Thank you, Dr. Shabib, for this kind introduction. And I would really would like to thank the organizing committee for allowing me to be among you here today. Our talk today is about celiac disease. If we look at this picture, we can see different types of bread. However, one is made from wheat, the other one from barley, and the third one from rye, al-jawdar. However, in common, they have certain protein, which we call the gluten. Despite the different names, in wheat we call it gliadins, in barley hordenins, and in rye saccharins. And if we go to the plant kingdom, or mainly to the family of grasses, mamlakat al-a'shab, we can see that wheat, rye, and barley, they come from the same tribe, while oats comes from totally different tribe. And oats contain different protein. We call it avenine. It is similar to gluten. And most people with celiac disease can tolerate gluten-free oats with no problems. Do you have any problems with gluten? If you don't have, listen to what Dr. Tom O'Brien, a person who dedicated all his life to celiac disease and gluten intolerance, wrote. No human can digest gluten. Do you agree with this statement? This is really important. This will decide to gluten or not to gluten. So to understand that, let's go back to our physiology. To digest any protein, we need to use the enzyme protease and to break it down to amino acid. And amino acids are the only molecules of protein that are supposed to get through the intestine into the bloodstream. This is really a key point. Now in gluten, we cannot break the protein down to amino acids. We remain with large peptides. Why is this happening? Because we humans, we lack the enzyme to digest gluten. Why did this happen? To understand it, let's go back into history. Humans, we were born as hunters and gatherers. صيادين ونلقط الأعشاب. Now, when our numbers started to increase, we need more stable food. So we introduced herding, الرعي. And with the increased number of population, we shifted to farming. We cannot continue to move. And from farming, we reach the model farming. And if you look at maize, rice, and wheat are the most important items in human diet by now. They provide 42% of the total world's food calories and 37% of protein supply. And they are considered as the foundation of world food security. Unfortunately, we are not among the countries who are producing these cereals. However, despite a human being on Earth for 4 million years, agriculture is something new. From 5 1,000 to 13,000 years. And we notice that it started in different pockets as root crops, الأعشاب اللي بتنمو تحت الأرض. However, in one place, which is in green, that we call Fertile Crescent, Palestine, Syria, Turkey, Iraq, they started to cultivate the land with the new crops, barley and wheat. And from here, by average of 1 kilometer per year, it spread all over the world. And this was when celiac disease was born. So let's say together, happy birthday, celiac disease. Maybe birthday, but not happy. And the first one to mention celiac disease was Areteus of Cappadocia, about 100 years before Christ. He described children who will develop abdominal distension, diarrhea, muscle wasting, edema, and many of them, they die. And he thought the problem is in the intestine, and he called it coliacos. Then there was silence in history until the 19th century, where Dr. Samuel Gee, who was working in Great Ormond Street, he noticed that the cause is a diet, and to treat it should be through a diet. He didn't know what diet, and based on that, in 1924, Dr. Sidney Haas, working in Maryland, started to put children who have celiac disease on banana diet. What happened to these children? Diarrhea stopped, the weight improved, the height improved, because banana diet was an intentionally gluten-free and high in calories. However, let's see what he wrote in 1924. When living in Puerto Rico, dwellers, mean people who live in the cities, who eat much bread, suffer from celiac, while farmers who live on bananas never. However, Sidney Haas skipped over the role of wheat and focused instead on the exotic bananas. It wasn't until the Second World War where a physician by the name of Dr. Willem Dieke worked in Hague. He noticed that the children who were diagnosed with celiac disease during the blockade, when there was a lack of food and they were not baking, their symptoms improved. And when the Alliance started to drop food by the parachute and they started to bake again, their condition deteriorated. That's how reasoning of observation revealed the cause of celiac disease. So he took 6 children, he put them on gluten-free diet, they improved. Then he introduced gluten, they deteriorated. And that's how he proved that celiac disease was caused by gluten. And from here, we should just stop and learn a wisdom from the arrogance of Dr. Sidney Haas to the observation of Dr. Willem Dieke. We learn that a few observation and much reasoning lead to error. Many observation and a little reasoning to truth. Should you stop eating gluten? Before I answer, I will tell you what gluten does. It gives the dough its elasticity. It allows dough to rise and not to fall down. Not only that, it gives its texture, a crust, and taste. So gluten is beauty. However, with the beauty comes the beast. So when we introduced gluten, we started to have autoimmune reaction like celiac disease, wheat allergy, non-celiac gluten sensitivity. With wheat allergy, we can diagnose it by allergy test, RAS test. Celiac disease, serology and biopsy. Wheat hypersensitivity, we need to exclude other causes. However, the treatment for all of them is elimination of wheat from the diet or gluten from the diet. Now, why not everyone who eats gluten develops celiac disease? So we have the culprit. We need something else. They found to develop celiac disease, you need certain genes. And these genes were found to be located on the short arm of chromosome 6, mainly on the human lymphocyte antigen, DQ2 and DQ8. If you don't have DQ2 or DQ8, you don't develop celiac disease. This is another key point. How does it work? The DQ2 or DQ8, they work like antigen presenting cells. They carry the gluten and they present it to the T lymphocyte, and the T cells, they start the damage of the tissue. So if you don't have them, you never develop celiac disease and no initiation of the autoimmune process. Now we know that 40% of people, they have DQ2 or DQ8. However, only 1% of the population can develop celiac disease. Why doesn't everyone with HLA, DQ2 or DQ8 get the celiac disease? Because, as I mentioned, we have the culprit, we have the genes and other risk factors like gender, infant feeding, infection, dysbiosis, but not everyone develops the celiac disease. It means there is a missing part of the puzzle. And this missing part was found in our pathogenesis, in the pathogenesis of celiac disease. So let's go simply through the pathogenesis. We should have the gluten, the culprit, and we know that the enterocyte have tight junction. However, the gluten for certain reason goes and into our bloodstream and reaches the tissue transglutaminase, where tissue transglutaminase does the amidation. It means they make it more antigenic, and the HLA, DQ2 and DQ8 presented to the T cell and starts the reaction. However, the biggest question is how these large indigestible gluten particles reaches our immune system. We were taught that the enterocytes are held by tight junction. If they open a little bit for a short while to allow the digestible food to go in, this is normal. However, in patients with celiac disease, they found that these junctions, they open wide and for a long time, allowing the peptide to go in. So what does open these tight junctions? There should be a key. And the key found by a group of investigators that it is a protein that is called the zonulin, which controls the tight junction. So high level of zonulin opens wide the tight junction and allows large particle of gluten to enter inside the gut wall. Passing of the gluten through the tight junction is called the leaky gut syndrome. And if we look the zonulin upregulation in those who are the ones who don't have celiac disease in blue and the ones who have celiac disease in red, we can find that high level of zonulin. And this is again to compare that people with celiac disease, they have higher amount of zonulin in their tissue and it allows it to open wide. And the zonulin was found to be located in a very small chromosome called the chromosome 16. But the fascinating thing that on the locus of zonulin, they found that there is also tendency for autoimmune disease, cancer disease, and disease of the nervous system. And also on the same chromosome, even on the loci that not associated with the zonulin, they found there are tendency for autoimmune disease, cancer disease, and nervous system disease. That might explain why celiac disease have higher incidence of autoimmune disease, cancers, and nervous system involvement. So, in the pathogenesis, we need three elements. One, the culprit, gluten protein. Two, genetic predisposition, DQ2, DQ8. And three, the leaky gut role of zonulin. So from here, allow me to come with a nice definition for celiac disease. It is a chronic small intestinal immune-mediated enteropathy precipitated by exposure to dietary gluten in genetically predisposed individuals. We know the incidence of celiac disease about 1%, more or less. However, in certain areas like Western Sahara, Sahara al-Gharbiya, it can reach up to 6%. Why? Because they have more genetic predisposition. And on the opposite side, Japan and Korea, it can reach up to 0, not because they eat rice, but because they don't have the DQ2 or DQ8 predisposition. And they found that the incidence has been increasing since the 1950s till now. And the latest studies in 2020, they found that the numbers in the United States, New Zealand, Canada, Germany, Scandinavia is still increasing. Why? Because the symptomatic patients are the ones who are above the surface of the water. It's only about 10%. Beneath the level of water, we have the silent celiac disease and the latent disease, the asymptomatic. We only discover them either by biopsy or by screening them with the serology. So for each one diagnosed celiac disease, we have 8 people remained undiagnosed, according to a study which was done in Ireland, Italy, Netherlands, Sweden, and USA by screening relatives for patients who were diagnosed with celiac disease. So the question is, to screen or not to screen? The answer is simply the best solution: screen high-risk group. We cannot screen the whole population. And high-risk group are identified as those who are first and second degree relatives to a person with celiac disease, or patients who have autoimmune disease like type 1 diabetes, IgA deficiency, Turner syndrome, Down syndrome, IgA nephropathy, and others. So let's look here. Patients who have dermatitis herpetiformis, 100% of them are diagnosed with celiac disease. While patients with first and second degree, they can reach up to 22%, Down syndrome up to 12%, and type 1 diabetes up to 8%. So how does it look to have celiac disease? We know the name, but really we don't know the face because it has different faces. It can be typical, mainly GI symptoms, atypical, various extra-intestinal manifestation, minimal or absent GI symptomatology, silent, asymptomatic, positive biopsy, positive serology, even latent, asymptomatic, with normal biopsy, but they have genetic predisposition and can appear at any time. So if we look at the classical celiac disease, it usually happens in children where they have diarrhea, muscle wasting, edema, and always they have positive biopsy. However, this form is becoming less common than we have ever known because the atypical celiac disease is becoming the typical, the most common. Atypical GI symptoms like recurrent abdominal pain, loose stools, lactose intolerance, pancreatitis, elevated liver enzymes, non-GI, constitutional like short stature, chronic fatigue, bone, osteopenia, mouth, enamel hypoplasia, cavities, skin dermatitis herpetiformis, alopecia, chronic urticaria, genitalia, late onset puberty, infertility, neurological, ADHD, hypotonia, peripheral neuropathy, hematological, iron or folate deficiency. So these are some examples: hypertrophied cardiomyopathy due to celiac disease, osteoporosis, iron deficiency anemia, dermatitis herpetiformis, recurrent after stomatitis, enamel hypoplasia, alopecia, and posterior phosocalcification with seizure. Yes, it is due to celiac disease. And in 2020, while we were involved in the COVID, they found that people living with celiac disease have higher risk of neurological damage, according to a new study from the University of Sheffield. The study found that the brain of people living with celiac disease showed evidence of damage to the brain matter and cognitive deficit in the form of slowed reaction times. And we know that people who have slowed reaction time, they are more prone to premature and sudden death. So celiac disease is really a clinical chameleon, and the diagnosis can be missed easily. So we have to stay alert and have high incidence of suspicion to diagnose celiac disease. So what we use for diagnosis, as I mentioned, we use serological markers. In the beginning, in the 1970s, we used to use antigliadinin. They are very low sensitivity, many false undiagnosed celiac patients, so no longer used. Then they introduced the anti-gliadin antibodies, not specific enough, with too many false positive celiac diagnoses, not recommended anymore. So please don't use it. And in the 1984, again, they found anti-endomysium. It is very good test. However, it is costly and difficult histopathological technique using endangered species like chimpanzee تتعرض للانقراض or live tissue. So it's very expensive. However, this is not the only cause for using the anti-endomysium. Cannot be used in IgA deficiency. Result is positive or negative. We cannot monitor the response to treatment because there is no titer for the anti-endomysial antibodies. Now, the most common use is anti-tissue transglutaminase, very specific and sensitive, and is still a reference. And in 2004, they introduced the anti-deamidated gliadin peptide. This has excellent sensitivity, especially on pediatric population and ideal for screening in pediatric population. So the most common we are using is IgA tissue transglutaminase antibodies, and at the same time we have to measure the total IgA, the total immunoglobulin A. If it is positive and normal IgA, then we can make presumptive diagnosis. No need for other testing. The other testing, we need them when we have low IgA level. And by using the other one, we can confirm the specificity of tissue transglutaminase. We can identify celiac disease in IgA deficiency and in children below the age of 2 years. Now, how we do our diagnosis? Apart from serology, we do biopsy. The patient to have biopsy should be on gluten diet. We cannot do it when the children or anyone is on gluten-free diet. So we have to make sure that he has been on gluten diet. Do we need always biopsy for celiac disease in children? This is a very important question because many people, they don't want biopsy. In 2020, European Society of Pediatric Gastroenterology, Hepatology and Nutrition Guidelines for Diagnosis of Celiac Disease, they said, the no biopsy approach for celiac disease is safe in children and adolescents, not in adults. We need to have high serum IgA tissue transglutaminase value 10 times the upper limit of normal. Then we do another sample. If it's still having 10 times, we can do endomysial antibodies, IgA, and if it is positive, then no need to do biopsy. However, if it is below 10 times the normal, we need to do biopsy so we don't miss any case. So we don't have to decrease the false positive diagnosis. And in those who are at high risk and they need frequent screening like Down syndrome, Turner syndrome, autoimmune diseases, diabetes, start if possible with the HLA DQ2, DQ8 if available. If they are negative, no need to repeat the test on yearly basis. If it is positive, then we have to continue screening. So now we diagnose celiac disease, we have to give a prescription. We have to give treatment. And the treatment, the prescription writes gluten-free diet. And this gluten-free diet should be lifelong. And we have to understand that the daily allowance for gluten-free is maximum 50 milligram of gluten per day, 50 milligram, not 1 gram, 50 milligram. This is very important. And this is the amount of gluten that will allow our intestinal inflammation to heal. And patients on gluten-free diet, they show clinical improvement within days to weeks. However, the serology will decrease in about 6 months and the healing in about 1 year. So no need to repeat immediately the test. We have to wait a few months and biopsy is not needed unless we're still in doubt or there is a refractory celiac disease. Now look at the gluten-free diet. We have many options, but still difficult to adhere to the gluten diet. Why? Because its cost, it's very expensive, poor palatability, the taste is not good, poor nutritional counseling, nobody explains how to follow the nutritional counseling, poor follow-up, poor food labeling, social culture, and peers pressure. The children will, why you don't try? He wants to eat ice cream, he wants to do, and especially when they go into adolescence. And just to give you about the price, in certain countries, it can reach up to 3 times the normal diet. And imagine if the whole family wants to be in solidarity with the patient and all of them to eat a gluten-free diet, how expensive it will be. So that's why there is no proper compliance. So we need novel treatment. What options do we have? Back on the pathogenesis that I present, either we need an enzyme supplementation for degradation of gliadin, maybe correction of intestinal barrier against gluten entry, so we have zonulin inhibitor, tissue transglutaminase inhibitor, or blocking of gliadin presenting to HLA. So let's see the available novel therapy. They did an enzyme therapy, which is glutinase, enzyme derived from bacteria and cereals. They found that it didn't achieve the primary outcome of histological improvement. So, and when compared to placebo, no significant improvement in histological and symptom score. So they abandoned it. They started the zonulin inhibitor to prevent the tight junction from opening wide. And they produced a drug that is called larazotide, which is given by mouth, prevent the opening of tight junction. And they, in 2019, they started phase 3 trial. However, it wasn't really promising. They just use it as adjunct treatment for patients with celiac disease who still experiencing symptoms on gluten-free diet. However, in 2020 again, while we were still busy with the COVID, some researchers found that involves encapsulating gliadin molecules, gliadin nanoparticles inside a biodegradable nanoparticles, very small. They believe that the human body responds to the presence of the nanoparticle, treating it like harmless debris and sending an immune cell called a macrophage to clean it up. So we can start tolerating it, and we reprogram our immune system to tolerate gluten. This could be promising, however, still needs more investigation and more trials. Now, what about the genetically modified gluten? Gluten has the bad boy reputation, and many people, even if they don't have gluten intolerance or celiac disease, they want to have gluten-free diet. However, we have to understand that gluten-free diet is high in fat, salt, and easy digestible carbohydrate sugars, and by removing the whole grain fibers from the diet, we are predisposed to constipation and other serious problems. That's why they thought to create celiac-friendly gluten by genetic engineering. Maybe this is also on the horizon. In the future, we can see it in the supermarkets. We hope so. So this is the end of my story. But before I leave, allow me to give 2 messages. One, the message says our greatest weakness lies in giving up. The most certain way to succeed is always to try just one more time. Winners never quit, and quitters never win. So for any questions, please contact me at this email. I will be happy to respond to your questions and answer and interact. And allow me in the end to thank you and thank the organizer. Thank you so much.
Thank you very much, Dr. Tawfiq. An excellent presentation covering everything in a very nice way. And actually, you open our appetite for a lot of questions. But I think for the time of the conference, I think we have a shortage of time. So you can proceed to the next speaker. Dr. Suhail.
Open appetite for many questions, but not for open appetite, not for gluten.
Actually, Dr. Tawfiq touched a lot of points. I have a lot of questions, but I think I will contact them.
Dr. Tawfiq has been focusing on gluten and for the past several years. And I know that he is a good speaker about this subject, and that's why I chose him. Thank you, Dr. Biltaji.
Thank you, Dr. Suhail.
Next speaker is Dr. Jamal Al-Kutesh. Dr. Jamal is a friend. I worked with him 10 years. Excellent invasive radiologist in children. We share a lot of cases. He's a consultant interventional radiology, chair of clinical imaging in Abu Dhabi at Tawam Hospital في Al Ain. Before we worked together at Sheikh Khalifa Medical City. However, again, his presentation is registered. And Mr. Ahmed, let's start, please.
Good evening, everyone. It's my great pleasure to be with you, and I would like to thank the organizing committee to invite me to speak at this conference, and especially I would like to thank Dr. Suhail Shabib to think about me to deliver this exciting talk. It's really a very interesting topic. It's called TIPS in kids. What TIPS stands for, it's transjugular intrahepatic portal systemic shunt. It's one of the most complex interventional radiology procedure which we perform. Before I go further, I have some disclosures. I'm a consultant interventional radiologist working in the United Arab Emirates since 2007. I have served more than 14 years in Saha and performed more than 50,000 IR procedures. Many of those are on children. And really, I'm one of the longest served IR in Abu Dhabi Emirate. And currently also I serve as the chair of radiology at Tawam Hospital in Al Ain. And over the last 14 years, I had the pleasure to work under the flagship of Cleveland Clinic, Johns Hopkins, VAMED, and Saha. We all know interventional radiology have changed the way we practice medicine. Many big surgeries in the past have been abandoned by minimally invasive interventional radiology procedures, as we can go through a small hole in the groin or in the hand, on the neck, to the area of disease and treat it. This is a picture of our new hospital in Al Ain. Really, we are very excited for this hospital to open next year. I would like to show you this nice picture for Dr. Suhail Shabib, which was published in Al Bayan newspaper locally, where we performed together a very exciting interventional radiology procedures, which is TIPS on a very small gear, one of the youngest in the Middle East. So what's TIPS stand for? So TIPS is transjugular intrahepatic portal systemic shunt. So how do we do the procedure? So we go from the neck, we puncture the jugular vein, and we put a large sheath around 11 French, and then we catheterize the SVC, we go through the heart, and we reach the right hepatic vein. And after that, we puncture from the right hepatic vein to hit the portal vein. And once we hit the portal vein, we put a guide wire with a little tract, and then we put the TIPS. And this is what the TIPS looks like after the procedure. So it will be like a shunt between the portal vein and hepatic vein to decompress the portal venous system. What are the indications of TIPS? So the most common indication is the uncontrolled gastric or esophageal varices, and also we use it for the recurrent varices bleeding despite endoscopic therapy. And also we use it in the portal hypertensive gastropathy and also on refractory ascites, especially in patients with liver cirrhosis, and also in hepatic hydrothorax when the patient get large pleural effusion due to the liver cirrhosis. And also the same procedure we use for Budd-Chiari syndrome. So the TIPS, as I mentioned, so the patient goes under GA, and then we clean the neck area, and then we puncture the jugular vein under ultrasound guidance. And then after that, we put a sheath, and then through a guiding catheter, we pass through the SVC, right atrium, and then into the IVC, and then we catheterize the hepatic veins. And once we reach the hepatic veins, then we insert special needle to puncture from it into the portal vein. This is what the needle look like. It's called Roche-Orshida needle. It's a very special needle, very long and very dangerous because it's a long throw, and it can perforate really the adjacent organs if we're not careful about the location of the puncture. So once we puncture into the portal vein, we dilate the tract and we put the TIPS stent, which will divert the flow into the systemic circulation. As you can see here, after the dilatation, you can see all the blood has been diverted into the main circulation and all the gastric varices will disappear. And how to prepare the patient? Of course, physical and nuclear examination is very important because we need to rule out hepatic encephalopathy as the tips might make it worse. And also laboratory tests is very important, especially the coagulopathy and renal function. And also endoscopy, very important to check on the status of the gastric and esophageal varices, and also Doppler ultrasound for the liver and jugular veins, very important to check on their patencies, and also multi-slice CT scan of the liver and abdomen to have a 3D idea on the liver. And of course, if there is ascites, we have to do paracentesis. And then ICU bed after the procedure is a mandatory. Contraindication, the most common contraindication is the coagulopathy, especially high INR, low platelet. So these need to be corrected before the procedure, and also high creatinine, as the contrast injected might push the patient to renal failure, and also polycystic liver disease and multiple liver metastases or malignancies, and also rapid progressive liver failure, and also sepsis. But unfortunately, most of the procedures are life-saving, done on emergency cases, and we close our eyes on all the above factors. There are some images showing like a polycystic liver in this CT, and also liver hepatoma here, and also another liver hepatoma, and biliary dilatation, which are some of the contraindications after the procedures. As I mentioned, it's very important to get familiarized with the liver vascular anatomy, the hepatic veins. We have 3 hepatic veins, and also the portal veins, main portal vein and right and left, and also the hepatic artery and its branches. So this is the first case, which is very exciting. She's a 3.5 years old girl. Her name is Alma. She's known to have a biliary atresia and liver cirrhosis. She was transferred to us to Sheikh Khalifa Medical City on an emergency basis because of the uncontrolled upper GI bleed. Straight away, she was received by our consultant at the time, Dr. Shbib, the pediatric gastroenterologist. So she was taken straight away to endoscopy to control the bleed. And it took him around 4 hours to control the bleed. And what was reported, that the stomach and the esophagus are full of the varices, which also very distended and really, which could bleed at any minute. So something needs to be done to prevent any second bleed, which might be fatal in her condition. So biliary atresia, just to give you an idea about it, is characterized by the fibrous ablation of the extrahepatic bile ducts and cholestatic syndrome and transition of the biliary cirrhosis into the end-stage disease. It's not very common disease, but happens in 1 to 12,000 to 15,000 of children. And the surgical correction procedure for this disease is called hepatoportoenterostomy. And the most common feature of this disease is the fibrotic changes in the portal trites around the portal venous system, which make them very small and very tough to puncture. And this makes TIPS procedure very difficult in such a patient. So what we faced in this child, she had a very difficult family because they had like 100 questions with 100 phone calls from abroad, try to answer the questions, plus they change their mind every 5 minutes. They agree and then they disagree and then they come back and then the child was not doing well. And then at the end, when there was a high risk to bleed again, they decided to agree. And the other difficulty we faced, we did not have a children TIPS set, so we had to do adult set. And imagine how difficult that was to use such adult set in a younger child. And also, we did not have much experience in TIPS in children, as the first case was reported in 1992. So I entered through a jugular vein. I passed the TIPS sheath into the right hepatic vein. As you can see, it's really completely blocking the right hepatic vein. It's really so large for the patient size. And then I did a forceful indirect portovenogram. So I injected through the hepatic vein, and the contrast was forced to reverse back onto the portal vein to pacify it, which is a way to pacify the portal vein. And then, as you can imagine, I have to puncture from this point to the portal vein. And once I enter the portal vein, I dilate the tract and with the stent. And as you can see here, the first puncture ended up with a spider of bleed inside the liver. So I started to panic. But unfortunately, I didn't have the choice to reverse back. So I have to carry on forward. A second puncture, and as you can see, I managed to pacify the left hepatic vein and some of the right portal vein branches. And the difficult part was to enter a guide wire into the main portal vein. And as you can see also in this picture, the contrast extravasation has started, which is a bleed outside the liver from my puncture and also inside the liver parenchyma. So my stress level really becomes very, very high. And luckily, I managed to enter the main portal vein and then dilate the tracts. As you can see here, the contrast injection before dilating the tract, you can see extensive gastric varices. And once I open and dilate the tract and put my TIPS stent, you can see these gastric varices disappeared and all the blood has been shifted to the main portal venous system. So the procedure lasted around 2 hours, which wasn't bad for TIPS. And endoscopy was done next day. And luckily, all the gastric varices disappeared. But unfortunately, the family decided to discharge the patient 48 hours after the procedure against medical advice, which made our really life difficult. But unfortunately, we could not stop them. And then, luckily, they came back for a follow-up 18 months after the procedure, 6 and 18 months, and patient was doing very well. And I just called the patient just last week to check how is she, and I was really glad to hear from her father that she's 17 years old now and she's doing very well and she did not have any intervention after our test procedure. I went to the literature and looked at the some papers in TIPS in biliary atresia, and I did not find many. This is the largest paper. They talked about 9 cases they've done over 5 years, and success rate was like 95% to 100%, and all the patient bleeding stopped at the time. Some patients, they have to go for a second procedure, and they all reported difficulty during TIPS due to the periportal fibrosis and small portal veins. This is the second case. He's a child, he's 16 years old. Again, he was referred to me with Budd-Chiari syndrome. In Budd-Chiari, we all know the hepatic veins are blocked, thrombosed and fibrosed, and you can see he developed enlargement of the liver and also signs of acute hepatitis, also ascites. So in Budd-Chiari, what we try to do, we try to open the blocked hepatic veins and just leave TIPS to the end if we fail. And if we fail to open the hepatic veins, we don't have much option to only to do the TIPS procedure. And in his case, really, this is you can see his labs, all the range, bilirubin, ASTs, ALTs, and we were really lucky. So you can see here the first image, you can see all hepatic veins are blocked, and this is the left one, the left hepatic vein. You can see very tight stores at the origin. We managed to enter the right hepatic veins, and we put the guide wire in, and then we did an angioplasty. And again, the IVC was really stenosis because of the hypertrophy of the caudate lobe. And again, we gave it an angioplasty. And again, there's another picture after the procedure. As you can see, the right hepatic vein is patent. And this is a follow-up CT scan after 1 year, 2 years, sorry. And you can see the liver size and shape has normalized and the ascites disappeared, and really he's living normal life. And again, this is a picture for the TIPS for the Budd-Chiari stent, again, which is patent, and the patient is still doing very well with that problem. In TIPS, what we don't use a bare stent, we use partially covered, partially uncovered stent. We use the covered part inside the liver parenchyma, as the bile, it might affect the material of the stent and cause stent stenosis and occlusion. So the cover part of the stent will prevent this complication. So what are the complications of TIPS? Of course, bleeding is the most common complication, and also it can cause bowel perforation because they are very close to the liver. Of course, infection is common, and also liver failure. But the most common complication is really the hepatic encephalopathy, as the blood does not get filtered by the liver, especially the ammonia. So it goes directly from the mesenteric portal vein system into the main circulation, which is really very toxic if it's in high amount. And again, this stent can be occluded or stenosis in the future. Death, of course, could happen due to TIPS. It's been reported 1 to 22%, 30 days mortalities. And believe it or not, 75% of urgent TIPS patient bleeding ones are already like in Child-Pugh class C, which is really the last class of liver failure. And these are some pictures of the complication. You can see the kidney is very close to the liver. So if we puncture this way, we might injure the kidney vessels. And again, you can see here the colon and the stomach. And again, we might cause perforation by our needle. And again, also the gallbladder is very, very, very close. We might cause hemophilia. So hepatic encephalopathy is one of the really most common feared complication of TIPS. So after TIPS, most patients, they go on a special diet to avoid high ammonia in their circulation. And this complication, it happens in 35%, but only 5%, they will require like intervention or to close the TIPS. And if the hepatic encephalopathy cannot be controlled, patient might really die because of it. TIPS patencies have been reported to be 25 to 60% for bare stent, and it's much higher in the cover stent. And associated patency rate for TIPS reported to be high in 85% in Beator. This is the last and third case. Again, she's an 18 years old girl. She is known to have a body carrier syndrome, and it was diagnosed like 3 years earlier, and she had, to make things worse, not only hepatic vein thrombosis, she had also portal vein thrombosis and also right jugular vein thrombosis, and also she had a procedure called peritoneal right jugular shunt, which is also closed, and she had a recent pulmonary embolism, and she was denied for liver transplant because of the thrombosis of the portal vein and hepatic vein. Again, this girl, she came to us with a massive upper GI bleed. Again, she was taken by our endoscopist who managed to control the bleed. And the only solution for this girl is the TIPS, but unfortunately TIPS was really extremely difficult because she had thrombosis here, main portal vein and also hepatic vein. And the only option was in front of us to go directly from the IVC to hit one of the portal vein branches and try to stretch it, to put a stent inside it to decompress the portovenous system. And as you can see, this is my sheath inside the IVC. This IVC is dense line. And then imagine really like we are puncturing blindly by a long needle. So you go to the IVC and you have this angle needle and you puncture and you don't know what's hit inside the liver. And luckily, after 12 puncture, we managed to hit one of the portal vein branches. So we entered into that. And after that, we dilate the tract. As you can see here, the waist on the balloon. And then we put the stent and we made the tract. And as you can see here, extensive gastric varices. And once we put the TIPS stent, all these gastric varices disappeared. This case was really very exciting, and the media, they get very excited, and it gets published in the local Arabic and English newspaper at the time. Over 90% of patients that undergo TIPS to prevent bleeding from varices will have relief from their symptoms. If we do the TIPS for ascites, 60 to 80% of patients, they will get relief. And if we do the TIPS for body care and we manage to canalize the hepatic veins, usually patients.
What we will do, we will stop at this level.
This is a nice poster for 3 cases.
Ahmed, can you please stop this lecture? Thank you. My apology. It seems like the speaker did not add his slides. And this is one of the lectures. I think slides are very important. On behalf of the speaker, I apologize, and we can move to the next speaker. And the next speaker is Dr. Majdi Mansour. Dr. Majdi is a friend, and he's a consultant pediatric cardiologist. And I welcome Dr. Majdi for giving us some really good, new, up-to-date information. Of course, I'm a gastroenterologist, not aware of what's in cardiology, but it's always nice to see what's new. Dr. Majdi, welcome, and nice to see you with us. Tfadal. Dr. Majdi? Mr. Ahmed, can you connect Mr. Majdi, please? Dr. Majdi?
He needs to just to unmute himself.
Welcome, Dr. Sohail. Thank you very much. I would like to thank the organizing committee for inviting me, and I hope I will share with you in the coming 30 minutes some of interested subject between pediatric cardiology and pediatric neurology. My topic will be about the point of connect between pediatric cardiology and pediatric neurology. You can hear me?
Yes, we are fine with you, but yes. Please go ahead.
And now you can see my slides?
Yes, they are clear. Go ahead,
yes.
Thank you.
During my talk, I will touch on the following points: introduction, whether it is syncope or seizure, and approach to diagnosis, some cardiac effects of anti-epileptic drugs, and cardiac complications of neuromuscular diseases, some practical cases, and at the end, conclusion. So, as you know, the brain and the heart are quite connected, and the heart is one of the most important organs in the human body. The heart has nearly 2 billion muscle cells and 40,000 neurons. The heart neurons are few in number, but really important. They are not like the brain, 100 billion, or even the gut. Dr. Sohail is our senior GI. Even the gut has 0.1 billion neurons. And this connection carries the signal from the brain to the heart and vice versa. And there is complex interactions exist between the brain and the cardiovascular system. A dysfunction of one system may lead to changes in the function of the other. As you know, the brain has sympathetic and parasympathetic supply, but the vagus nerve supply only the atria. It does not supply the ventricles. This to protect the ventricles from the effect of the vagus inhibition to the heart. Regarding syncope, is a transient loss of consciousness, which is a dramatic symptom, usually brings the family to the hospital, and estimated to be 1 to 3% of the number of the total visits to primary care facilities in some hospital to be from syncope. In Greek, syncope means to interrupt, and mainly it is due to global cerebral hypoperfusion. And in the pathophysiology, it is either hypersensitivity of the baroreceptors in the vessels and the chemoreceptors at the level of the left ventricle after any subtle change in postural tone, circulating volume of blood, or direct release of catecholamines. This hypersensitivity results in an efferent response consisting of peripheral alpha adrenergic withdrawal and enhanced parasympathetic tone. The causes of syncope vary between benign causes and sometimes dangerous causes. Benign causes like reflex-mediated inappropriate neural control, which may lead to vasodilatation, cerebral hypoperfusion, and syncope, or orthostatic syncope in insufficient autoimmune response, and sometimes in rare cases psychiatric causes. But what is important for us and for neurology, the cardiac syncope and the neurological syncope. Just we will touch on some points related to neurology. All of you pediatrician, seizure is a manifestation of abnormal rhythm in the brain or abnormal electrical activity of the brain, which usually paroxysmally charged. And epilepsy is the recurrence of this charge. It is really clinically important to diagnose between syncope and seizure disorder. This clinical change came because some syncope are associated with myoclonic jerk. All of us, even from the media, from the past, we know that seizure is associated with myoclonic movements, but does syncope also sometimes associated with myoclonic jerks? Yes. So not every patient with loss of consciousness is due to abnormal brain activity. It may be from syncope, from cardiovascular cause, from decreased brain perfusion. So to have a very simple clarification or differential diagnosis between syncope versus seizure, in syncope usually there is no aura. In seizure, all of you know that there is sometimes, in most cases, aura. The patient knows that he will develop seizure. In syncope, usually there is post-loss of consciousness jerks. The jerks comes after loss of consciousness. In seizure, the jerks came or comes pre-loss of consciousness. In syncope, it is asynchronized jerks, but usually in seizure, it is synchronized jerks. In seizure, if tongue bite habit, usually it will be on the lateral side of the tongue, but in syncope, usually the tongue bite occur at the tip of the tongue. The patient will be flaccid in syncope, in seizure will be stiff. There is quick recovery in syncope, but there is some post-ictal stage in seizure. And there is no anion gap acidosis in syncope, but there is transient anion acidosis in seizure disorder. So which is which? The chicken and the egg scenario. A seizure can be triggered by a low cerebral perfusion during arrhythmia? Yes. And the cardiac arrhythmia can occur during a motor seizure? Yes. So our responsibility is try to find a clue. Syncope accompanied by a myoclonic jerk might occur in up to 5 or more patients with presumed seizure disorder, depending on how far the initial diagnosis procedure and re-evaluation done. If we will go to the literature, there is 3 adult studies involved altogether around 100 patients, and these studies have focused on patients with presumed seizure disorder who needed re-evaluation. About 13 up to 15 out of them were treated, but without any response to anti-epileptic drugs. That's why they are re-evaluated again for the initial cause or the root of the problem of the syncope or the loss of consciousness. In these studies, it was confirmed that vasovagal syncope may be accompanied by myoclonus and due to carotid sinus hypersensitivity or primary arrhythmia such as bradycardia caused by sinus node dysfunction or intermittent AV block, as well as ventricular tachycardia, torsades de points, which occur in long QT syndrome. I also found 2 separate pediatric studies. They involved only 22 patients, predominantly infant and toddlers, with reflex anoxic seizures, the pallid breath holding attacks. And in this, we found documented prolonged asystole. The pause was more than 4 seconds. We consider asystole dangerous if the pause is more than 3 seconds. 86% had either complete resolution or a significant reduction in the number of syncope after being exposed to pacemaker or after pacing of the heart. So from patient age wise or standpoint of view, in the very young, if you have a syncope and you would like to think of a cardiac cause, think of vasovagal syncope or variant of long QT syndrome. In the older patients, think of sinus node disease or intermittent high degree AV block. So our goal as a pediatric cardiologist or as a pediatrician is to first to identify life-threatening causes of syncope, especially the cardiac causes like long QT syndrome or heart block, and also to reach a stepwise approach, including history, physical exam, and investigations. In the history, you look for the age of the patient. As we mentioned, young age are prone to long QT syndrome, and older age to heart block, position, prodrome, triggers, associated symptoms, associated injury, duration of symptoms, previous episodes, and family history. In the history, the patient emotion details around the incident. If you have aura, it will give you a clue that this is seizure. But this should include also where the event occurred, the nature of the activity, and if the patient was standing or seated, if there was any positional state, hydration status, and last meal. We asked, as I mentioned, about prodromal symptoms, including the neural mediated syncope, such as gastric symptoms, dizziness, weaknesses, tunnel vision, and more concerning symptoms regarding cardiology, such as palpitation, chest pain, trouble breathing, which vary some from cardiac standpoint of view. Also, we ask for how long the event lasted, if there was any seizure-like behavior or post-event, like post-seizure confusion, so on. And also, prior to the incidents, if there was any evaluation or treatment for any cardiac or neurological problems, any exercise intolerance or cyanosis. In the family history, we ask about family history of cardiac or neurological problems. Sometimes we find incidentally that there is hypertrophic cardiomyopathy in the family, and the hypertrophic cardiomyopathy can lead to syncope due to arrhythmia. And if you dig down more, you may also find that the family has history of seizure or congenital deafness, which give a clue to long QT syndrome. History of sudden infant death syndrome in the family also can trigger some cardiac causes like long QT syndrome or heart block. So in summary, there is some few things that gives you a clue towards cardiac cause, like lack of prodrome occurring while supine, occurring with exertion, history of chest pain or palpitation before the event, history of cardiac disease like congenital heart disease, family history of sudden deaths, and if you find in the cardiac exam some positive finding like pathological murmur, and if you find change in ECG. Physical exam usually does not give you a clue, but you look for heart murmur, you look for a presentation that gives you a clue that this is a neurological cause of the syncope, like cafe or low spots, dysmorphic features, sometimes hearing loss, and the patient hydration status. We have list of investigation. You customize your investigation according to the case, including lab work, which should include something like blood glucose, ECG, Holter monitor, and loop recording. And I will touch on this with time. Head tilt test with video telemetry, echo, and video telemetry, and lastly, metabolic screen. Most of the time when you do routine screen, you don't find any clue. this is from our experience. A loss of consciousness from hypoglycemia will not improve except when you give the patient insulin. So with any case of loss of consciousness, you have to take blood glucose, even scan test for blood glucose, first thing to do. And when ECG abnormality present, such as prolonged QTC interval, you check for level of electrolytes, potassium, magnesium, calcium, which can exaggerate the long QT in patients who had long QT as genes, or can cause by themselves long QT syndrome. When you cannot find anything in the 12 leads ECG and the initial lab work, you step forward for another cardiac modality, which is Holter monitor, which you can adjust it for 24 hours or 48 hours. In Holter monitor, you measure the ECG of the patient over 1 day, during activity, during sleep, during everything, or 2 days, aiming to detect any abnormal rhythm. Even if you cannot find something in the Holter monitor during 2 days, there is another method when you extend this to 3 months, up to 3 months, when you put a loop recorder inside the chest of the patient will turn it on to record any abnormal or funny heart rate. And this is the loop recorder of one patient inserted on his or her chest. And we have a machine to analyze the abnormal rhythm of this loop recorder. Then you go for echocardiogram. Echocardiogram is very essential. If you have long-lasting cardiac anomalies like long QT syndrome or so, you will find dilatation of the heart. Sometimes you immediately see hypertrophic cardiomyopathy, which give you an idea that this patient has arrhythmogenic right ventricle or arrhythmia. In the past, people used to use tilt table so much, but unfortunately, the specificity and sensitivity of the tilt table alone, without recording from video telemetry, is not so high nowadays. So usually the neurology session, they don't use it alone. You have to use it tilt table, usually done by cardiologist, and the neuro recording done by the neurologist. So now it is done mainly by the neurologist. You include the video table and the video telemetry to record any activity in the patient during the changes in his position. An area of connect also between cardiology and the neurology is the use of anticonvulsant drugs. Anticonvulsant drugs work on ion channels, and it is the same mechanism where anti-arrhythmic drugs work. Even some of anti-convulsions can be used as anti-arrhythmic. So when you use anticonvulsant drugs, pay an attention to the heart, pay an attention to the rhythm of the heart. So the anti-epileptic drugs can cause dysfunction of the entire conductive system of the heart, especially with carbamazepine. And that's why when you use carbamazepine, my advice to neurologists, do not ever, they are طبعا aware about that, stop it suddenly. Withdrawal of carbamazepine found to be accompanied by changes in the heart rate variability and electrocardiographic signs of increased arrhythmogenic state. And the majority of patients with anti-epileptic drugs, polytherapy has changes in the QT interval. So better before starting anti-arrhythmic drugs, especially carbamazepine, to have a baseline ECG. And at this BCG, if you are aware about the ECG, record the QT interval, the corrected QT interval. If you are not aware, consult pediatric cardiologist. Then with time, you have a follow-up ECG, and when you stop anti-epileptic drugs, better to do an ECG. There is some incidence also in some of the studies of sudden infant deaths or sudden unexpected deaths in use of anti-epileptic drugs. And they postulated that most of the time, when you use multi-anti-epileptic drugs with very high levels, the possibility of sudden cardiac death or sudden death due to cardiac lesions or arrhythmia, cardiac arrhythmia is there. And I will touch on the cardiac manifestation of neuromuscular disorders, mainly cardiomyopathy, and some of them will have atrioventricular conduction defects, and some will have tachyarrhythmias. So most of the cases of neuromuscular disorders like Duchenne myopathy and other myopathy will have follow-up with cardiologist. This one case of dilated cardiomyopathy, and this echocardiogram of a cases of hypertrophied cardiomyopathy. And we usually give them anticongestive therapy even before the dilatation and the heart failure to help them to anticipate the problem. And the efficacy of AC inhibitors and beta blockers in such conditions had been examined thoroughly in a lot of studies, especially in USA. And if the patient developed atrioventricular block, he may need pacemaker implantation. Now we will come to some accidental finding in echocardiogram. If you have a patient with syncope and the neurologist just even thought of cardiac cause, usually we do echo. Sometimes when you do echo for a small child, you find something like this mass in the right atrium. And mass in the right atrium usually rhabdomyoma in the young age, and rhabdomyoma is one of the features of tuberous sclerosis. And when you do for this patient CT scan brain, you will find the classic periventricular calcification of tuberous sclerosis. So sometimes you find the clue from echo or a clue from ECG. This patient has left ventricular hypertrophy, which came to him from long QT syndrome. So when we did for him 12 leads ECG, it gives us an idea about the diagnosis. I will like to share with you some practical cases. I hope there will be an interaction, but I will proceed with them. This is a picture of a neonate who has this satellite lesions, and he has loss of consciousness or syncope. Most people will think this patient has a neurological disease or something. They will not think that this patient has cardiac disease, but this is the diagnosis. This patient has complete heart block. If you have a look here, there is discrepancy between the P wave and the QRS complex. Here is another P wave. Here is P wave without conduction after it. This is a complete heart block due to congenital lupus erythematosus, where the mom has antibodies that attack the conductive system of the heart. According to the amount of antibodies, either will happen incomplete heart block or complete heart block. And you can apply a pacemaker to overcome this problem, even from a very young age, like 8 weeks, 3 kilogram baby, and to infant age or toddler age, 5 years of age. This is a case of supraventricular tachycardia, which may lead to decreased brain perfusion and syncope. It is a cardiac cause of syncope. And sometimes you have accessory busways like WPW, where when you have short PR interval and delta wave slurring of the QRS complex. Or another abnormal busway, this is Lown-Ganong-Levin syndrome, which includes some metabolic and some GI problems. Or VTAC. The VTAC can lead to syncope very early because there will be a decreased blood volume going to the brain, and VTAC can happen in long QT syndrome. And even if you did an early ECG for a patient with long QT syndrome, you can check a manifestation, an indirect manifestation of left ventricular hypertrophy, which gives you an idea as this patient has chronic long-standing problem in his rhythm problem like long QT syndrome, which is inherited syndromes with many abnormalities in the channelopathy, like potassium channelopathy, sodium channelopathy, and there is two famous diseases associated with, one of them associated with hearing loss, Jerfel Lang Nelson, and the other one not associated with hearing loss. And it can happen secondary to drugs, some drugs that use in GI, like cisapride, and some antibiotics, also secondary to hypocalcemia, hypothermia, hypokalemia, cerebral injury. So in conclusion, consider the possibility of convulsive syncope whenever you doubt that this is not pure epilepsy. And EEG alone is not diagnostic, and anti-epileptic drugs is inefficient in cases which is not related to neurological disorders, which is related to cardiac arrhythmia or other problems in the cardiovascular system. And there are atypical premonitory symptoms like nausea, lightheadedness, and palpitation, which is associated more with the cardiac causes of syncope. And ion channel active anti-epileptic treatment is followed by an increase in the attack and the frequency of syncope due to cardiac causes. And there is torsades de pointes ventricular tachycardia, which is usually associated with syncope and loss of consciousness. So my take-home message is always check a standard ECG and complete cardiac exam during and after starting patient on anti-epileptic drugs. Do not assume that all cases of syncope is due to neurological disease, and try to consult pediatric cardiology if you face such a case. And thank you very much. Again, I would like to thank the organizing committee for inviting me.
Dr. Majdi Mansour, thank you very much for this interesting, nicely put overview. And I open the time for questions. Any questions for Dr. Mansour? Dr. Mansour, thank you very much once again, and nice seeing you.
You are most welcome. You are most welcome. See you, Dr. Soel. See you, my friend.
Okay, we still have two speakers in this session. Professor Biltaji will introduce Dr. Khalaf.
We have the honor to have Dr. Khalaf Gargai here today. Dr. Khalaf is a well-known figure of pediatrics in the Arab world, and he's a regular speaker in many of the international conferences all over the world. And I have a long list of achievements. I think the time is not enough to mention all. However, I will just mention some of them. He is associate professor in the Duhok University pediatric department, and also he is the president of many international conferences, including the Pedia Mediterranean, and he is also actively sharing and heading a lot of active continuous education societies, including the joint Iraqi-Italian Pediatric Association. He is the president of the joint Iraqi-Italian Pediatric Association. Also, he is the immediate president of the International Medical Academia Forum, a Swedish-Iraqi network, president of the International Pedia Mediterranean conferences, and many other, and he is a guest speaker in many conferences in the Arab world and outside. And we have the honor today to have it and giving a very important hint about the pediatric reflux method and truth in diagnosis. The floor is yours, Dr. Khalaf.
Well, thank you very much, Dr. Muhammad, for the kind presentation. And you are a dear friend and a dear brother. And I do thank the organizing committee and the scientific committee. And namely, I thank my colleague and my brother, Dr. Muhammad Salman al-Maliki, for his kind invitation. I suppose that you are always, during virtual presentation, we have those technical stuffs and problems. So I suppose that everybody is seeing my slides and hearing me very clearly. If there is any comment, kindly just use the chat box to comment if you have any problem with the presentation or with the slides. Well, so actually this is a very interesting topic, talking about pediatric reflux disease, the dilemma of diagnosis or myths of diagnosis. My disclosure is that Bismillah ar-Rahman ar-Rahim والوالدات يرضعن أولادهن حولين كاملين لمن أراد أن يتم الرضاعة. الآية 233 البقرة. And mothers breastfeed their children for 2 full years for those who want to breastfeed. Actually, the story of GI diseases belong to very long history, and Hippocrates said long time all diseases begin in the gut, really. So I'm sure colleagues are saying what we are going to hear, because this is a very known subject. Today I'm going to try to concentrate on some very practical points, which is very important to diagnose reflux and not to treat, because actually the treatment should be the job of GI or pediatric gastroenterologists who are in the field. But still, the general pediatrician, the general practitioners, the people who are working in the primary health centers, they need to know how to diagnose that. This is the first scenario. Who is Levant? He is 3 months old, presented with extreme irritability, vomiting, failure to gain weight, and he was bottle fed. He received all forms of anti-colic medications. I'm sure all of you are aware about that. They used IR and comfort formulae without any response. His body weight was 3 kg, while his birth weight was 3.5. So it means that he lost like ½ kilo from his weight. Clinically, if you see, there is very evident muscle wasting and loss of intercostal muscle masses and wrinkling of the skin. After complete history and evaluation, without sending the patient for any single investigation, the diagnosis of gastroesophageal reflux disease was settled, and he was started on hydrolyzed formula. And then after 3 days, you see, this is his picture, published after permission from his parents. I told him I'm going to publish the picture, actually. Irritability disappeared, vomiting improved, and his body weight reached 4.5 kg. The second scenario is absolutely the different story. This is Ala. You see, she is 6 months. She is thriving well. But the problem is that she is vomiting and spitting whatever she eats. And that actually bothers the family life. And they were very concerned about that. But during examination, you look, she is very nice, plumpy girl, and her body weight is 9 kg, while her birth weight was 3.9, and has been sent to barium swallow to exclude GER, which means gastroesophageal reflux. And this is one of the area when people overdiagnose that. The other point and the other thing I want to show you, this is a local real story. Someone who has ultrasound written then that he do 3, 4, and 5 D ultrasound And you see at the end, he writes slightly widened distal end of esophagus in favor of GERD, which is absolutely not scientific. And please don't be misled by those ultrasound, because we are going to see how you are going to approach those patients when you face patients with suspected reflux, how you are going to go through them. Even sometimes you don't need to do investigation, you can reach the diagnosis. Well, back to the definitions. What is regurgitation? It means the passage of the reflux content into the esophagus, the mouth. Sometimes we use spitting up, sometimes prosthetic, sometimes spelling. All are equivalent to regurgitation actually. While rumination, it means some effortless regurgitation of something which has been recently ingested into the mouth with subsequent mastication and re-swallowing. And I'm sure people who are dealing with animals, they know what we mean by rumination. But rumination syndrome is something different. It is a different clinical entity when the rumination follow after a while after ingestion. It does not occur during sleep and does not respond to the standard medications of gastroesophageal reflux. Sometimes it may involve repeated contraction of the abdominal wall, arching of the back, and that's called Sandifer syndrome. I think all the colleagues know about that. While gastroesophageal reflux, it means the passage of the gastric content into the esophagus, maybe with or without regurgitation or vomiting. So patients may have reflux, but still is not vomiting and is not regurgitating any food content. While GERD, it means when reflux is associated with troublesome symptoms, with failure to thrive, or with some complications. Patients with refractory GERD, it means patients who are not responding to 8 weeks of optimal therapy for reflux disease. Reflux hypersensitivity, those patients usually clinically they have heartburn or chest pain or big gastric pain, but their endoscopy is normal and the acid burden by PA study is normal on the study, and there is no evidence that this event the reflux is triggering the event. While patients with functional heartburn also they have those symptoms like heartburn, epigastric pain, chest pain. They have normal endoscopy, they have normal acid burden on monitoring, but there is no evidence that those symptoms are triggered by the reflux itself. And the last one is the non-erosive reflux disease. Those patients actually, they have normal endoscopy, but they have abnormal acid burden, and those symptoms which they have, epigastric pain or heartburn or others, may or may not be triggered by the reflux. And as you will see when you go through the algorithm, which was published March 2018 by joint committee between ISPAGAN and NASPAGAN, we will see how we will diagnose each one of them and how we are going to approach those patients algorithmically. Well, is it an old disease? Yes, it is a very old disease, and front pieces of General Herbal written by John Gerard years back. So it is not a new disease, an old disease, and written. It can happen in children and adults. Being pediatrician, I'm more concerned about pediatric population. And at the 18th, this was the cartoon, which was at the 18th century published by the British one, and this confusion about the reflux. Back to the regurgitation, which is very important because we should not mix between regurgitation and reflux, and we should know how to differentiate and how to approach each one of those patients. So the room 4 criteria, which is the last criteria about regurgitation, is that there will be 2 or more time per day, or for 3 or more weeks. But there should be no hematemesis, no retching, no aspiration, no apnea, no failure to thrive, or swallowing difficulties, or feeding difficulties, or any abnormal posturing, which we stated before, Sandifer syndrome. Well, how common it is? If you go through the net, The parent, like 31% of them, they are searching about that. And the top of the list, colic is disturbing the life of the family and constipation. But the second leading cause for parents to search in the net about PGI problem or problem in the digestion in children is the reflux. Medically speaking, 20% of those babies, they have that, while 30 may have constipation, 15 have colic. While their physician, they may be biased in a way or another, but still it is like 25%, one fourth of those baby, they have the regurgitation. In some references, they said that up to 2/3 of infants, they may have regurgitation, which is usually physiological, and we should only assure the parents about that. If you see when it will be, usually it will be mainly at around 4 to 6 weeks. Those who have like 70%, they have 1 time per day, or like 25%, 20% of them, they will have more than 4 times a day. And then sometime, please don't tell the parents that this is going to disappear by the age of 6 months, because they are going to come back to you and they will tell you, well, my infant's now 6 or 7, 8, and still he has or she has some regurgitation. So until the age of like some percent of them, 1 or 2 or 3% of them, they will still have some sort of regurgitation. So we should not tell them that this is usual. The usual story by pediatrician, always we tell the family, well, this is a physiological and is going to be ended by the age of 6 months. And then by the age of 6 months, they will come back and they will tell you, well, the child passed the 6 months and still he is having some sort of regurgitation. So you should give them a hint. You should tell them the real story, that some of them, maybe 1 to 2% or 3 up to 5%, they will have some regurgitation until the age of 1 year. Well, if you see the studies, also many of them starting from Hagar as a case report and then ending with the Martin, you will see still some of them until the age of 1 year. In some of the paper, like D, he found like 15% of infants, they still have some sort of regurgitation until the age of 1 year, and still it is physiological. All what we need is that to reassure the family, to tell them, well, this is just a physiological process, don't be bothered. And the most important thing is to assure them about the weight measurement of those babies. Well, what about cow milk protein allergy and GERD? Actually, 15 to up to 20% of children, they may have both conditions together, and up to 40%, 15 to 40% of children with history of GERD, they have some symptom of cow milk protein allergy, and because of that, they may respond to hypoallergenic and hydrolyzed formula, as you will see here. Well, why infants? Why it occur in infants? Why not in older children? If you see the length of the esophagus is 9 centimeters in infants, while in adults is 3 centimeters. The intra-abdominal esophagus is 1 to 2 cm, while in adults 4 to 5 cm. The ingested amount of volume, per kg, usually, as adult, we ingest like 40 to 50 ml per kg, while infants, they ingest more than that. In addition to that, to the gravity, because the adults are standing, and while the infants, they will be always lying in that. And the stomach is also, if we know that at the age of 1 day, the size of the stomach is like about 5 milliliters, we will understand that. And by the age of 30 years, it will be the size of an apricot. So those all physiological data makes the infant more prone to regurgitation and vomiting than adults. Well, this is just illustration what is happening when there is loss of the sphincter action, and then the acid of the stomach will go into the esophagus, causing esophagitis and erosions and others. This is the algorithm which was published. The last thing which was published by a joint committee of NASPGHAN and ISPGHAN. If you have an infant with those suspicion of GERD, what you are going to do? You should do detailed history, and physical examination, which is very, very important in infants. If you have alarm signs, here you are going to tailor and to do testing or to send them appropriately for. If there are no alarm sign here, if the baby is breastfed, we should ask the mother to continue breastfeeding. We should ask her to avoid overfeeding. And if the baby is bottle fed, we ask them to do giving some thickeners or do thickened or anti-reflux formula. If the baby improves, then we are going to continue. If there is no improvement after this intervention, then if the baby is breastfed, we are going to ask the mother to eliminate the cow milk from her diet. Actually, practically speaking, it's not an easy job. It's not easy to convince them, but we should try always with them. And if the baby is bottle fed, here we are going to give hydrolyzed formula for like 2 to 4 weeks. If there is improvement, then we will continue our management, and then we will discuss to reintroduction of the milk protein to the maternal diet and return the child back to the regular formula. If there is no improvement, here you should refer to the PIT-GI. If the referral is not possible, after trying those steps, after preventing overfeeding, stopping overfeeding, asking the mother to eliminate that, after giving hydrolyzed formula, here we may consider if the referral is not possible, we consider 4 to 8 weeks of acid suppression therapy. If you weaned it after that and it was successful, there is no further management or treatment. If the symptoms recur or the referral was possible, then you send it to the PGI, and they are going to do a lot of things, and including the acid study, including the endoscopy and others. And actually, the aim of doing investigation is to see the complication or to exclude the mimickers of reflux and not to diagnose reflux. While in children, you will do also detailed history and physical examination. If there are some alarm signs, you should refer them appropriately. If there are no alarm signs, you are going to start lifestyle changes, dietary modification, asking them not to eat very lately. Head elevation can be done, positioning can be done. If improved here, you should stop and continue management. If there is no improvement, here you have the right to start the acid suppression for 4 to 8 weeks. If the baby improved, then you continue, and then you do weaning after a while. If the patient did not improve or the symptoms recur after weaning, here you should refer to the PGI when there are persistent of the symptoms in spite of the patient receiving PPI or H2 blockers, or the patient was not responding at all. Then they are going to do endoscopy here at this level. Sorry. If endoscopy showed erosions, it should be treated appropriately. If there was no erosions and the symptoms persist, here it is the place to do pH metry. Then, if there was abnormal acid exposure, then this is non-erosive reflux disease. If it was normal and if there was positive correlation, this is reflux hypersensitivity. And if the pH metry was normal and there was the symptoms were not triggered by the event of the reflux, then this is functional heartburn, or it may be due to functional GI disorder, which are mentioned in details by Nasfagan and Isfagan. This is the simplest and the easiest approach for infants and children. Well, I think most of us, we know Ivan van der Blas. He's very well known, I think, in our area, and he studied the rule of extensive protein hydrolysate formula. He found that it reduces regurgitation in infants with positive and negative challenge for cow milk. Even patients who has no cow milk allergy, still they responded to protein hydrolysate, and this was and it should be actually, it should be not partially, it should be extensively hydrolyzed formula, either thickened or non-thickened. Both of them, they had the same effect for those patients. Then what we do for those patients, as we said, we do thickening of the feeds. The thickeners are actually safe. They are either ciliar based or they are commensurate against some gums and others. We should reduce the amount of the ingested. We do small feeds and more frequent feeds. We should eliminate cow milk protein from the maternal diet if she is breastfeeding. Positional therapy should not be used in infants. It can be used in children, in older children, but it should never be used in infants. By the way, the study by Ispagan and Naspagan, they included children from age of 0 to 18 years. So in position therapy should not be tried for infants, but it should be done for children. Lifestyle modification is very important. Avoidance of exposure to alcohol, tobacco, whether direct or passive smoking in the family. Remember, massage therapy has no rule in treatment of reflux disease. Complementary hydrotherapy, homeotherapy, acupuncture, herbal medication, all has not proven effect in treating those patients. Pre and probiotic also, you know, now it is the era of pre and probiotics, but they have no role in treatment of reflux disease. Weight loss is very important and should be applied in children actually, and they respond very well to that. Parental guidance is very important. Education, sitting with them, spending time with them, educating them about the disease is very, very important to convince them not to, because you know those especially young parents, young couples, they are going to shift from one physician to another if you are not going to convince them, not going to educate them, not going to tell them that the real history of reflux and gastroesophageal reflux and regurgitation and vomiting in infants especially. Actually, there are a lot of concerns about the use of PPI, and we do believe that many of us are overusing PPI, and you will see bulk of side effects of them. Actually, those are all documented side effects, and this was published not very old. It was just like 2.5 years ago. You see all these are the side effects, and it also cause disturbance of the gut microbiota. It causes dysbiosis, and which can lead to a lot of problems even as an adult later on, not only as children. If you see USA, you see Brazil, Australia, and Europe, you see people who are improperly or over prescribing them, like in Brazil up to 59%. I'm sure in our area it may be a bit more than this, the overuse of PPI and the effects. What about the age? Actually, if you go through those H2 blockers and the PPI, you will see cimetidine, 16 years and over. Famotidine should not be used in infants. Nizatidine, 12 and older. Ranitidine is the one can be used, while pantoprazole and others has no rule. Esomeprazole 1 to 16, lansoprazole 1 to 17. You will see all of these. Some of them pantoprazole, there are no pediatric indications. Rabiprazole, which is frequently used, it should be used in children who are 12 to 17, and below 12 should not be used. So you will see most of us, we are sometimes maybe we are over biased for the diagnosis of reflux, and we give them medication. And sometimes we may be misled by some of the investigation like ultrasound and others, which are not the real practice and not on any scientific base. Well, so we should be very careful. The most important thing is that history, and proper physical examination. And then you should, through the algorithmic approach, you should not rush to the diagnosis of that. And if you have any concerns, try always to consult PGI if they are not available. For infants, if they are breastfed, you should ask the mother to eliminate cow milk protein from her diet. If they are bottle fed, you give them hydrolyzed formula. You should not rush to the use of PPI for children. We can use PPI as a diagnostic and therapeutic approach. If they respond, it means that they are that. Please feel free to contact me. This is my email, and thank you very much. And I hope I was sticking to my time of presentation.
Thank you very much, Dr. Khalaf. An excellent presentation as usual, and you highlighted all the aspects of the GERD, and I think we have a lot of talk about it, but I think we cleared the time. Do you have any question, Dr. Suhail?
I do, yes, I do. Starting with the duration of treatment and the schedule of treatment, organizing the treatment. In 2018, the American Academy of Pediatric Gastroenterology, in association, you know, they meet every 4 years together, the European Pediatric Gastroenterology and the American one, and they put a plan how to manage these patients. And the plan is to start with conservative treatment, as Dr. Khalaf mentioned, where you try to eliminate abdominal pressure, you try to position the child, try to not overfeed the child, and see if this will work or not. If not, at that point, you start the PPI. PPI course should be for 2 weeks, and if there is a response monitored by less regurgitation and weight gain and less fussiness. This is very important. You can extend maximum 1 more month. So the total is 6 weeks based on second week visit in the clinic. If this failed, so not to confuse issues, one would start thinking seriously about cow's milk protein allergy. If these two fail, this is the general pediatric part, and it's a simple schedule and safe. Dr. Khalaf mentioned that the PPI are not safe, and this is what we allowed to use maximum to 6 weeks. Now, if all this failed, it's time to go for extensive workup and doing that. Now, trying PPI and hydrolyzed formula and all that stuff without initial investigation, one could miss something. I personally don't like that. X-ray, barium, is of no value in reflux. You know, reflux it's called GER, gastroesophageal reflux. This is normal phenomena. If it exceeds the normal range according to age, we add D, so it will be gastroesophageal reflux disease. And this is where we keep an eye on the disease. The regular GER is known to occur in the first 2 months in 90% of the babies. And of course, you cannot treat 90% of the babies. That is too expensive. No one can do that. After a year, this drops 50%. By 5 years, it approaches 10%. And these are the ones that will develop adult GER, D. So that's a different category. Dr. Khalaf mainly addressed infants, and the approach is correct. However, I personally like to follow the Pediatric Gastroenterology Society's recommendations. In terms of thickeners, recent studies are showing that they have no place in the management of the GERD or GER. Main thing that start investigation early and bypass all this is the failure to thrive. Mother comes to me and says, my baby is vomiting, I always have this towel and he's always vomiting, I try to burp him, he throws up and all that. One single question will either make me hit the roof or not. How it was his birth weight? 3.5. Okay, he's 2 months. What's his weight now? Oh, about 6 kilos. I'm not concerned. I treat the mother. I don't treat the child. All right. I give the mother instructions. He's thriving well. We don't have a problem. She has to tolerate some spitting here and there, but I concentrate, follow up. My nurse will follow. I don't have to see him every 2 weeks. Just a phone call. This will do it. Thank you. I want to other people to discuss issues. Thank you, Dr. Khalid.
There is a question for you, Dr. Khalid, from Dr. Nirmit. She's asking about the position and the treatment and the risk of sudden infant death. Dr. Dana, she's asking about your advice about the use of the infant, special infant beds for treatment of gastroesophageal reflux and the risk of infant death syndrome according to the new guideline and the new studies.
Thank you very much, Dr. Suhail, and thank you very much, Dr. Muhammad. And thank you for the very important question from our colleague. Actually, yeah, I always when I make presentation, I always depend on some referees, some expertise. So this was the recommendation by both Ispagan and Naspagan regarding position therapy, and one of the big concerns actually is the sudden infant death syndrome, and positional therapy should never be tried in infants. Regarding what Dr. Suhail stated, actually, he summarized a chapter in his comment. I'm sure this is very, very big subject. Regarding the use of thickeners, it is recommended by the last publication. It was March 2018, and recommend especially for those infants who has very frequent regurgitation, comparing to the regular those who are bottle fed, not breastfed. Actually, breastfed. Even for some of the breastfed, sometimes they use the thickeners during breastfeeding, and they get benefits, and they have some controlled studies. And for infants who are bottle fed, they found that the frequency reduced. The point is that regurgitation is a physiological process. We all know that it don't need any treatment. It needs reassurance, but sometimes it disturbs the family life. And because of that, if you go through the literatures, sometimes they use those thickeners. For the use of PPI, actually, I am one of those who always talk about that. It is a big concern for us, actually. The use of PPI should never be for prolonged period. Regarding sophisticated investigations, the investigation I stated before, we send them to see if there is GERD or complication, or we try to actually, I didn't go through the list of the red flags or the mimickers, which may present like reflux, but actually they have different. Usually we do investigation for that. And then the next step, when we go through the algorithm, which by Ispagan and Naspagan, this is specifically, this is not for someone who has subspecialty. This is for general pediatrician, for general practitioners who are dealing with infant and children, how they can proceed. They should stop at some level and send them, and we should never start with PPI as a first line in those in infants. But for children, we start
second line.
Yeah,
it's second line. First line,
yes,
conservative
yes, surely,
treatment.
Surely.
Including position. The position of the baby.
Lifestyle modification, reducing the weight, head elevation, asking them not to take meals late at night, avoiding environmental exposure to tobacco and others, and it should never be the first line. The first when we have a red flags and we have alarms, we should go directly and investigate them. We should not try PPI or H2 blockers for patients who have any red flag. Patients with red flags, we should go directly from the history and physical examination. We should thoroughly investigate them to reach the diagnosis. Thank you.
Yeah, I think I do agree with you, Dr. Khalaf, and this is according to the new recommendation. The only physician who is allowed to prescribe proton pump inhibitor for this very young age is also the pediatric gastroenterologist. So the general pediatrician actually are not allowed to prescribe proton pump inhibitor, and it is too much unsafe below the age of 6 months. Thank you. So I think the Dr. Siba was raising her hand. Dr. Siba Sani, if you have a question for Dr. Khalaf, you can unmute yourself and ask your question. Dr. Siba Sani.
I think Dr. Dana is also has a comment talking about some advertisement for some infants bed commercial with head elevation. Actually, this is not scientific, and actually it should not be used according to the. This is according to the evidence-based medicine.
Dr. Sohail, you have a comment?
I do.
Okay.
We saw the nice picture of the adult and the young esophagus, and your comment is that it's short and it's the fluid will pass faster in the short esophagus, which is a normal physiologic and physics. It's like a pipe. Any water in the stomach will have a level. If the baby is flat in bed, the water level will be in the stomach and extending through the esophagus. When you have the shin higher than the stomach, that column of water is back to the stomach. And that's the proper position to have a baby sleep, based on physics. You know, if you have the lower esophageal sphincter not functioning, open, you have a continuous pipe. If you drop the lower of the pipe and raise the upper side of the pipe, the fluid will go back to the lower part. So the shin should be always higher than the stomach level. That's in my 42 years experience.
Actually, I was just about to ask you that question. This is a personal expectation and experience. But
No. You can go to Susan Schoenheimer, and she is one of well-known GERD investigators.
Dr. Sohail, we exceed the time for the lecture. I know that the lecture is very, very nice and very comprehensive.
This is very interesting.
Yeah, and subject. We can also do it again, in more explained.
We shouldn't be firm about opinion, but we have to follow the most experienced.
Sure, Dr. Sohail. I think the time now is for Dr. Tariq Al-Ma'adawi. I think most of us know Dr. Tariq. Dr. Tariq Al-Ma'adawi is a consultant psychiatry in Dr. Tariq Al-Ma'adawi Center. He is a pioneer in psychiatry, and he's also interested in childhood psychiatry. And he is all time giving his nice hand to help us in dealing with some difficult situation related to the childhood psychiatric disorder. And Dr. Tariq, for me, is the father of psychiatry in Bahrain. I would like to give him the floor to give us a very important topic today, which is affecting a big sector of the children, and many of the parents and teachers and schools, they have a lot of concern about this particular childhood disorder, which is the attention deficit hyperactivity disorder. The floor is yours, Dr. Tariq, and we are sure that we'll enjoy.
Thank you, Dr. Muhammad. Actually, it's a pleasure to join this eminent meeting, and it's a pleasure to see you and talk to you again, Dr. Muhammad. You know, you're my brother. Thank you very much. Today, we're going to talk about, I believe, it's an interesting topic, which is ADHD in children. We'll start.
You can use F5, or this one, yes.
It's okay. It's clear? Okay.
Very clear.
Okay. Today we're going to talk about ADHD in children. This is the difficult child. Here, a mother brings her 8-year-old son for evaluation after being suspended from school for jumping on his seat, doing a lot of troubles. Night before, he spent almost 3 hours doing his homework, and he never succeeded to complete it. His mother wants to know what's wrong with her child. Simply, the child is a victim of ADHD, attention deficit hyperactivity disorder. What is ADHD? ADHD is a condition affecting children and adults as well. It's characterized with problems of 3 aspects: attention, impulsivity, and overactivity. The prevalence of ADHD all over the world is almost 7.5% in all children. Male to female differences or ratio 3 to 4 in males compared to females. This is the most important points in this slide. But we have 3 subtypes of this problem. Either predominantly inattentive, so the problem is only inattention. I'll talk later about it. Or predominantly hyperactive or impulsive, or combined. So these are the 3 subtypes of ADHD. Inattention, difficulty sustaining attention, makes careless mistakes at schoolwork, fails to complete tasks because he can't focus, and disinterested, which requires, in any activities, requires mental effort. And because of the inattention, is forgetful. We know that memory needs attention, concentration to register and recall, but because there is no proper attention, so he can't recall, so forgetfulness. So this is the inattention. How about the hyperactivity? Often fidgets, runs about, climbs, difficulty in obeying any orders. The child is often on the go. He is about to go and talks excessively. How about the impulsivity? Interrupting is often interrupts with anything, blurs out. So inattention, hyperactivity, and impulsivity. And it should be more than 6 months, according to the international classification or DSM classification. We have to have these 3 aspects or 3 cores in the to diagnose ADHD, not less than 6 months duration. Why? Why our children might have this ADHD? As most of our problems or conditions or disorders in medicine generally, it's a multifactorial. ADHD, you need to have genetic predisposition, neuroanatomical or neurochemical problems, environmental or CNS insults. So these are the 4 main etiological factors for ADHD. Look at the brain of the children affected with ADHD. We will see decreased blood flow in the prefrontal cortex and pathways connecting the limbic system, which is caudate, nucleus, and the striate. We'll see diminished arousal of the nervous system. PET scan shows decreased glucose metabolism throughout all the brain. So there's an evidence that we have an organic etiological factors. Decreased blood flow, decreased glucose metabolism, and diminished arousal of the nervous system. Again, we will see smaller anterior right frontal lobe. We will see significantly smaller corpus callosum and caudate nucleus. So the circuit between the limbic system and the frontal cortex is having a problem here. I'm always explaining to the parents of children of having this that we have a dysregulation between the subcortex and the cortex. As you all know, the corpus callosum, the limbic system, the subcortex. The prefrontal or the frontal lobe is the cortex. Usually, we have, in the normal case scenario, we have a coordination between the development of the subcortex, limbic system, and the cortex, the prefrontal lobe or the frontal lobe. And simply, the impulses or the urge to do something coming from the subcortex. And the prefrontal is the area to control this impulse. If we have dysregulation between these circuits, so we don't have this disinhibition from the prefrontal or from the cortex, especially the right prefrontal cortex. So the child can't control his impulses. So this is the main problem. Genetics. Patients with ADHD have more than 50%, more than 50% chance of having a child with ADHD. So it's 7% the prevalence. But if we have parents having ADHD, the prevalence of having a child with ADHD increases to 50%. 25% of children with ADHD have parents who meet the formal diagnostic criteria of ADHD. It's related definitely to dopamine gene and to dopamine receptors and other catecholamine receptors as well. We'll talk about this later. This is the catecholaminergic neurotransmission, which are related to the ADHD. Two main neurotransmitters, dopamine and norepinephrine. Dopamine in the striatal and prefrontal. Dopamine, as we all know, enhances the signal transduction. It improves attention. So it's related to focus, vigilance, a lot of things. Norepinephrine, on the other hand, it's in the prefrontal region, and it improves the disinhibition. So it enhances the executive functioning, the behavioral, cognitive, and so on. So these two neurotransmitters are the culprits in our problem, ADHD. We have other causes or other probable etiological causes. Injury to the brain, environmental factors, problem in the pregnancy, problem in the labor, so premature birth, any possible injury to the brain. And theoretically as well, we have either subclinical lead exposure, could be in pregnancy, while the mother could be affected, or the child in the early stage in his after labor, or low zinc. Again, we don't have a definite etiological factor. These are the possible etiological factors, but in these children, we have a definite organic pathology in the circuits controlling the behavior, the impulsivity. Circuits are, again, the prefrontal cortex and the limbic system. This circuit is affected in these children. Why? Could be, again, genetic, neurotransmitters, zinc, lead, injury, whatever. But we have the evidence that we have a problem in these circuits. How to assess these children? Good clinical history. We have to have a proper history. A thorough developmental history is mandatory. We have to sit with the parents and have a proper history and take good time, spending good time with the parents, and also, if we can, with the teachers, to have proper history of this child. We have what we call rating scales. The most common rating scale is the Connors rating scale. We have a home version, so we give it to the parents. We have a school version, and this Connors rating scale can be applied starting from 3 up to 17 years. It's very simple. It's not that complicated. It contains many items, and we address all the problems of this. It's proper to document these rating scales in the file of the child for follow-up. And it's not only our clinical judgment, we have to verify or to have other psychometric evaluation. We call it psychometric evaluation. So clinical evaluation and psychometric evaluation. And for myself, actually, I usually do EEG for any child presenting to my clinic with ADHD to exclude any possible etiological electrical dysfunction. So the parents always ask me, are you suspecting epilepsy? No. I want to see the homogeneity of the two hemispheres. I'm assessing the corpus callosum function, the two hemispheres, comparing the right prefrontal or the right frontal cortex with the left frontal cortex, the right temporal or limbic system with the left limbic system. I usually do this in my practice, comparing. So clinical assessment, proper history taking, doing the psychometric evaluation, and assessing the child. We have a lot of differential diagnoses. Anxiety disorder is very common in children and might present with almost similar symptoms. Depression in children. Depression in children might present with a lot of similar manifestations. Depression in children is different than depression in adulthood. Adults with depression might present with being withdrawn, being unable to do things. Depression in children might present with hyperactivity, with impulsivity, with behavioral problems. So we have to exclude anxiety, depression. And there is a very common, actually, disorder, which is a conduct disorder. We call it opposition defiant disorder, which is part of the conduct disorder, which is the disorder to be in the differential diagnosis. But opposition defiant disorder can be only at home or only at school. The child is disobedient. He doesn't obey any order. So we call it opposition defiant disorder. These are the most common diagnostic or differential diagnoses we have to exclude when we diagnose ADHD in children. Comorbidities, yes, ADHD might come with depression, conduct disorder, and anxiety. We have to be sure that the child is having only ADHD, or no, he is having another comorbid condition. And the most comorbid conditions are anxiety, depression, or conduct disorder. What's the prognosis of ADHD? Simply, to simplify things, we used to say it's either the child is going to have the ADHD till adulthood, or in the adolescent phase, the condition is going to be okay, or it will be, unfortunately, the child, instead of being hyperactive and impulsive, would be, on the other hand, disorganized, calm, not calm, but would be apathetic. So generally, I don't want you to be that overwhelmed with the slide. It's either will continue to have ADHD till adulthood, or 30% will continue the same, 30% will subside, and 30% will convert, instead of being hyperactive, to be apathetic. And definitely we're talking about untreated conditions. So the natural course is third of the cases will continue, third of the cases will subside, and third of the cases will convert to be apathetic, almost depressed patients. What are the treatment goals? Usually, I'm always saying that we are tailors. We don't have standard just for everyone, we have the same treatment. No, we have to tailor the medication according to the site. It's a child-specific, individualized treatment. And the goal of our treatment is to improve the relationship and performance at school, to decrease the disruptive behaviors, to promote safety for the child and the others, to increase the independence, and to improve the self-esteem. The treatment options, like medications, behavioral therapy, psychotherapy, and teaching techniques. We, in the school, I'm talking about applying some environmental techniques in the school and at home as well. But medications, behavioral therapy, and psychotherapy. The medications are the first line of choice for treatment of ADHD. Medications help treating the core symptoms of ADHD. Psychotherapy and behavioral therapy, very effective in management of the comorbid conditions of ADHD. So we have this triangle: pharmacotherapy, school instructions, and parents' educations, CPT. 3 core management goals, and we have to apply the 3. I can't rely on only medications. If we have medications, I have to have the family therapy, parents, and the school instructions to enhance the management. The medications, we use stimulants. The theory, again, if you recall, I mentioned that we have problem in the circuit between the cortex and subcortex. The cortex is unable to disinhibit the subcortical impulses. So we're giving stimulants to stimulate the cortex to be able to disinhibit the subcortical impulses. So stimulants like methylphenidate and derivatives, amphetamine and derivatives, many medications available on the market, and we have a lot of, we have in Bahrain medications available, alhamdulillah, and other medications, non-stimulants like antidepressants, antipsychotic, and atomoxetine, which is an antidepressant that enhances the norepinephrine and dopamine as well. We might use it instead of stimulants because of the possible side effects of the stimulants. And as I mentioned, the mechanism of action we can say that we know it exactly. It's not specific, but as I mentioned, it improves the level of dopamine and the norepinephrine so as to stimulate the cortical pathways to the subcortex. As you see, it improves the dopamine level in prefrontal cortex, striatum, nucleus accumbens. But the problem with the stimulants, that abuse potential, it might lead to having tics in children, insomnia, anorexia. These are the most common side effects of the stimulants, and we have to take care while administering the medications, doses, and everything. Other agents, as I mentioned, tricyclic antidepressant, bispermine or ibuprofen, but we have to take care of the cardiotoxicity. Bupropion, it is an antidepressant which enhances the effect of dopamine. But we have to take care that bupropion might have some potential in increasing the seizures probability. Non-pharmacological measurement, which is very important as well, the parent behavior management training and social skills training. I'm trying to accelerate to give a few minutes for the questions. CBT, cognitive behavioral therapy, it's very helpful, especially in adolescents and adults having the ADHD. Daily activities, scheduling, training, teachers in schools, very important to have an access to the schools because, as I mentioned, triangle, pharmacotherapy, school, and parents. Thank you very much. I hope that I didn't exceed the time and ready for questions.
Thank you very much, Dr. Tara. Dr. Tara, you are exactly on time. Thank you very much for the excellent presentation about the ADHD, which is very common in the pediatric age. We see a lot of cases. If you don't mind, I have a question for you. You know that we have a lot of cases of autism, and many of the patients with autism, they come also with some feature of attention deficit hyperactivity disorder. According to the studies, that ADHD is a very important comorbidity for autism. What about your experience about this point? Second point, that we have also in children, adenoidal hypertrophy is also very, very, very common. And some cases may be misdiagnosed as ADHD. For some cases who are presenting with severe adenoidal hypertrophy, they may have obstructive sleep apnea, which make brain hypoxia, which irritate the brain and make the child little bit have some hyperactivity and misdiagnosed as the ADHD. Do you have in your clinical practice, do you meet some cases of that?
Thank you, ma'am. Actually, with the proper history, we go through these possible conditions that might mimic the symptoms. So proper history, proper examination, proper investigation to rule out any other possible condition that might lead to having the symptoms. Hypoxia, definitely. Glucose deficiency, definitely might lead to behavioral disorders that might have the similar symptoms of ADHD. Regarding autistic children, yes, I'm seeing a lot of autistic children that having some AD or ADHD symptoms. We have autism is a spectrum. We don't have one condition. So we might have autism with ADHD or with ADD, and we are treating these children exactly. You know, autism, we don't have medication for autism, but we have behavioral modalities. And a lot of autistic children are coming to see me, and they have exactly, as you mentioned, AD problems, and I'm treating this with medications and with the other two modalities, behavioral and school instructions as well.
Okay, Dr. Tariq, another question, if you don't mind.
Sure.
Do we have an Arabic questionnaire for the Arabic patient about, you know, that we can diagnose either autism or ADHD using some questionnaire, either for autism or ADHD? Do we have a well-known questionnaire available in Arabic language?
Yeah, Connor's questionnaire is having an Arabic translation, verified, and it's available in everywhere.
Okay, thank you very much.
You're welcome.
Thank you very much, Dr. Tariq, for your time. I know how much you are busy, and you give a lot of time, not only now, but all over the year, with continuous support for the continuous medical education for the pediatrician. I think Dr. Sohail also have to say something. Dr. Sohail, you mute yourself, please. Unmute yourself. Dr. Sohail? Okay, I think he cannot hear us.
Maybe he's not hearing you.
No, okay.
Yeah, Dr. Tariq, thank you very much for this really superb lecture.
It's my pleasure, Dr. Sayed.
I actually just in energy to get my autistic and hyperactive children who are presented with GI symptoms to get family therapy, collect all these patients together and let the mothers learn from each other what they are doing to alleviate some of their problems. And I was thinking of getting yourself one day, as long as we work in the same direction, and perhaps we can get the president of the Autism Society or a group and sit and discuss issues related to autism. Maybe we can start some group therapy in the hospital. I'm looking for that. I'm interested in autism and the GI component of autism. That's why I'm interested in it. Thank you very much. I really appreciate your presentation. Thank you. Dr.
Thank you very much. Thank you very much. This is a very good idea, actually. And
thank you, everybody. Tomorrow we will have our. تفضل Dr. Tariq.
I'm saying that it's a very interesting idea to have a group therapy or family for families, and it will be very interesting to me to share it. Thank you very much.
You're in?
Sure.
Tomorrow we will have the second starting at 12. And I will. Hello? I'm here.
Sound is interrupted, Dr. Sohail.
Yeah.
I'm sorry. I don't know why, but okay. I appreciate Dr. Tariq joining us in this group session, a group therapy, and I think it will be something novel for the autism patients in the country. And this is what we look at the hospital here, the Royal Hospital for Women and Children.
Totally agree with you.
One thing, thank you. You agreed with us.
Thank you very much.
I'm putting this session to end, and tomorrow we will start at 12. Tomorrow we have another variety of lectures consisting of immunology, gastroenterology, again, cardiology, pediatric surgery. Dr. Sadiq Hussain will talk about coping with COVID-19. I heard one of these lectures before from you about COVID-19. That was perfect. And we have pediatric nephrology also. So it's a nice variety, and we will see you tomorrow. Thank you very much, and good.
Thank you, Dr. Suhail. Thank you, Dr. Muhammad.
Thank you. شكرا دكتور محمد، شكرا جزيلا.
Thanks for all the audience, all the speaker. It was very successful day today, and looking to see you all tomorrow also.
Thank you. Good night.
شكرا.
Thank you, Dr. Talib. Thank you.
Thank you very much, Dr. Muhammad.
مع السلامة. مع السلامة.
مع السلامة.